Recording in progress.
So hello friends, NEET PG exam is over and I hope you did well. Exam was moderate paper, not very difficult, not very easy, but there were a lot of expected topics as we have got to know whatever students could help us with. And image-based question was moderately, occupying the space of the examination. And here am I on behalf of each and every member of doctoral's team. We really at the outset only wish you good luck for a wonderful score. The cutoff is supposed to go a little higher because when the exam is moderate, that is expected, but it gives reassurance to a lot of students that okay, we have done really well because whatever we studied we could see in the exam also. So here am I to start with this grand recall session, which will be having one by one every faculty from DT team would be coming to discuss what are the question asked over there. And at the outset, I have a disclaimer that there will be certain errors of recall. We want to go as close to the the exact question, but there will be certain choices which will be here and there, or maybe statement maybe not you agreeing. I would request everyone to join me in the chat box with me and please share this link also. There'll be a lot of learning process. Anybody who is actually preparing for the NEET PG 202C also will be useful for it. So let us see what question have been asked out of ENT. And I'm really glad to share that around 10 to 11 questions we could recall out of ENT from students and only, and all of them were doable question. The most important thing is this will add on to our rank. If you say 10 to 11 questions means that it can really phenomenally improve our rank in a very good way. So first question, let me show you. This was the question. They say that a female who is 52-year-old and she is presenting with unilateral hearing loss, tinnitus, and imbalance. Even this much history, any middle-aged, old-age person with single-sided hearing loss, with tinnitus and with some balance or vertigo issues, I think there is some problem with the CP angle over there because eighth of compression will be there, and the patient is having the MRI also mentioned over there. There is a lesion in the CP angle area, and we know very commonly discussed topic. The most common CP angle tumor is vestibular schwannoma, also called acoustic neuroma, and this tumor arises from the inferior vestibular division of the eighth nerve. The answer to this question is C. So once again, C, CP angle tumor over there, and the vestibular schwannoma is the answer over there. Now, the second question, which they again asked, again a very common topic, epistaxis management. And if you see the patient has have some trauma history during football match, and there was a bleeding over there, and they tried to do the management of the epistaxis with the packings and all that, but still there is bleeding going on actually, and we know which artery is called artery of epistaxis. The answer is sphenopalatine artery. The answer is sphenopalatine artery over there. And if whenever anterior posterior nasal packings fail, and the next management is T-SPAL, transnasal endoscopic sphenopalatine artery ligation, the answer to this question is B. And I think again it is a very very easy to score question, clinical story based question. This time there were not too many one-liners. There were 3, 4, 5-liners questions, and they are checking the logical understanding of the subject. So I think both these questions were doable. Like vestibular schwannoma also, acoustic neuroma also. Now this one, sphenopalatine artery ligation also. Now everyone, let us see the question number 3. Now, 28-year-old male with history of chronic ear discharge and hearing loss undergoes otoscopic evaluation. The image shows complete absence of tympanic membrane. Now, There is ear discharge, which is chronic, and it's not mentioned foul smelling or not foul smelling. Whenever it's not mentioned, of course, it is not foul smelling. And there's a hearing loss also. When tympanic membrane has got a perforation or is a subtotal or total perforation, and the middle ear structure also visible over there. So almost it's a, you can say, the subtotal perforation over there. And what is the most common surgery to be done in this case, guys? Whenever you get this kind of question, now of course it is not episiotomy or it is not modified radical mastectomy. Why? Because uh, the episiotomy or MRM surgery are reserved for unsafe CSOM or eticoenteral CSOM. uh, but in that case, we will be having the foul smelling ear discharge. In this case, patient is having chronic ear discharge, not mentioned foul smelling. So we have to understand when the history is negative, it is not foul smelling. So it is a case of tubotympanic CSOM or the safe CSOM. But he's saying that perforation is almost total, and there are visible middle ear structures also. As you know, in safe CSM also, whenever there are long-standing cases when the management is not really done, there can be ossicular erosion also. And he's already saying that middle ear structure are visible. So it is indicating that, like you should expect some ossicular erosion over there. And the most common ossicle to be eroded is the incus over there. The lenticular process incus get eroded. So we are ruling out choices A and B because A and B are for unsafe CSOM. Remaining are C and D, maringoplasty or tympanoplasty. And better answer will be tympanoplasty. As discussed in the DT videos also, you must have seen over there that the tympanoplasty is actually, maringoplasty plus some ossicular job also. Like, for example, Wilson classification as in INICT also of tympanoplasty type 1, 2, 3, 4, 5. So this is also, even if you are doing only maringoplasty, but you have to inspect the status of ossicles, and that is also called type 1 tympanoplasty. So tympanoplasty is a better answer than maringoplasty. I will request everyone to comment in the chat box. Did you really write the answer? Now people are asking why not the answer of the first question. This one is the meningioma. Let me take up your discussion also. Please feel free to write in the chat box. Why not meningioma? Please open up your notes. Please see over there. Most common CP angle tumor is not meningioma. Most common CP angle tumor is vestibular schwannoma or carcinoma. I would be very happy if you open up your notes and see the chapter of schwannoma very clearly written. It's not a ear tumor, it's a brain tumor. It is most common variety of cerebello-pontine angle brain tumor. So, that is the answer. Now, in this question, the answer, of course, this is very clear-cut question of artery of epistaxis, sphenoid artery ligation over there. Answer. Okay. Everybody, if tympanoplasty was there, then tympanoplasty is the better answer in this case. Of course, if tympanoplasty is not there, then maringoplasty, as I told already, everyone, that the patient would be requiring tympanoplasty, but if not there, then maringoplasty. There is disclaimer again, there will be some little bit titration of the choices over there. Everyone, please understand, everybody please inform your friends also to let's really discuss the questions one by one over here of all subjects, 90 subject one by one. Now, this question again, very favorite topic of there is audiometry, audiogram, that sort again. Look at this patient. A patient has got, age of 27-year, male patient, reduced hearing in the left ear for 2 months. He denies tinnitus or vertigo. When somebody is directly saying that there is no tinnitus, no vertigo, somewhere you are ruling out the cochlear or inner ear involvement in this case. Anyway, they've given the audiogram also. Now, as I told you multiple time in the HIT session of the DT and the main videos, the QRP also, we have to definitely revise audiogram before the examination because one question certainly come over there. Now, this patient is having clear cut. See over there, there is A B gap on the left side. Patient anyway has got history of left side ear discharge, so the bone conduction is normal, and the cross indicate what? The left side air conduction. There's a very definite AB gap more than 15 decibel over there. The answer to this question will be left ear conductive hearing loss. Everybody, please comment. Did you answer this question correctly? Please answer this question. Did you answer this question correctly? Left ear conductive hearing loss. Left ear conductive hearing loss. The AB gap is there, so I think that is very clearly indicating left ear conductive hearing loss. Okay, now again, Adolescent male with epistaxis, nasal obstruction, CT scan shows bowing of the posterior wall of the sinus. I think this is again a gift to you because they know certain topics are asked by everyone. What is the answer, everybody? What is the answer of this question? Tell me. I think adolescent male epistaxis, any young boy with nasal mass, nasal bleeding is which question? Is angiofibroma question. Angiofibroma question, guys. Please have a genuine hope of scoring wonderful score because look at the topics asked till now. Young boy, nasal mass, epistaxis. On top of that is giving you Hallman-Miller sign also. CT scan shows the posterior wall of the maxilla is being bowed anteriorly. What is the name of this? What is the diagnosis in this case? Of course, the answer is the angiofibroma in this case. Angiofibroma in this case is the answer. Okay. Now, there are, I think, 4 image-based question or image linked questions in the ENT segment. The mark structure over there. I think they are the mark 2 arrow, put the white arrow over there. We have discussed multiple time in our sessions also. Any arrow on the side of larynx is pyriform sinus. I know they did not give endoscopy picture. As I told you, the paper is always having certain question based on the class understanding, but asked in a little different way. This is the exact example of that. So they are giving one arrow on the side of the larynx. They're not putting the arrow on the some cartilage or some on the valvular area or something like that. They're putting the arrow on the side of the larynx, and this is pyriform sinus region. And I think it's very clearly visible. Of course, the thyroid cartilage would not come so low. It's C3 to C6 vertebra is the total extent of the adult larynx over there. Epiglottis can't be seen on this thing. So the white arrow indicate pyriform sinus. And I think the indirect thing is, anytime fishbone impaction is there, and if fishbone is radio opaque, you can see some foreign body over there, some denture maybe getting stuck over there. So it is basically pyriform sinus. Pyriform sinus has been discussed multiple times. I would say again, see your notes, that there are 3 parts of laryngopharynx, hypopharynx, and discuss again. Pyriform sinus is coming every time. Fishbone infection question in the NICT now, again this question. So it means that there is a very sequence like of expected question which is being asked by the the faculties over there who decide the question also. So now this is pyriform sinus region, and we know that the upper white arrow was the vallicle, the lower arrow white arrow was pyriform sinus, and then it continued down as esophagus over there. Okay. Now, trauma is always asked. Look at where they are going. Actually, they are not really going into too much, like different kind of topics. Or this time they have stuck to the commonly asked topic of epistaxis management. Then the one question of audiogram, one question of the like CSOM question. And now they are asking trauma patient. They gave a history of somebody having injury to the nose, and they gave a picture of nasal bone fracture. And I think we know which is the forceps used to reduce this fracture. Walsham forceps. I think we know it very clearly. Walsham forceps is for the close reduction of the nasal bone fracture, and the Ash forceps is for the reduction of the septum fracture. Please tell me very, very clearly, did you score up to these questions correctly or not? Okay, fine. Okay, fine. Now, so answer this question is, of course, Walsham forceps. Tilly forceps is for nasal packing. Actually, Luck forceps is for the polyp removal and for the septal surgeries and all that. Okay, thyroid cartilage is not here. Thyroid cartilage will be higher. The thyroid cartilage is not. Thyroid cartilage would not be visible like this. It's on the arrow on the side of the larynx. So pyriform sinus is a more likely answer over there. Okay, now again, tuning fork has been asked again. Always audiology dominates the scene, and that's why we spend too much time on audiology. Somebody asked me that why in DT we have got audiology or audiogram, approximately 1.5 hour, 2 hour session on that, because audiology is asked actually for sure. Again, Rene negative on left side, positive on the right side, and Weber later is the left. Okay, please correct me if the any error in this actually recall. Rene negative on the left side, positive on the right side, and Weber later is the left. I think we know if Rene is negative, conductive hearing loss. And if it's conductive hearing loss, the Weber must be lateralized to the poor ear. In this case, left is the poor ear. Please look at this question again. Rene negative on left side, mean left conductive hearing loss. And if it's a left conductive hearing loss, Weber must be lateralized to the poor ear, which is the left ear. And the statement says Weber lateralized to the left side. The answer is left conductive hearing loss. Okay, left conductive hearing loss. Okay, fine. Audiogram question was this one. Audiogram question was this one. There were two questions recalled as of now. One question was with the history of the patient, and there was AB gap given over there, and they asked what is the type of hearing loss. It's a conductive hearing loss. Fine. Okay. Now, yes, I know tuning for question always like having a recall issue. We understand that, but as of now, this is the like recall people give. This is a very initial recall. We understand that, and every faculty of DT would be joining now after me. Like sequentially would be having 90 student recall. Please inform your teammates also to be here with us. So you get in. So we understand student want to know what went right or wrong on during the day and what is the exact key over there. So we are closely matching what actually would have happened in the real exam. Now, this laryngectomy image, actually, I think this is asked very, 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 very commonly. Like again, there is a neck hole and the question probably asked was which surgery has been done in this patient, and the choices were again total laryngectomy, partial laryngectomy, or pharyngectomy and all that. I think this is a very clear-cut case discussed ample number of times in our videos also that it is a post total laryngectomy neck image showing the permanent tracheostomy over there. Permanent tracheostomy means when the edges of trachea are sutured to the skin of the neck to make a permanent tracheostomy, and they have shown very clear cut image, and they probably asked, please correct me or please help me out with the choices if you have in your mind. And I think they asked this question that what is the surgery done in this patient, and the answer was total laryngectomy. Tell me if it's correct. Total laryngectomy. Total laryngectomy was asked over there. Okay, everyone, would you confirm that? Total laryngectomy. Okay, could you recall this question? Okay, yes. One question was about the 2-year-old child. Again, I'm not sure about the statement of this question. Peanut, again, in this case, the airway management in the foreign bodies is the common question. Again, we don't know exactly what question was there, but there was a choking history after a peanut. Whenever choking is there, then the answer would be, the laryngeal foreign body. And in a child of this age, we avoid the Heimlich maneuver. Of this age, we go for the back slaps over there. So back slap over there. Now, this was the answer of this question will be total laryngectomy, post total laryngectomy, post total laryngectomy neck patient. The answer to this question is post total laryngectomy. So if patient is having the peanut ingestion and like choking after any food ingestion is laryngeal foreign body question. Okay, fine. So yes, total laryngectomy is the answer. Everybody, please try to recall. Once again, I want to show you the question asked. If you any question want to add on the vestibular schwannoma topic, then the epiphysis sphenoid artery ligation, then the management of perforation, tympanoplasty better than laryngoplasty, conductive hearing loss due to AB gap with the history given over there, then very clear question of angiofibroma, and then the X-ray in piriform sinus question, and then the nasal fracture forceps was asked over there, the Walsham forceps. And then we have got the tuning fork question, left conductive hearing loss, and total laryngectomy patient, and then the airway. I think one more question was asked over there, and anybody who can help me, I would be very happy. So I think this is these are the question asked as of now out of the ENT part, and I'll be happy to receive any inputs on this. And again, there will be a proper recall. This is just the initial recall over there, and stay tuned with us to have the information about what various other subject questions were asked over there. But yes, paper was moderate, not tough paper this time, and we are expecting higher cutoff. And any doubts you have, please write in the chat box. Otherwise, it's done from my side. Thank you very much for the team. we'll have you know more detailed recall. Yes, total laryngectomy. Yes, definitely this question is total laryngectomy. This was again a very common. Your child turning unconscious, but laryngeal foreign body, you have to give back thrust immediately. In this question, child choking, yes, back thrust. Anything you want to comment in the chat box, you can. We'll start the next subject from my end. We are done. So 10 to 11 question out of ENT. Please stay tuned with us for the next subject. In the meantime, if you have any doubts, please, like somebody's asking some more question, we'll come out with that. Oh, orange color tonsils. Yes, somebody's saying, can you confirm orange color tonsils? Did they come? Orange color tonsils, danger disease. Orange color tonsils, very, repeated discussed topic. Yes, wow. Gautam Kumar, anybody can comment on this? Okay. So guys, there's another question. So approximately 12 question out of ENT. Then, like orange color tonsil, again, a repeat question of, like danger disease. We discussed in the class also that the lipid metabolism disorder, when the orangish deposition on the tonsillar area, and again, a straightforward question from the videos only, that orange color tonsil danger disease. My dear friends, I'm really happy. Thank you for recalling this danger disease. I guess, let's please understand, out of out of around 11 to 12 question, like I'm sure you would have scored pretty, like angiofibroma, definitely, uh, and of course vestibular schwannoma straight away. Yes, yes, like this one also, sphenoid artery ligation also, management of CSM also, the audiogram question, tuning fork question, angiofibroma question. I think we have done well. I think you must have scored a lot of question correct out of all this actually. Yes. The case history also given. Then danger disease, perfectly all right. Okay. The answer of this question cannot be percutaneous tracheostomy. Percutaneous tracheostomy will be always have a tube over there. We discussed in the class also how to differentiate permanent tracheostomy from temporary tracheostomy. Whenever tube is not in situ, you have to think about permanent tracheostomy. Tube not being over there, think of permanent tracheostomy. Okay, I think that is percutaneous tracheostomy would be actually having tracheostomy tube in situ over there. It's just another way of doing tracheostomy. Okay. We can start the next subject.
Okay, now I hope that I am audible. Okay, now I hope that okay, so at last the NEET PG is over, and from biochemistry there were around 26, 27 questions were there. They were from the notes, but there were some questions which are little tricky. They are multi-step questions were there. There were some overlapping questions with other subjects are there. I know that you must be very tired, so will not take much of your time. The detailed discussion will be there on the app, but I will just tell you that how was overall the paper was. So starting with the first question, and you try to give me the input from your knowledge which we have discussed in the classes and in the lectures. A 7-month-old infant presents with the developmental delay, seizure, and cherry red spot. The moment we see cherry red spot, one of the things that was coming in our mind was Tay-Sachs Sandoff disease. And they have already written that the genetic testing reveals that there is deficiency of hexosaminidase. The moment there is deficiency of hexosaminidase, it is going towards Tay-Sachs or Sandoff. And when it comes to Tay-Sachs or Sandoff, it is due to the metabolism defect of which molecule? It is the defect of GM2, the GM2 gangliosides, right? It's very good. Let's move to the next question. A 10-year-old boy presents with the coarse facial feature, organomegaly, and corneal opacity. For us, the buzzword was corneal opacity. The moment we'll see the corneal clouding, we should think of Hurler disease. We have discussed Hurler Hunter disease. So here we have to, because the corneal clouding is there, so it's a Hurler disease. And in fact, they have written the name of the enzyme also. That deficiency of iduronidase was there, that is associated with Hurler disease. Now, what happens in Hurler disease is basically the molecule dermatan sulfate, heparan sulfate. These molecules are actually metabolized by the enzyme iduronidase. Iduronidase enzyme is going to help in the metabolism of these molecules. But in Hurler disease, there is deficiency of these enzymes, so the metabolism of these molecules will not happen. The moment metabolism will not happen, these molecules will start accumulating and they will start increasing. So the question was, which of the following molecules will accumulate? See, it was again, I told you that's a multi-step question. First, you have to make the diagnosis. Looking at the word corneal opacity, we went to Hurler. In fact, the name of the enzyme was also there. And then they are saying that ki Hurler ke molecule in the Hurler disease, which molecules are going to accumulate? It is dermatan sulfate and heparan sulfate that is going to accumulate. Right. Very good. The next question was a repeat of multiple times. A 10-year-old patient presents with multiple freckles and photosensitivity. The word that they have used in the question was most likely that sun exposure. Maybe they have written that sun exposure was leading to the problem. And whenever the patient is going in the sunlight, they was having the freckles on the skin, on the face area, the sun exposed area. Plus there was a history of 2 lesions of basal cell carcinoma on the face, right? You have rightly most likely have given the answer. That was xeroderma pigmentosa, dry and pigmented skin. And can you tell me that xeroderma pigmentosa? Because the hint was key when he is going in the sunlight, there is problem is happening on the skin. There is photosensitivity. The skin is becoming dry. That was written in the word of freckles, and the it is a pre-malignant condition. So there was the history of basal cell carcinoma was there. It is due to defect of what? It is due to defect of nucleotide excision repair defect. If you see the recently conducted FMG exam, the similar question was asked, but that was on the HNPCC, the mismatch repair defect. That was the question on mismatch that was in the FMG exam. Yes. A 10-month-old boy presents with the recurrent oral ulcers, respiratory infections. So 10-month-old boy was presented with pneumonia. He was having reduced level of B cells, T cells, and natural killer cells, along with the reduced activity of adenosine deaminase. The moment you see reduced activity of the enzyme adenosine deaminase deficiency leads to SCID, severe combined immunodeficiency. And that is why this child was having recurrent pneumonias, because he was having the immunodeficiency. And why it is called as combined? Because in this, the B cells, the T cells, the natural killer cells, all the cells are affected. So it's called as combined immunodeficiency. And for us, the diagnosis was actually here, the adenosine deaminase deficiency. So it is going towards the SCID, severe combined immunodeficiency. It's a very simple, straightforward question. It was not difficult. Which of the molecular diagnostic test is used for the syndromic conditions like meningitis. In meningitis, because we have the different etiologies, and if we want to figure out that what is the exact etiology that is going on, then we will go for the multiplex PCR, multiplex polymerase chain reaction. Now here is a question which was more of logical question. What they are saying is that we are having a mRNA sequence where 100 nucleotides were there in that gene. Now, in that 100 nucleotide, the fourth number nucleotide, they had some frame shift mutation. There are two types of frame shift mutation we have, either deletion or insertion. But the point is, the moment we have the frame shift mutation, either deletion or insertion, down the line, everything is going to change. If you remove this nucleotide, if you delete this, then down the line, all the nucleotide will come one step forward, and that is going to change the entire sequence. That is going to change the entire sequence if we remove the fourth one. Now the point is, if they would have mentioned the insertion or deletion, they would have written any of them, the entire thing will change. And the moment this entire thing will change, most likely we will have a complete loss of protein, or it's going to be a non-functional protein. So the options were, there is no biological change. No, there is going to be a change. It's not going to be just a partial change. It's going to be a complete loss of protein, or maybe we can have a non-functional protein. It's going to be complete loss of protein, or we will have the non-functional protein. Non-functional protein. A 70-year-old male presents with fracture with a tribal trauma. He is also having parafollicular bleed. Uh, there is the parafollicular bleed, petechial hemorrhages was there, dry skin is there. He was having some exclusive diet on toast and buns. Basically, he was not eating the citrus foods. And that is why he was having these parafollicular bleed. The moment we see parafollicular bleed, petechial hemorrhages, gum bleeding was also mentioned, I think, in that question. Gum bleeding was also mentioned. And the moment you see gum bleeding, parafollicular bleed, what is coming in your mind was scurvy. And they have also mentioned that he was having some exclusive diet. He is not eating the fruits. So definitely he is having vitamin C deficiency. Now, what they have asked not is the which vitamin deficiency or what is the diagnosis. What they have asked is which enzyme is most likely be affected. See, vitamin C is required for which enzyme during collagen synthesis is the hydroxylation. So this patient will have the problem with the enzyme propyl hydroxylase or the lysyl hydroxylase, because the hydroxylation during the collagen synthesis, we have the hydroxylation process, and that requires the vitamin C, right? A labor was stuck in a tunnel for 5 days. Which of the following will be the primary source of glucose for the brain during this period? See, what happens is the the brain the cells in the brain, means the neurons, they love to eat glucose. If the glucose is available, they love to eat the glucose. At the first priority, they always love to eat glucose. But if the person is not eating the food for 5 days, continuously 5 days, then the supply of the glucose is going to decrease. And then the brain has to shift on the ketone bodies. The after 5 days, mostly the brain will be using the ketone body. To some extent, may use glucose also, if a little bit of glucose that will be provided to brain, but mostly it is going to use the ketone body. So what is the primary source of energy for not the glucose, but there's a primary source of energy for the brain during this period? It is going to be the ketosis. The primary source of energy is going to be the ketosis. Right. There was an image that was showing phrenoderma, means follicular hyperkeratosis. There was a child, he was having follicular hyperkeratosis. They must have been given you the image of elbow. Somewhere here, the small nodule-like structures were there. That is follicular hyperkeratosis. In fact, they have mentioned the word also there. They have given the image of this. Along with that, they have mentioned the word keratosis. And this happens due to what? This is due to deficiency of vitamin A. This is vitamin A deficiency that leads to follicular hyperkeratosis. Now they are saying that which of the other investigation should be done. We know that vitamin A deficiency will also lead to night blindness. So if a person is having follicular hyperkeratosis, we should rule out the night blindness also in that patient. So what is the other test to be done in this patient is the ocular examination. We should go for ocular examination. right? The next is, even if the brain word is not given, then also we would go for ketosis, because after 5 days, the main source of energy is going to be from ketosis only. The next was, there were two lipid disorder questions were there. Even if you see the last NEET PG exam, which happened in two shifts, in both the shifts, there were two questions from the lipid disorder. And this time also in the NEET PG exam, there were two questions from the lipid disorder. It's a very, very frequently asked topic. Now, there is an 8-year-old boy presents with subcutaneous xanthomas on his right elbow. His father has died from myocardial infarction, means there is a history of coronary artery disease, atherosclerosis. The total cholesterol is more. The cholesterol is more. The triglyceride was in the normal range. The LDL is more. Now, if this was the combination, total cholesterol is more, LDL is more, but the triglyceride is normal, then it is the familial hypercholesterolemia, that is the lipid disorder type 2A, if this is the combination. But if there is a slight twist that if the cholesterol is more, LDL is more, that is obviously was there. But along with that, if they have mentioned that the triglyceride is also more, if they would have mentioned like that, then the answer would have been type 2B. So type 2A and type 2B, it will be defined on the triglyceride levels, because type 2A may there is only increase in the LDL, whereas in the type 2B there is increase in the LDL as well as VLDL. So if they have mentioned the value, the triglyceride is more, the triglyceride is more, then the answer would have been the type 2B. And if the triglyceride was normal, then the answer would have been type 2A. Okay. What is the mechanism of the pegloticase? Pegloticase is, it's a overlap question with pharmacology actually. They're asking what is the mechanism of pegloticase is. What the pegloticase is doing is basically it converts the uric acid into allantoin. Whoever is having the increased amount of uric acid, we give the pegloticase. What it will do is, it is basically a synthetic form of uricase enzyme. And can you tell me what is the other name of uricase enzyme? Uricase enzyme is also called as the urate oxidase. Also called as urate oxidase. So they're asking what is the mechanism of pegloticase. What it will do is it will do the oxidation of the uric acid and it will decrease the uric acid. It will do the oxidation and it will convert the uric acid into allantoin. So the answer is going to be the oxidation of uric acid. It was not a very difficult question, because provided if you are knowing that key pegloticase, we all know that pegloticase, rasburicase, they are the synthetic form of the uricase enzyme, and this uricase enzyme is uricase is also called as urate oxidase. The moment you know that the oxidase word is there, it's oxidation. It's going to do the oxidation of uric acid. A 40-year-old woman underwent ileal resection and presents with the feature of anemia despite a good diet. Now, and her serum iron level was normal, but the RBC was less, means she was having the anemia after ileal rejection. The terminal ileum is the part where the vitamin B12 is getting absorbed. So after ileal resection, the vitamin B12 deficiency is going to happen. And that was leading to anemia in this lady, and that was the megaloblastic anemia. Megaloblastic anemia. Now, if there is a hypothetical condition that the blood glucose level spikes 2 to 3 times from the normal, what is going to happen with insulin? Say, if you suddenly increase the glucose level, there will be a sudden stimulation will go to the beta cells, and beta cells will suddenly release a lot of insulin. A lot of insulin will come. If you increase the glucose level very rapidly, a sudden spike in the insulin levels will come. Now, the moment the insulin spike will come, it will try to control the glucose level. But if it is not able to control, then the down regulation will start happening, and there is a slight gradual decline in the insulin level will start happening. So what they're asking is, if there is a sudden spike in the glucose level is there, what will happen with the insulin level? There's going to be a sudden rise in the insulin, followed by a slower but a sustained drop in insulin. It's basically is the biphasic uh, nature of the insulin. The release of the insulin happens in the biphasic manner. The moment the glucose comes, जैसे ही हम खाना खाते, there is a sudden release of insulin happens. That is a sudden spike that comes, and then there is going to be, if If it is still not able to control, then the down regulation will happen, and there's going to be a slow, sustained drop in the insulin level will start happening. Okay. A 22-year-old college student flies to Leh. It's a very high altitude, and she experienced nausea, mental confusion, headache was also mentioned in the question. Which of the following is the underlying mechanism? See, when you go to such a height, the oxygen levels are very less. There's going to be decrease in the oxygen level for sure. Now, the moment there is a oxygen levels are going to decline, it will lead to cerebral vasodilation. And this cerebral vasodilation will lead to headache, nausea, vomiting. The patient will not feel good. So that is the high altitude sickness that is going to happen. So what they're asking is, what is the underlying mechanism at the high altitude? What is the problem is, there's going to be decrease in the oxygen level, and that will lead to vasodilation. There's going to be decrease in the PaO2, and that will lead to vasodilation. And that will lead to headache. See, if even if you're not able to recall that in the exam, what you would have thought is ki headache ho raha hai, right? And the confusion, see, every one of us is knowing that on the mountains, the oxygen levels are less at the higher altitude. So you may have been confused between the option 2 and option C in the exam. The difference was vasoconstriction or vasodilation. You could have recalled that key in migraine, what is the drug that you give for migraine? For headache, what we give is the vasoconstrictor, that is the triptans, right? So whenever we have the headache, it's mostly because of vasodilation. And because in this MCQ, the headache word was mentioned, you should thought of that. It must have been vasodilation that would have been leading to headache, right? So this is how you would have got the answer. Which of the following, if given in large volume, can lead to hyperchloremic metabolic acidosis? Now, it was a tricky question. Hyperchloremic means there is increase in the chloride and the metabolic acidosis is happening. It normally happens if we give excess amount of normal saline. Now, you must be saying that ki how a normal saline, if we give, how there will be acidosis. Hyperchloremia, we understand it may be because of chloride. If we are giving excess amount of normal saline, the excess amount of chloride is going, right? Then how the metabolic acidosis will happen? If we give normal saline excess, this excess amount of chloride is going to bind with the bicarbonate, and it is going to decrease the bicarbonate levels, and that can precipitate the metabolic acidosis. So if we give a very high amount of normal saline, it can lead to hyperchloremic metabolic acidosis. There were 3 questions were there from the EBG. A patient presented with a casualty after multiple contusions on the chest. The ABG was given the pH of the blood. It was 7.3, means it was going towards acidosis. Then they have given the value of bicarbonate, that was 16, means it was less. So it was going towards the metabolic acidosis. This patient was having metabolic acidosis, and I think the hypotension word was also mentioned there in that question. And we know that hypotension can lead to prerenal AKI, and that can also lead to metabolic acidosis. Along with that, they have given the value of the sodium, chloride, and bicarbonate. So we can calculate the anion gap. So it is going to be the total positive minus total negative. The positive was 130, and the negative was the chloride and the bicarbonate, that is coming out to be 100. So the anion gap comes out to be 30. Normal anion gap is 8 to 12. So here the anion gap is coming high. This patient is having metabolic acidosis with a very high anion gap, with a very high anion gap. So the answer was metabolic acidosis with the anion gap of 30. So metabolic acidosis with the anion gap of 30. A patient presented with the bleeding symptom that resolves after administration of vitamin K. Now, means what they want. Now, this was more of a language question. What they are saying is, when we are giving vitamin K, the bleeding stops. Means this patient must be having vitamin K deficiency. Why this patient is having vitamin K deficiency? See, vitamin K is basically is a fat soluble vitamin. Whenever we are not able to absorb the fat soluble vitamins are also not absorbed. So it is possible that why this patient is having vitamin K deficiency, that he might not be able to absorb the fat. So he's having the fat soluble vitamin deficiency. And among the given choice, where we have the fat malabsorption, among the given choice, The fat malabsorption occurs in the biliary obstruction, because if there is a biliary obstruction, there is going to be decrease in the bile, and if the bile is not there, there is going to be fat malabsorption. And if the fat malabsorption will happen, there is going to be decrease in the fat soluble vitamins. And along the fat soluble vitamin, it is going to be the vitamin A, D, E, K, means the vitamin K. So if a patient is having biliary obstruction, he may be having vitamin K deficiency, and if you give him vitamin K, his bleeding will stop. So it's more of a language question that was there. Uh, then there was an image-based question on the pedigree, where what they were showing was that the female was transmitting the disease. Means it was a pedigree of mitochondrial inheritance. They have asked that which disease among the given choice is having the mitochondrial inheritance pattern. It is the Kearns-Sayre syndrome that is going to have the mitochondrial inheritance. What are the other diseases that have the mitochondrial inheritance, such as MELAS, NARP, Lone syndrome? These are the other mitochondrial inheritance, but the one that was given in the choice was the Kearns-Sayre syndrome, that is the mitochondrial inheritance. Williams syndrome is going to be a autosomal disorder. Prader-Willi is going to be for genomic imprinting. So they are not the mitochondrial inheritance pattern. It was a pedigree-based question that was given. Yes, if even, yes, rightly said, somebody, you are saying that factor 9. Okay, if it is factor 9, then it would have been a different thing. Yes. Okay, we'll come to that then. We'll correct that. The factor 9 will add in that. A 50-year-old male presents with the OPD, and he was having osteoporosis. I think he's having the bowing of the legs also were there. The outward bending of the legs were there. Which of the following is not used for his management? Which of the following should not be done for this patient? Basically, in old age, this outward bowing is because of osteofluorosis. This is indicative of osteofluorosis. He's having excess amount of fluoride. Is this osteoporosis because of osteofluorosis? So what should not be done for this patient? We should not give the fluoride supplement. We should not give fluoride supplement. Right? We will change the source of water. Definitely will change the source of water. We'll give him the running surface water that will contain less fluoride. We will also give him lime water so that the fluoride content in his body will decrease. So it is a case of osteoporosis. If you see the choices also, three choices are going towards one side, right? They are going towards a side that they are saying that will decrease the fluoride. Then there is one that is fluoride supplementation. A patient presents with the recurrent episodes of disseminated gonococcal infection, and there is Neisseria gonorrhea that was seen. Now, it's more of a question from the immunity. The recurrent gonorrhea infection happens if there is decrease in the MAC, membrane attack complex. If the membrane attack complex is not made, then the recurrent gonococcal infection happens. And why the MAC is not made? It is because of the defect in the C5, C6, C7, C8, C9 that is going to be defective. The terminal complement deficiency, if the terminal complement deficiency is there, C5 to C9, the MAC will not be made. And if the MAC is not made, the gonococcal will not be killed. And again, gonococcal infection will happen. Recurrent gonococcal infections will happen. Yes. The next was a 69-year-old male presents with severe dyspnea and increased amount of clear sputum. The ABG was showing 7.2 pH. It was very straightforward. 7.2 pH means the pH was less, means it is going towards acidosis. And the carbon dioxide level was more. The moment the carbon dioxide is more, it is going towards the respiratory acidosis. Respiratory acidosis. They have given the bicarbonate that is 26, so more or less normal. So it was a straightforward case of respiratory acidosis. And because they have given the respiratory illness also, if you see the patient is having dyspnea, sputum, means some infection is going in the lungs. So it is the CO2 retention that was happening and that was leading to respiratory acidosis. It's case of respiratory acidosis. A boy presents with the orange colored tonsil that Dhawan sir also have discussed towards the end. The orange colored tonsil with the family history of the cardiovascular disease showing a very decreased amount of HDL. decrease amount of HDL. HDL is the good cholesterol. So the good cholesterol is not there. This helps in the reverse cholesterol transport. So now if the HDL is not there, the reverse cholesterol transport will not happen and the excess cholesterol will remain on the tonsils, and that is why the color of the tonsils will become orange. And there is a family history also is there of cardiovascular disease, because this excess cholesterol will just not deposit on the tonsils, it will deposit in the blood vessels also. So what is the disease? That is the Tangier disease. In fact, this simple word, the orange color tonsil, would have taken you to the answer. It is a defect of the ABCA1. The ATP binding cassette protein A1 is defective, and that is leading to the Tangier's disease. Yes. A child presents with the elevated concentration of phenylalanine. Now, it was a very interesting question. There is increased amount of phenylalanine, and they have mentioned in the question that the tyrosine is less. The moment we saw that combination, we were thinking it's phenylketonuria. To do this reaction, we require two things: phenylalanine hydroxylase enzyme, and we require tetrahydrobiopterin. Tetrahydrobiopterin. In that question, the this particular reaction is not happening. Now we have to figure out that why this reaction is not happening. Is it a deficiency of phenylalanine hydroxylase or BH2 reductase deficiency? And because in the question they have mentioned that the phenylalanine hydroxylase activity is normal, means this thing is normal, but despite that the reaction is not happening, means it is a deficiency of then tetrahydrobiopterin. It's a tetrahydrobiopterin deficiency. So the answer is going to be the biopterin or tetrahydrobiopterin deficiency. It is a phenylketonuria type 2, PKU type 2. As we have discussed many times in the class in the same manner, hydroxylase deficiency is phenylketonuria type 1, but they have mentioned in the question that it is normal hydroxylase, then automatically the answer is biopterin deficiency. A patient presented with the feature of dorsal column dysfunction, means the Romberg test was positive. There was ataxia is also mentioned. There was neuropathy was happening. Now, this was, I feel that one of the difficult questions that was there in your exam as far as the biochemistry is concerned. So far, we understood that till this point, we understood dorsal column problem, ataxia, neuropathy. It is a mixed problem that is happening where the sensory, motor, upper motor, lower motor neuron all are getting affected, means it was a B12 deficiency. And that was leading to subacute combined degeneration of the spinal cord. That we have understood. They have also mentioned that this patient is having increased amount of homocysteine. That is, yes, rightly said that in B12 deficiency, we have increased amount of homocysteine. That is true. In B12 deficiency, the methylmalonyl acid, the methylmalonyl CoA is going to be more. That is also mentioned. So far it was looking very straightforward. When we were reading this question in the exam, increase homocysteine, increase methylmalonyl, it's a B12 deficiency. Then what they have asked is, production of which amino acid would be affected? See, in the class, we have discussed that to convert the homocysteine into methionine, we require vitamin B12 and B9. Mainly, we require vitamin B12. So if the B12 is not there, what is that is happening in this case? The B12 was not there. If the B12 is not there, this reaction will not happen. And the homocysteine will not be able to convert into methionine. So production of which amino acid is going to be affected in this patient? It is going to be methionine. It is not going to be cysteine, guys. It is not going to be cysteine, because what is going to happen is, if you want to make cysteine from homocysteine, can you tell me that from homocysteine, if you want to make cysteine, which amino acid is required? Which vitamin is required? From homocysteine to cysteine, we require vitamin B6, because from homocysteine, we make cystathione, cysteine, that requires B6. This patient is having B6, so there is no problem in cysteine production. The problem will happen in the methionine production because he's having B12 deficiency. A patient presented with a feature of heart failure, horizontal nystagmus. Nystagmus was there, ataxia was there, and heart failure was there. Now, we know that nystagmus, and I think the cerebellar ataxia, the word that was mentioned was cerebellar ataxia, means imbalance was happening, nystagmus was there. There is no history of alcohol or smoking, but the patient is having heart failure. They are asking that which vitamin deficiency is associated. Now, if you remember vitamin B1 thiamine, it can lead to beriberi. When it comes to beriberi, it's of two types, right? The wet beriberi and the dry beriberi. Wet and dry. The wet beriberi will lead to the cardiomyopathy, means it will lead to heart failure. It is associated with the cardiovascular problem, whereas the dry beriberi, it is associated with the neuronal problem. And here you can see that this patient is having both the things. He's having heart failure as well as the neuronal problem. So he's having nystagmus, ataxia. So this is a special variety of beriberi, that is a mixed beriberi, where the person is having both the symptoms, wet beriberi as well as dry beriberi. Heart failure features are also there, as well as the neuronal problems are also mentioned, the cerebral ataxia, nystagmus. It's a mixed beriberi, and mixed beriberi, again, it is due to deficiency of thiamine. It is a thiamine deficiency, right? It's very good. The last question was simple, straightforward one. A patient presented with the long limbs, arm span is more than the height, ectopia lentis. The moment you read till this point, you would have also figured out that it was Marfan syndrome. Ectopia lentis, the height is tall, arm span is more. The Marfan syndrome is suspected. Which of the genetic defect is there? Marfan syndrome is due to defect of the fibrillin 1. It's a fibrillin 1 defect, right? So yes, hydrochlorothiazide question was there, and I know that, and that will be discussed in pharmacology. Don't worry about that. You stay tuned. This is all about from the biochemistry part. There was 27 questions that we have discussed. I understand that there may be 3, 4 questions that was overlap, but still you can easily figure out that 22 questions were purely from biochemistry. In an exam or 200 question, 20 to 22 questions of biochemistry, and which is everything was from the notes. If you are knowing your notes thoroughly, the videos that we have discussed, if you have seen all that lectures, I would, I can easily say that you would have scored more than 23, 24. Easily you could have scored. Right? They were not difficult question, but just they were lengthy, and there were a lot of information were there that you have to process in a limited time frame. And that is possible if you would have done multiple revision, then it would not be have been a challenge for you in the exam. Right. So this is all from the side of from my side of the biochemistry. I wish you a very good result. You have done a wonderful hard work, and definitely the result will come as you have expected. Wishing you all the very best for your results. And stay tuned. The next subject will be is coming shortly.
Good afternoon, everybody. And just let me know quickly if you can hear me properly. And we'll get started with the radiology recall of NEET PG 2025. We had a significant number of images and a lot of radiographs, a lot of X-ray images in this exam. And I hope you have done well. Radiology was pretty much on the moderate to easy level, I would say, right? Not difficult, but few questions were very straightforward and easy. And there were some questions which were, moderate level. Just let me know how did you do with radiology. Shall we get started? Yeah. And I'll be showing you the questions, almost around 10 questions we'll be discussing. And I want you to let me know if you can get into better options or the clinical case scenarios. Let us look at the first question here. There was a simple question, the routine question that we have. They gave you a patient who is having difficulty swallowing, weight loss, and there was also an associated finding of bronchiectasis on the radiograph. And they said there is a barium image given, which showed a bird beak appearance, right? So very clearly achalasia cardia. They asked what is the investigation, which will confirm the diagnosis for this condition. And the answer was manometry, right? So the answer for this question was manometry. We had CCT, esophagogram, upper GI endoscopy as options, and the answer was manometry. I hope you have done this correctly. Okay, what did you do for this question? A right flank pain, 50-year-old male, CT abdomen showing a mass in the right hypochondrium. What is the answer for this? What did you answer for this question? A coronal CT scan image was given to you. This was a coronal CT. And he gave very close options. He gave a gallbladder cancer, renal carcinoma, retroperitoneal tumor, okay, and a renal abscess, like not renal abscess, actually they gave you as a liver abscess. The option was a liver abscess there. What did you mark for this question? So if you can see the image carefully, let me zoom it for you. If you can see the image carefully, you are seeing a heterogeneous lesion in the upper pole of the right kidney. A heterogeneous lesion in the upper pole of the right kidney, and you can see actually the invasion into the IVC also. So this is a renal cell carcinoma with renal vein invasion. And this answer is renal carcinoma. Okay, a right renal mass. The answer was a right renal mass or a renal cell carcinoma that was given. So it was not a mass in the liver or a mass in the gallbladder. It was a mass in the kidney. So you just have to identify the anatomy where the mass was there. So I hope this was clear for you. Next question. A simple question. I think you have done this. Newborn admitted to NICU within 24 hours with severe dyspnea and respiratory distress. The radiograph was given. I tried to bring in as similar radiograph, and you are seeing multiple air fluid, the bubble loops that are present, which are continuous with the bubble loops of the abdomen. You are seeing that in the left hemithorax, in the left lateral part of the hemithorax, you are seeing these bubble loops, and these are continuation with the bowel loops of the abdomen. This is a classic congenital diaphragmatic hernia. You had options of congenital lobar emphysema. Congenital lobar emphysema would be in the upper lobe, right? Congenital pulmonary airway malformation would show a lot of cystic areas, but not continuation with the abdomen. So the answer here was congenital diaphragmatic hernia. And I hope you have done this correctly also. Not GB cancer. This was renal cell carcinoma. Okay, it was separate from the gallbladder. What you were seeing was the invasion into the IVC. Right, so what was seen there was the invasion into the IVC. It's a renal cell carcinoma, right renal mass with invasion into the IVC. The next one we had, there was a clinical description given. They showed you a pulsatile mass in the upper cervical region, which was getting compressed and filling slowly, right? Once you release the compression, it was filling slowly, and an angiography image was given. And what was shown to you is a classic Leyer sign, Leyer sign. What did you mark for this Leyer sign? You had a external carotid artery and an internal carotid artery, which were separated by a mass here. So this is the carotid body tumor, So carotid body tumor or paragangliomas. Please remember two important radiological findings we stress in our classes: Leyer sign and salt and pepper appearance on MRI. Salt and pepper appearance on MRI. These two things for carotid body tumor. So classic angiography image was given. Carotid body tumor was the answer, right? So I hope you got that right. Next one. Then did you come across this question of neonate presenting with congenital hypothyroidism? There is decreased T3, T4 levels and decreased radioactive iodine uptake, but a normal thyroid on ultrasound. So when you get our radioactive iodine uptake studies, it was showing decreased uptake, but the thyroid gland on ultrasound was normal. And they asked you what is the condition? Is it iodine deficiency, defective iodine uptake, thyroid agenesis, or is it a case of hypothyroidism? Did you? I think the fourth option was something. And what did you mark for this? What did you mark for this? There is decreased radioactive iodine uptake, but ultrasound shows normal finding. Ultrasound shows normal finding. So when you have the T3, T4 levels decreased, right? Ultrasound showing the thyroid normal. This, okay, the other option was dysharmonogenesis, right? So the other option was dysharmonogenesis. Dysharmonogenesis. And this is a case of defective iodine uptake, because the uptake of radioactive iodine is less, but there is a normal thyroid gland. Think of a defective iodine uptake, that was there, right? So dysharmonogenesis was the correct option, the fourth option. The answer was defective iodine uptake. Next thing. The other questions that we had was, did you get a question like this? A 32-year-old female presented with having abdominal pain from last 1 year. Based on the given MRI image, what is the likely diagnosis? They actually showed you an MR showing a lesion at the fundus of the uterus. There was a T2 weighted MRI. You can see the bladder is white, and they marked it as an endometrial lining was marked. The endometrium was marked, and they asked, what is this lesion? So this lesion, which is at the fundus of the uterus, which was separate from the endometrial lining, where you can see that the lesion was slightly distinct from the endometrial lining. So this was an intramural fibroid. So this is an intramural fibroid. Pelvic adenomyosis, you see cystic areas. What do you see in adenomyosis? You see cystic areas, myometrial cysts. And along with that, you see increase in junctional zone. So this was separate from the junctional zone, right? So this lesion was separate from the junctional zone. So this junctional zone more than 12 mm, that would be pelvic adenomyosis. But it was not thickening of the junctional zone. It was a separate lesion, so right, in the fundus of the uterus. So that was intramural fibroid, There was an option of endometriosis, okay? So one option was endometriosis, okay? Endometrial polyp, endometriosis. But the answer was intramural fibroid. Endometriosis will be outside the uterus, right? So outside the uterus, it was in the fundus of the uterus. So this is intramural fibroid. Then, okay, something similar image. I have given you one more image. So you had this kind of image where the T2 weighted MRI was given. So the bladder was white. So T2 weighted MRI. And you see a lesion within the fundus of the fibroid. So this is intramural fibroid. And one more question. A 32-year-old female presenting with recurrent headaches. The following MRI image is given. What is the likely diagnosis? And they showed a contrast enhancing lesion, broad base towards dura. And you can see adjacent dural thickening. What is this called? Dural tail sign. And female patients, right? So female, more common in females. What is this? It was we can do MRI for fibroid. Okay, so the thing was, the examiner showed you, if you look at the question carefully, the endometrial thickening was marked. It was separate from and from the lesion. So it was shown that the endometrial thickening was separate from the lesion. So that was fibroid. Okay, so that was fibroid. And what is this? A dural tail sign that you have. A female, which is this lesion more common in females, right? So because of progesterone receptor positive, showing two important findings: a dural tail sign and a mother-in-law sign, or contrast enhancement, which is very early to come and late to go. So this is a meningioma, right? Classic meningioma image, MRI image was there. And they gave you a radiograph, and the question said there was fever and cough in the patient, and they gave a radiograph. And they asked, what are the options? What is the condition? Is it right upper lobe collapse? Is it a mass? Is it a, mass? Or is it a right upper lobe consolidation? Anybody remembers any other option with this kind of radiograph? Anybody remembers any other option? Any other option for this? Meningioma, another option was ependymoma. Okay, other option was ependymoma. Okay. So the answer still was meningioma. Okay, so the classic was meningioma. Now, what is this radiograph showing you? What did you mark for this? Along with chest pain, fever, cough, chest pain was also there. Okay. What do you mark for this? Lung abscess was also there. So what did you see here is a opacification in the right upper lobes. And you could actually see these air bronchograms, these black air bronchograms that you can see. So when you're seeing the air bronchogram, this is a right upper lobe consolidation, right upper lobe consolidation. So presence of air bronchogram and the clinical features also, fever, cough, chest pain, right? So all of this was right upper lobe consolidation or right upper lobe pneumonia, right upper lobe consolidation pneumonia, fever, chest X-ray. Remember, in case of collapse, there won't be no air bronchograms. There won't be air bronchograms here. You can see some black areas there. So those were air bronchograms. So that was the important thing that you have to identify. If you could see the air bronchograms, that was pneumonia or consolidation, pneumonia or consolidation. Next. Okay. There was one more radiograph showing the pelvic radiograph of a 10-year-old boy complaining of hip pain. And they gave a radiograph and they asked what is the diagnosis. And in the right hip, you were seeing some sclerotic areas. And the options were showing you slipped capitofemoral epiphysis, you had Perthes disease, you had any other options, do you remember? Any other options you remember? Tracheal deviation to the right? No, I mean, this was showing the classic air bronchogram. This was fever patient, cough patient. Please mark it as right upper lobe consolidation. Okay, so that was a clear-cut case of right upper lobe consolidation. And developmental dysplasia, good. One was DDH. Any other options that you remember? Painless limb, right? Painless limb in a young 10-year-old. 10-year-old boy. And what was the other thing? Yeah, TB hip. So these were the options. A painless limb, 10-year-old boy, and the radiograph showing you a sclerotic margins of the acetabulum and the head of the femur. So this was avascular necrosis of the head of femur. The avascular necrosis in young. This is Perthes disease. Okay. Now the answer was Perthes disease for this. And there was one AP view of the barium swallow image, so asking you to know what is the mark structure. They asked you what is this structure. They gave this arrow here and they asked you what is this structure. What did you mark for this? What did you mark for this? What is this? Is it epiglottis, piriform sinus, vallicula, or thyroid cartilage? They showed a AP view of the barium swallow and they asked what is this structure. This is piriform sinus. Okay, so piriform sinus. So that image was the piriform sinus. The next one, okay, so I've just shown you where the vallicula lies and where the piriform sinus lies. Okay, so just mark the piriform. The question asked where the piriform sinus is. And they gave a IVP image. They asked most appropriate sentence regarding the given investigation. And they asked, what is this investigation talking about? So they gave an IVP image and they asked, what is this investigation about? Is it invasive and used for treatment of bladder calculi, non-invasive and used to diagnose retropelvic junction obstruction, non-invasive and gold standard for bladder cancer, or for percutaneous image guidance? Now, what do you think is this answer? What do you think is this answer? So you understand the given image is IVP. IVP is a non-invasive. So you have to choose among non-invasive. Non-invasive and gold standard for bladder cancer, obviously it is not true, right? Bladder cancer, we do biopsies, right? That would be the gold standard one. So non-invasive and used to diagnose uretropelvic junction obstruction. What would happen in PUJ obstruction? When you have a PUJ obstruction, what do you have? What do you think will happen? In PUJ obstruction, obviously the pelvis will be dilated. There will be prominent pelvis, right? And you will not see this contrast filling into the ureter. So you'll have prominent pelvis without contrast opacification of the ureter there. You suspect PUJ obstruction. So yes, it can be used for PUJ obstruction. So the answer was B. It is non-invasive and used to diagnose uretropelvic junction obstruction. Okay, so this was the answer. And one more question, something, okay, just correct me with the wordings. There was a young male with lower back pain and stiffness, improving with exercise, anterior uveitis, in the patient, loss of lumbar lordosis, restricted spinal flexion. The Schobert test was given, and X-ray was normal. X-ray mention was normal. And what is the investigation that will help you to diagnose this condition early? So they asked you which investigation will help you diagnose this abnormality early, and this was, what is the investigation? So what is the condition? It's an inflammatory arthritis, right? There is loss of restricted spinal flexion. There is Schobert test positive. So this was classic ankylosing, young male with low back pain. This was ankylosing spondylitis. And they asked what investigation helps you diagnose this condition early? CT of the sacroiliac joint, MRI of the sacroiliac joint, anti-CCPs, or X-ray of the pelvis. So the answer was MRI of the sacroiliac joint, the investigation of choice for STIR MRI. Okay, anti-CCP was mentioned, and they asked what is the investigation of choice? Investigation of choice is a STIR MRI, right? So the STIR MRI. The answer was STIR MRI. Next, another 62-year-old female with low backache, and they gave a radiograph, a lateral view of the lower lumbar spine was given, and they asked you what is the investigation, what is the diagnosis there? Is it Klippel-Feil syndrome, crushed vertebra, spondylolysis, or spondylolisthesis? What did you mark for this, guys? This is the last question in radiology. What did you mark for this? What did you mark for this? Now, if you see carefully, okay, what you had to do in the exam is you had to trace the anterior spinal line, and you could see that the anterior spinal line is continuous. So you were seeing a break in the pars interarticularis, and the anterior spinal line was continuous. So this is Scottish dog collar sign. This was spondylolysis. You are seeing a Scottish dog collar sign. If you trace the anterior spinal line, if it is continuous, that is spondylolysis. Only if you have a discontinuous anterior spinal line. If you look at the spinal line, if it appears discontinuous, then it was spondylolisthesis. Spondylolisthesis has a beheaded Scottish dog. Right? These were different questions that came in radiology, and I hope you have done most of these questions correctly also. And the image is similar. Okay, the image is similar. Okay, you had to just trace the anterior spinal line. You'll get to know whether it's spondylolysis or spondylolisthesis after tracing the anterior spinal line. If it is discontinuous and you see break in the pars interarticularis, that was spondylolysis. Okay, it was not crushed vertebra. Klippel-Feil syndrome will be at the cervical, fusion of the cervical vertebra, right? Klippel-Feil syndrome will definitely not answer. The only difference you have to make was whether it is spondylolysis or spondylolisthesis. And you have to track the anterior spinal line. If it was continuous, you are dealing with spondylolysis, right? So that was it, right? The answer was spondylolysis. Okay, go ahead. This is what it is. Next. Fine. I think there was one question on central pontine melanosis also. They asked what you do for that investigation, right? And I think there was also a question on Paget's disease. They'll discuss you in your orthopedics classes also. Increase in heart size, but X-ray showing lytic and sclerotic areas, right, in the bone. So that was Paget's disease, right? So alkaline phosphatase levels were elevated. So it's a lot of integrated questions. So 4 image-based questions were also there, and a lot of integrated questions were there. And I hope you have done your radiology questions fine. There are a lot of discussion of radiology that was done in your regular classes, in your your live classes, that online live sessions also, and I hope all these sessions would have worked, right? Sure. I hope whatever you have marked, I hope and I pray that it is right. But this is what I have got from something I trust, and I hope this. But I really wish that whatever you have marked will be right on the day of exam. Okay, so I think that should be it for radiology. You'll have the next sessions followed up with this, and any other things, any queries in this that you had felt about, right? How many questions did we cover? 1, 2, 3, 4, 5, 6, 7, 8. Also 9, 10, 11, 12, 13. Okay, so almost 13 questions were there, and I hope you have done them rightly, right? And I think it'll be followed by the next session. This is a recall sessions only, but don't completely, be worried. Or if you get some options correctly, please, if you get to know that if a certain image was there or a certain option is different, you can please get to us, right? So you'll have a next session planned. Thank you.
This is Dr. Rohith Daniel, your orthopedics faculty. So after several months of waiting, finally the exam is over. That itself is a big relief for all of us. And the questions, I would say, were moderate. And I think most of the questions were doable. It was not that tough. And from the chat box, I was reading all of your opinions and all of your answers and everything. And I feel that most of you are actually relieved that the exam is finally over and somehow you have done it. And I know that many of you would be in a little bit of doubt whether I have done it well or not. You have to forget about all those things. There are a few more days till the results would be out. Until that time, I think you deserve a break. Take rest, go watch movies, enjoy with your friends. Don't worry about the results now. Whenever the results come, we'll see. And whenever we do a recall, please remember one thing. These are not perfect questions or answers that we are giving here. So from several students that we talk to, we collect the questions and prepare the options as well. And from our experience over the last several years of seeing and helping students prepare for the NEET PG exams, we know how the questions could be framed. That is how we are making up these questions. And if some wording here and there are different, please forgive us. And if you have any inputs to give, please give them in the chat box. We'll be open to that as well. Okay. So unlike the previous years, we had good number of questions from orthopedics, around 10 questions. A few questions were directly from orthopedics. Some were questions that had overlap with other specialties. Few of the questions you would have already listened to from the previous session. Then when you discuss about the anatomy questions, again, you will hear about some of these questions. Don't worry. I will quickly do this record. And if you have any suggestions or additions or something like that, you're all welcome. Okay. So we'll start with the first question. 80-year-old child presents with limping for 10 months. His X-ray is given below. What is the diagnosis? Here again, there are two groups of students who told me that one group told me that, sir, this is a case of slip capital femoral epiphysis where the capital femoral epiphysis or the femoral head was kind of subluxed or dislocated. But another group of students told me that no, sir, there was some other problem with the femoral head. But uniformly, everyone told me that the age of the child was 8 years. So 8-year-old child with limping for 10 months and with an X-ray. The interesting thing about pediatric hip problem is that just by looking at the age, 90% of the time you can get to a diagnosis. How is that possible? I will tell you. Okay. So first we have the first option, osteomalacia. Osteomalacia is what? Osteomalacia is vitamin D deficiency in an adult, isn't it? So can it occur in a child? No. This is seen in an adult. What about Perthes disease? The common age group of Perthes disease is 4 to 8 years. Slip capital femoral epiphysis, what is the age group? It is between 12 to 16 years. It usually occurs in the peripubertal age group. And finally, we have DDH, which is developmental dysplasia of hip, which is a congenital anomaly, and most of these children will definitely get diagnosed before the age of 1 year. Okay, so just look at the age and tell me which is the most probable diagnosis here. So if it is 8 years, the most probable diagnosis is Perthes disease. It is very unlikely that an 8-year-old child can get a slip capital femoral epiphysis. Why? Because it occurs only in the peripubertal age group. When the sex hormones of the child starts to increase, that is the age group when you get slip capital femoral epiphysis, and not before that. Now, what could be the changes in Perthes disease? See, this is the normal capital femoral epiphysis or the femoral head. And what has happened here? There will be collapse and fragmentation of the femoral capital epiphysis. Okay, that would be the changes in Perthes disease. Now, if the patient's age was not 8 years and if it was 13 or 14 years, then very well this could have been a capital femoral epiphysis. But as long as you are sure that the patient's age is 8, then the answer probably is Perthes disease. Okay. Next question. A male presents with chronic back pain and anterior uveitis for several months. On examination, there is tenderness in the sacroiliac joint. What is the diagnosis, investigation of choice to make the diagnosis at the earliest? So, any male patient with chronic back pain and anterior uveitis, what is the first thing you would think about? You would be thinking about ankylosing spondylitis, isn't it? Ankylosing spondylitis is one of the most common inflammatory arthritis causing back pain in a male patient. And anterior uveitis, remember, is the most common extraskeletal or extra articular manifestation of ankylosing spondylitis. So it is ankylosing spondylitis, and one of the methods to identify ankylosing spondylitis is to identify sacroiliitis. Okay, and the best method to identify sacroiliitis is MRI of the sacroiliac joint. X-ray will not be useful, CT will not be useful, and the CCP again is for rheumatoid arthritis. So the best option is to do an MRI sacroiliac joint. Next question. Again, there would be a confusion here. A 65-year-old lady presents with chronic low backache. Her X-ray is given below. What is the diagnosis? So, Kaushik is asking why not anti-CCP? Anti-CPP is positive in rheumatoid arthritis. Okay. And ankylosing spondylitis. Angspond is a seronegative spondyloarthropathy. What does that mean? A seronegative spondyloarthropathy means it is seronegative or RA factor negative. Okay, RA factor, anti-CCP, everything would be negative in these conditions. Be it ankylosing spondylitis, psoriatic arthropathy, or it could be enteropathic arthropathy, Reiter syndrome. All these are examples of seronegative spondyloarthropathies where RA factor, anti-CCP, etc. would be negative. Okay. Now, again here there are two groups of students. One group saying that there is this question, 65-year-old lady presenting with back pain and there is this X-ray. And a group of students say that there is a small break in the pars interarticularis here. Another group say that no sir, there is a definite subluxation of one vertebra on top of the other. Okay. So in the previous discussion, sir told you that If there is a break in the pars interarticularis, it has to be spondylolysis, isn't it? So this is for the other group of students who believe that no, there is a subluxation. So if this was the X-ray given to you, you can see that this is the L5 vertebra and this is the L4 vertebra. The L4 vertebra should have been here, isn't it? The L4 vertebra should ideally be here. Instead, it has subluxed anteriorly. It had to be here. It has subluxed anteriorly. This subluxation of one vertebra on top of the other is called spondylolisthesis. Spondylolisthesis. If this was the X-ray given, then the answer, as most of you have put it in the chat box, if this was the X-ray, then the answer probably would be spondylolisthesis. There is high chance that spondylolisthesis would be the answer because over the last 2 years, several of the FMG papers had similar X-ray with spondylolisthesis being asked at least twice in the last 2 years. So it is probable that they have taken this and put it for you. Question number 4. A young male sustained mid-shaft fracture tibia and was treated surgically. In the postoperative period, he developed severe pain in the leg. On examination, there was swelling in the leg and diminished sensations. However, the dorsalis pedis pulse was intact. What is the next line of management? Tell me what is the diagnosis? Mid-shaft fracture is notorious for a complication. In the upper limb, supracondylar fracture causes this complication. In the lower limb, tibia fractures causes this complication where there is severe swelling of the muscles causing increase in intracompartmental pressure. What is this? Yes, it is your compartment syndrome. Yes, this is compartment syndrome. This is a condition where there would, which we call as compartment syndrome. And compartment syndrome will present as severe pain in the leg, and we know that in the immediate postoperative period we would be giving the patient analgesics, but even with the analgesics the patient is developing severe pain and there are some neurological problems such as diminished sensations, isn't it? Now, is there any importance for dorsalis pedis pulse being intact? Actually, there is no role for dorsalis pedis pulse being intact. Whether it is present or not, compartment syndrome diagnosis does not change. Whether the pulse is present or not, we can make the diagnosis of compartment syndrome just by clinically examining the patient. And these kinds of patients have to be treated how? Yes, excellent. Yes, Comisian, you're absolutely correct. You have to do a emergency fasciotomy. Don't waste time. That is the dictum. Don't waste time. Okay. When you are suspecting, just suspecting is enough. Suspecting compartment syndrome is enough to do a fasciotomy. Otherwise, what will happen? You keep on thinking whether this is compartment syndrome, maybe it is something else, and the patient's limb will go in for gangrene. Even if you have a doubt, no problem. Get the patient into the theater and do a fasciotomy. Don't waste time in all these things. Okay. So the answer is emergency fasciotomy. Next question. A young male had sustained fracture shaft of femur after RTA. He was treated with surgical fixation. After 6 days, he developed acute onset shortness of breath and rashes on the upper chest. What is the diagnosis? What is it? We know, isn't it? Whenever there is fracture shaft of femur, we are always scared of a particular complication where fat globules from the bone marrow get outside, get into the systemic circulation and go to the various organs and cause multi-organ dysfunction and even death. This is your fat embolism syndrome. Fat embolism syndrome, the most common trigger for fat embolism syndrome is fracture shaft of femur, and these patients will always have a time delay from the point of injury till the onset of symptoms. It never happens that the patient has an injury today evening the patient gets fat embolism syndrome. Never happens like that. There will always be a time delay. Usually it is 2 to 3 days. However, up to 6 days also, it is possible that the patient would be fine for 6 days and suddenly on the 7th day he starts developing the symptoms. That is also possible. Okay. And these patients will develop a triad of symptoms. Triad. So, triad of symptoms of what? There will be a rashes, Then there will be CNS symptoms in terms of what? There would be altered sensorium. There could be aggressive behavior, abnormal behavior, seizures could be there. Then there could be respiratory symptoms in the form of shortness of breath, fall in partial pressure of oxygen, dyspnea, tachypnea, all these things would be there. So someone is asking why not DIC? DIC would present as bleeding. DIC can occur as a complication of fat embolism syndrome. That is possible. Fat embolism syndrome can give rise to DIC, but DIC, if you have to answer as DIC, some kind of bleeding manifestation should be there. This is a very commonly asked question. This type of vignette has been asked so many times in the last 5 years. This is straightforward fat embolism syndrome. Next question. A 60-year-old man presents with generalized body ache and increasing hat size. On examination, the bones are warm to touch. X-ray shows lytic area in the long bones. And what is the diagnosis? What is it? We have not got all the options, but the answer is very straightforward, isn't it? This is your classical Page's disease. Whenever I take classes, I always tell you to remember the definition, isn't it? What is the definition of Page's disease? It is a chronic disease usually affecting males, characterized by replacement of normal bone with abnormal bone. And what is the abnormal? So, normal bone is replaced by abnormal bone. And what are the features of this abnormal bone? It will be excessive. Excessive means it will be too much, more than that is required. Then it will be hypervascular. Hypervascular means large amount of blood flow is going into the bone, and then it would be weak. Lot of bone is formed, but it is very weak. Understood? So this is the problem with Page's disease. So because you get excessive formation, what happens?
Systemic examination का क्या मतलब होता है यार?
So whenever there is excessive bone formation, these bone can get deposited into various parts of the skeleton. Okay, so if you palpate the bones would become thick. And in Western countries where people wear hat, what do they say? They will go to the doctor and say, "Sir, earlier my axis was 7, now it is 8. And slowly it is increasing. My skull size is increasing. That is why the hat is becoming tighter and you have to increase the size of the hat." Then the bone becomes hypervascular, which means lot of blood flow is going into it. That is why when you touch the bones, it will be warm and it will be weak. Because of weakness, there will be small micro fractures causing pain. There can be big fractures also. And what do you call the big fractures in fracture in pages? Fracture in pages is called banana fracture. Banana fractures. Okay. Anyway, this is straightforward Page's disease. Yes, Akash, yeah. We have discussed this so many times in our lecture classes, isn't it? Correct. Next question. An athlete presents with hyperextension injury of the shoulder. The doctor suspects avulsion of the long head of triceps. Sorry, long head of triceps. What is the origin of long head of triceps? What is it? This is a straightforward question from anatomy. I'm sure you'll hear the same question in the further sessions as well. The origin is from, yes, infraglenoid tubercle, isn't it? Infraglenoid tubercle. Next question. A 20-year-old man sustains inversion injury to his foot while playing football. Which ligament is injured? So whenever there is inversion injury to the foot, you have to think of the most common ligament injury in the body. Most common ligament injury in the body occurs in inversion injury. Where do you get inversion injury? When you are climbing down steps and you miss a step, what will happen? Your foot goes into inversion, and this will cause stretching of your anterior talofibular ligament, ATFL. So that is the answer, anterior talofibular ligament. Okay. Next question. Question number 9. An elderly patient presents with knee pain. X-ray shows changes of arthritis. Synovial fluid analysis shows rhomboid crystals which are positively birefringent. What is the diagnosis? Can you tell me? So whenever an elderly patient comes with knee pain, what will happen? So some students are saying that it is eversion injury. Don't worry, after this question I'll come back. Okay. So elderly patient presents with knee pain. X-ray shows changes of arthritis. Synovial fluid analysis shows rhomboid crystals which were positively birefringent. What is the diagnosis? Then here we know that whenever there are crystals in the joint, we have to think of a crystal arthropathy. And which are the two crystal arthropathies? Gout and pseudogout. Gout means that there is deposition of MSU crystals, and pseudo gout means that there is deposition of calcium pyrophosphate dihydrate crystals. And we know that MSU crystals are negatively birefringent and they are needle shaped, isn't it? CPPD crystals are rhomboid in shape and it is positively birefringent. So what is the answer here? The crystals are rhomboid and positively birefringent. So it must be pseudo gout. Okay. Now, if it was eversion injury, I'll just quickly go back to question number 8. If it was eversion injury, if many students are saying that if it was eversion injury is quite rare, okay, to occur like that. If the question was eversion, then the possibility is deltoid ligament injury, that is a possibility. Okay, but inversion, this is the question that is commonly asked. Actually, this is a previous year question. The ligament to get injured in inversion injury is a previous year question. Most probably it is anterior talofibular ligament. If you are absolutely sure that is inversion, then probably a ligament on the medial side, which is your deltoid ligament, could get injured. Last question. A patient presents with meralgia paresthetica. Which nerve roots are affected? What is this meralgia paresthetica? Meralgia paresthetica is a compression neuropathy affecting the lateral femoral cutaneous nerve, also called as the lateral cutaneous nerve of thigh. It is a nerve that arises from the lumbar plexus from nerve roots L2, L3. L2, L3. Okay, that is the answer. Okay. I think all the questions from orthopedics and the associated questions were also discussed here. Okay, so these were the questions, and if you have any opinions or anything to add, you are all welcome to do that in the chat box. Any corrections would be made whenever that is necessary. Okay, so thanks for the patient listening, and don't worry at all. Take rest for a few days, and all the best for your results. Thank you.
Hi, dear students. I hope you had a very good exam. Question was quite from the topics which we have already discussed in our main videos and QRPs. And questions were quite easy. I would say, I would not say, let's say very easy, but it was at least very much answerable. And the main thing which I noticed in the question was that the students who had done, who would have done many revision of our lectures and the video notes and lectures, etc., they must have been able to solve the questions easily. So let us discuss the first question, which was asked. The question was on the neuromuscular blocking agent. A patient scheduled for surgery developed preoperative bradycardia, hypotension and facial flushing. So bradycardia, hypotension, and facial flushing. Which of the following muscle relaxant is most probably responsible for that? Now, we have discussed these are all non-depolarizing neuromuscular blocking agent, and we have discussed that non-depolarizing neuromuscular blocking agent, the group that is benzyl isoquinoline, they are histamine releaser. And since they are histamine releaser, the histamine is released and it causes flushing, bronchospasm, hypotension. Now, there is a little doubt here whether it was Brady or Tacky. Whether it was Brady or Tacky, I would like your help in that. That whether it was bradycardia or written tachycardia, because it should be tachycardia, because with hypotension it should have been tachycardia, right? So if you can help me in that, if whether it was written Brady or Tacky, I would be very grateful. So as I said, that neuromuscular blocking agent is divided is non-depolarizing, is divided into aminosteroid and and benzyl isoquinoline, benzyl iso. And benzyl group releases histamine. So first we need to see here that which are the benzyl group. So atrocurium is the benzyl group. Atrocurium is the benzyl group. Then cis-atrocurium is benzyl group. Then pancuronium is aminosteroid. Pancuronium is aminosteroid, and vecuronium is your aminosteroid. Aminosteroid. So definitely these two will not cause facial flushing, hypotension, or any cardiovascular fluctuation. So either atra or cis-atracurium, because both are benzyl isoquinoline. Cis-atracurium causes less histamine release. It is more cardiovascular stable. It is more potent. So less amount is given. So it is not causing as much histamine release as atracurium. So answer has to be atracurium. Answer has to be atracurium. Got it? Okay. Now, so this for this question, the answer was atracurium. Now let us see the next question. The next question which was asked was, let's say, a patient undergoing surgery is administered succinylcholine along with muscle relaxant. So patient was given succinylcholine along with muscle relaxant. I'm not understanding this point, along with muscle relaxant. But the patient was given succinylcholine. And shortly after giving succinylcholine, the patient developed bradycardia and hypotension. Well, we have discussed the side effects of succinylcholine. So what are the side effects of succinylcholine? Succinylcholine, whenever I teach in my lectures, in QRP lectures, everywhere I said, it is mirror image of acetylcholine. So when we give succinylcholine, we always have a atropine syringe in our other hand. Because since it is mirror image of acetylcholine, it can go to the cardiac muscarinic receptor attached like acetylcholine and can cause bradycardia, right? So bradycardia is managed with atropine, and here the answer should be atropine, right? So bradycardia, hypertension was most probably due to bradycardia. So we will first give atropine, and if the blood pressure is not increasing, then we will think about any other drug. But initially, we will give atropine. Okay. So remember, succinylcholine can cause bradycardia, the side effect, and as the management of bradycardia, we always have atropine ready with us. And the older anesthesiologist used to mix atropine with succinylcholine to prevent this bradycardia to happen, right? So bradycardia would be atropine would be the answer. Now coming on the next question. Okay. The question was on mechanical ventilation. Now the question was, a critically ill patient with COVID-19 is admitted to the ICU and is currently on mechanical ventilation. His PaO2 and FiO2 ratio is 100. So PaO2 FiO2 ratio is 100. So he is in severe hypoxemia. He is in severe ARDS, right? Indicating severe ARDS. Which of the following is most appropriate ventilatory strategy? So in ventilation, we have talked about that in severe ARDS, we go for lung protective ventilation. We go for lung protective ventilation, right? So when we are going for lung protective ventilation, now what is the strategy? The strategy is to give the low tidal volume, right? So tidal volume should be low tidal volume. It should be between, let's say, 6 to 8 ml per kg body weight. Okay. And the PEEP is titrated according to the requirement of patient. So let's see the options. High PEEP, low tidal volume, high PEEP, high tidal volume, low PEEP, low tidal volume, low PEEP, high tidal volume. Now, PEEP is adjusted according to the requirement of the patient, but ARDS network, what they suggest कि for severe ARDS patient, we have to go for high PEEP, low tidal volume, right? This should be the ventilation strategy because the oxygenation is very poor and PEEP would help in increasing the oxygenation because patient is already has a PaO to FiO2 ratio less than 100. So in this case, we have to give high PEEP to maintain the oxygenation of the patient. Now, if this would not work, then in severe ARDS, when low tidal volume and high PEEP high PEEP does not work, then we go for your prone ventilation. Then the next step becomes prone ventilation. So prone ventilation was not in the option. The answer has to be high PEEP, low tidal volume. High PEEP, low tidal volume, right? Okay. Next. So, patient diagnosed with functioning adrenal tumor, scheduled for surgical excision. Which of the following drug is most appropriate to be administered preoperatively and intraoperatively to control the blood pressure and prevent hypertensive crisis? So, pheochromocytoma, we all know, causes the release of catecholamine in the blood, and we need to have a proper preparation of the patient 2 weeks before taking the patient for surgery, and we always start with the alpha adrenergic blockers. We start with alpha adrenergic blockers, right? So, and once a proper alpha adrenergic blockade has been established, then we go for the beta blocker 3 to 4 days prior to surgery. And intra-op hypertensive crises are managed by the short-acting hypotensive agents like sodium nitroprusside, etc. So, what would be the best answer in this? Now, clonidine is an antihypertensive, but it is a central sympatholytic, not very frequently used in managing the hypertensive crisis in pheochromocytoma. Phenoxybenzamine or phentolamine. These are the best one which we use 14, let's say 13, 14 days before taking the patient for surgery as a non-selective alpha 1 and the alpha blockade. The phenoxybenzamine is non-selective alpha blockers, and this is first given to the patient, and once the serum level is built up, then 3 to 4 days prior to surgery, a beta blocker is added to control the heart rate. Beta blocker is never added before phenoxybenzamine, the alpha blockers, right? Labetalol can also be used. It's a non-selective, alpha one, alpha and beta blockers, but phenoxybenzamine would be most appropriate to be used in pre-op period and pre-op period for preventing this hypertensive crisis. The word was prevention of hypertensive crisis. So phenoxybenzamine would be the best answer. Sodium nitroprusside is mostly used intra-op as a short-acting agent and to prevent the hypertensive crisis in case when the other drugs are not working properly. So in that case, the answer has to be phenoxybenzamine. Okay, so here we will use answer would be phenoxybenzamine. If phentolamine would have been there, there could have been a little confusion, but then also my answer would have been phenoxybenzamine because phentolamine is a shorter acting one. Phenoxybenzamine is a longer acting one. Just the only thing we need is proper monitoring of the patient. So answer is phenoxybenzamine. Okay, next question. Now this is a question on perioperative fluids. Which intravascular crystalloid in excess can cause hypercaloremic metabolic acidosis? So for perioperative fluid supplementation in our lecture, we have discussed that today we are using balanced salt solution. The isotonic crystalloids is what we are using, but balanced salt solution. Why we are using balanced salt solution and not preferring very commonly used fluid, which was previously used, normal saline? Because normal saline has 154 millicoulomb sodium and 154 millicoulomb chloride. It has a very high chloride. Normal serum chloride level is 111 millicoulombs and it has a very high chloride. So when we are giving a massive infusion of normal saline, the serum chloride level increases. Serum chloride level increases. And when the serum chloride level increases, the bicarbonate level decreases. The HCO3 level of the blood decreases. The chloride counteracts the bicarbonate. So when this happens, what happens? The metabolic acidosis results, right? When bicarbonate would decrease, metabolic acidosis will result would be result. So hypercholoremic metabolic acidosis is due to over infusion of normal saline. Normal saline would be the best answer here. Well, Ringer's lactate is balanced salt solution and it doesn't have more than 111 millicoulombs of chloride, which is near the serum chloride. Dextrose doesn't have at all chloride, so it will not cause any of this sort. DNS is creating a little confusion. It's a dextrose normal saline combination, but normal saline, pure normal saline would be better answer. I would choose normal saline better as a better answer over DNS, right? DNS also has just a dextrose added, and it is also the normal saline mixture. But normally, normal saline would be the better answer to give in this question than DNS, right? But of course, a massive infusion of DNS can also create a problem. But right, so answer has to be normal saline. Okay, okay. Now, next is a patient administered sevoflurane and succinylcholine for abdominal surgery, developed post-operative muscle rigidity. So patient developed post-op muscle rigidity. So muscle rigidity or increased carbon dioxide, all these in perioperative period is pointing towards malignant hypothermia. And the two drugs which was given is sevoflurane and succinylcholine, both of which can precipitate malignant hypothermia, right? So these can precipitate malignant hyperthermia, right? The succinylcholine and sevoflurane. And patient develop postoperative muscle rigidity, which is one of the early feature of malignant hypothermia. So what would be the drug of choice for managing malignant hypothermia? Answer has to be dantrolene. So dantrolene has to be the answer, right? So dantrolene is used for managing. And this is every year being asked. Malignant hypothermia is every year being asked. So even if I am having a confusion, they have not given an increased carbon dioxide or hypothermia. Well, SIVO and succinylcholine resulting in post-op muscle rigidity, I would think for malignant hypothermia. The two reasons: one, it is most commonly asked topic, and the other things does not correlate well with it. That why a post-op muscle rigidity will happen, right? So answer has to be malignant hypothermia. And answer, the drug of choice for managing malignant hypothermia, needless, I know all of you must be knowing, is dantrolene. Okay, now next question. A 2 years old child choked on peanuts. What is the immediate management? So choking, the question on choking, and the child is 2 years old. For less than 1 year old, we do the back slaps. And above 1 year, we do something called Heimlich's maneuver, which is abdominal thrust. So any choking case, only you have to see two things. What is the age? If the age is less than 1 year, right? If the age is less than 1 year, the answer would be back slap. And if the age is more than 1 year, the answer has to be the abdominal thrust. And if a choked patient goes into cardiac arrest, then only the chest compression, right? Then only we have to answer the chest compression. So answer has to be abdominal thrust. Okay, so these were my 7 questions which I got. Any more you want to contribute? I would be very grateful. Please put in the chat box and contribute. ओके अच्छा, रैपिड राइज इन टेम्परेचर था, फिर तो और क्लियर हो गया. अगर रैपिड राइज ऑफ टेम्परेचर था इन द क्वेश्चन ऑफ द sevoflurane and succinylcholine, muscle rigidity and rapid rise in temperature, rapid rise in temperature, thank you, right, rise in temperature. Well, अगर ये था guys, तब तो एकदम clear it is malignant hypothermia. It's crystal clear malignant hypothermia. Answer has to be dantrolene. Okay, फिर someone is saying that esmolol was in the option for the pheochromocytoma patient, right? Esmolol was in the option, not labetalol. So esmolol, I am adding esmolol. Well, then again, it is more clear that phenoxybenzamin has to be the answer because esmolol is a short-acting agent. Pre and intra, perioperative management के लिए anything asked, and that also to prevent hypertensive crisis, not to treat hypertensive crisis. Then answer cannot be esmolol or sodium nitroprusside, and clonidine is not so commonly used. So it's clear phenoxybenzamin. It is clear phenoxybenzamin. Okay, so now, so question was 2 years old child unresponsive. Cool. Then the answer will change. Thank you so much for providing me with this. So 2-year-old child choked on peanut, unresponsive. Then definitely, guys, the answer will change. If someone is unresponsive, I'm changing my answer. The answer has to be chest compression, nothing else. Chest compression. Okay. So if it was unresponsive, the answer has to be chest compression, no doubt. So, guys, during choking, till the person is responsive, less than 1 year, we do the back slap, and more than 1 year, we do the abdominal thrust. And once the person becomes unresponsive, we immediately start the chest compression. And every time after, let's say, 2 minutes of chest compression, we check for the oral cavity for the choked material to come in the oral cavity. And again, we continue with chest compression. Yeah, then the answer I'm changing, it is chest compression. So 2-year-old child choked on peanut has become unresponsive. What is the immediate management? Chest compression. Okay. Okay. Then guys, sixth question, I'm repeating all the answers. Patient administered sevoflurane for abdominal surgery, developed postoperative muscle rigidity, drug of choice. And you have added for me the rapid rise in temperature. And the question is crystal clear. Malignant hypothermia, answer is dantrolene. Wonderful. So a very clear question. Intravascular crystalloid in excess cause hypercaloremic metabolic acidosis. The answer has to be normal saline. Answer has to be normal saline, right? I hope all of you have answered because in my perioperative fluid topic, I told you normal saline has gone out of the favor because of the huge chloride content which it has, leading to metabolic acidosis. And we do not prefer it over balanced salt solution. We prefer Ringer's lactate or plasma light nowadays because normal saline causes hypercaloremic metabolic acidosis, right? Okay, then a patient diagnosed, okay, we have discussed this. Functional adrenal tumor for perioperative blood pressure management and prevention of hypertensive crisis, phenoxybenzamin would be the answer, right? Then a critically ill COVID patient admitted to ICU, currently on mechanical ventilation. The PF ratio is 100, which is severe ARDS. So oxygenation is something we have to keep in mind. So definitely the lung protection, protective ventilation we have to do. So low tidal volume we have to give, but we have to give high PEEP. For severe ARDS, the ARDS network says you have to give high PEEP to maintain the oxygenation. And this is not maintaining, then we have to go for prone ventilation. We have to go for prone ventilation. So high PEEP, low tidal volume would be the answer. High PEEP, low tidal volume would be the answer. Okay. Now the second question, a patient undergoing surgery administered succinylcholine along with, I don't know, if you can correct, please, any one of you can, along with muscle relaxant. Succinylcholine itself is a muscle relaxant. So why it will be given along with muscle relaxant? So if please, if someone can correct it. Okay. Okay, tell me. Succinylcholine along with, because the question was for prevention of hypertensive crisis, prevention. So what was prevention? Esmolol, etc. are used in hypertensive crisis, not for prevention, right? So if the blood pressure is rising alarmingly, then we add esmolol, we add sodium nitroprusside. These are the drugs which we keep prepared, right? It was for prevention. Yes, phenoxybenzamin is used mostly preoperatively to prevent the hypertensive crisis. I agree with you, right? To prevent it. Okay, can anyone add in this that what succinylcholine was given along with what? So Vikas, can you add? Shiva, Vikas, Sona, can you add that what succinylcholine was given with what? If any one of you can remember. But the patient developed bradycardia, and we have already discussed that succinylcholine is notorious in causing bradycardia, and second and third dose, 80 to 90% time causes bradycardia. And we always have an atropine syringe ready. But patient, if doesn't respond to atropine, then we go for other drugs, right? So here answer has to be atropine. So answer will be atropine, right? If you remember, please put in the chat box. A patient, so this we already discussed. Patient after giving neuromuscular blocking agent develop facial flushing. Facial flushing, histamine release. Histamine release, benzyl isoquinoline. Atra and cis-atra both an option. I would choose atra because it releases more histamine. It releases more histamine, right? So these were my, let's say, 7, 8 questions which I got. If you can contribute more, I would be very grateful. I can put in the chat box. I will add it in my let's say slides before finally let's say before final putting it in our app, before final recording and putting it in the app. So my best wishes for your result. I know all of you have worked tremendously hard with all your duties and all, and my best wishes with you and my blessings that you all secure a very good rank, right? Thank you.
Most of the questions that I have received were already discussed in the classes, I would say almost all of them. Just the language was a little different, just different enough to confuse you, but I hope not different enough to not give you the correct answer. So, should we begin? So, should we begin? So, starting with the first question here. Please, all of you, I would, just announce it initially only that this is a recall session, which is very, very, very fresh after the exam. So, even though we have received a very good recall questions, but if there are any discrepancies from what you saw in the exam, any change in options that you would want to recommend, please write it there in the comment section. It is very important to make a proper recall so that we know exactly what questions were asked. So let's begin. I hope you got all the drama questions correct, because I can say it is 100% discussed in the class notes. Thankfully, not a single question that I saw was out of the regular class notes, I would say. So the first question here: a patient presents with grouped pruritic papillovesicular lesions over the elbows, knees, and the buttocks. She has known gluten sensitivity. Direct immunofluorescence from the perilesional skin shows IgA deposits. What is the most likely diagnosis? So, look at the things that the question is telling you. First of all, pruritic papillovesicular lesions. It is a papillovesicular disease, belongs to the vesicular group of disorders. So, that is where you have to think of. Elbows, knees, and buttocks means it is present on the extensors. So, itchy, vesicles present on the extensors. Whenever it mentions itchy, it is going towards the subepidermal group. So, this is a subepidermal disorder which is present on the extensors. Gluten sensitivity. That's a very, very important hint. The DIF shows deposition at the dermoepidermal junction. The dermoepidermal junction again goes in the favor of a subepidermal disease. And when you look at the DIF, this is a granular deposition. So that is what we can make out from the image, that this is a granular deposition. Question tells us IgA. So on the DEJ, we see a granular IgA deposition with gluten sensitivity, with lesions on the extensors. Is this linear IgA disease? Yes, it is itchy, but it is bulle. Yes, it has IgA, but that IgA is linear, it is not granular. So this is out. Bullous pemphigoid again will have itchy bulle. It will have deposition on the dermoepidermal junction, but it will be IgG and C3, not this. So, for 1 second, even if you ignore gluten sensitivity, you still can rule out the others. Pemphigus vulgaris, absolutely not. The DIF is not matching. The clinical scenario is not matching. So, the only answer, even by elimination, that remains is dermatitis herpetiformis. It presents with the entire clinical vignette as mentioned in the question. Itchy papillovesicular lesions involving the extensors, no mucosal involvement. Patient has lean granular IgA deposition at the dermoepidermal junction. There could be association with gluten sensitive enteropathy. The next investigation that you do is anti-TTG, which was okay. So linear IgA. The option was epidermolysis bullosa. Okay, okay. So even if it was epidermolysis bullosa, that is also depends whether it is epidermolysis bullosa acquisita or congenita. Acquisita can show DIF positive, but the lesions will be non-itchy bulle. DIF will be different. Again, very, very, very different. So whether it was epidermolysis bullosa or it is linear IgA disease, it's out. If it is congenital epidermolysis bullosa, then anyway the DIF is negative in congenital EB. You should always know there are two types of EB, acquisita and congenita. Anyway, so This is either way out. This is out. This is out. The correct answer here is dermatitis herpetiformis. Next test, anti-TTG, which was asked in the exam last year. So this is a almost direct pickup question from the NEET PG 24. It's a direct repeat, I would say. So the correct answer here is option A. Coming to question number 2. A young girl presents with non-pruritic hyperpigmented lesions over the elbow, knees, and the buttocks. On examination, hair appears dry, sparse, lacks luster. Which of the following will be the next step in the investigation? The image here shows us multiple papules, which may be skin colored as we can see in the image, or if the question tells us that these are hyperpigmented, then also it is okay. They are present on the elbows, knees, and the buttocks. That means lesions are present on the extensors of the joint surfaces. So these kind of papules on the elbows and the knees in a child, hair is dry, sparse, lacks nutrition. This goes in favor of malnutrition. In malnourished children, this is generally the status of the hair. So the clinical scenario tells us that the patient may be suffering from malnutrition. Then it tells you that lesions are present on the extensors. Where does it take you? Tell me, where does it take you? Follicular papules or maybe whatever papules. If it doesn't mention follicular, it's okay. But these papules present on the elbows, knees, and the buttocks with malnutrition in the form of hair being dull, coarse. Yes, one B12 and B1 was in the options. Was this question asking which deficiency is seen, or was this question asking what would be the next step in the investigation? Because there is a slight discrepancy in the question received here. Some students say that it is asking us what would be the next step in the investigation. Some are saying that there would be deficiencies that was asked. So if it is asking what is the next step, what is this? First of all, tell me the diagnosis. What is the diagnosis here? The diagnosis here is what we call as phrenoderma. So the diagnosis here is phrenoderma. And phrenoderma happens due to deficiency of vitamin A, B, E, K, and essential fatty acids. So this is overall a patient who is suffering from malnutrition. Now, since vitamin A forms a very important deficiency that is a cause of phrenoderma, patients with phrenoderma will have symptoms of vitamin A deficiency as well. So a very important point that you have to do in these patients is when they come to you, you have to examine the eyes. You have to ask for symptoms related to vitamin A deficiency. Would you do vitamin D3 levels? Maybe in future course of action, if you are wanting to diagnose multiple nutrient deficiencies, you may do it. But would it be your next step? No. Would you do a skin biopsy? It's a clear-cut case, a clinical diagnosis. Skin biopsy is generally not needed in these patients. And these are non-pruritic. If this was pruritic, you could go in favor of lichen planus or whatever. But these are non-pruritic, so we don't need to do skin biopsy. Systemic examination, of course, you can do. In every patient, you are going to do systemic examination. But clearly, what is the next step? What is the next? Okay, there was no systemic examination mentioned, then okay, then we have a doubt over option D. We don't know what this option D was. This could be B12 levels, as is mentioned by one of you, Kaushik. So maybe this was B12 levels. So you anyway won't do B12 levels. B12 levels do deficiency does cause hyperpigmentation. So hyperpigmentation may confuse you, but it doesn't present as papules. It presents as a diffuse hyperpigmentation over the creases, over the periungual area. You wouldn't do B12 levels, you wouldn't do skin biopsy, you wouldn't do vitamin D3 levels. The next investigation would be a ophthalmological examination. And I want to tell you all, this is a NEET PG 22 and 24 question. So this question is like a PYQ picked up from 2 times in the last, 4 years of NEET PG paper. This is the importance of, doing these last year's papers and doing these important topics. That's what they ask. And a pretty straightforward question here. The only twist is that they are asking you what would be the next test. So you should know vitamin A deficiency is seen in these patients. You would do an ophthalmic examination. Question number 3. A 20-year-old presented with non-progressive hypopigmented skin lesion since birth, shows white accentuation under Wood's lamp. Diascopy is inconclusive. What is the most likely diagnosis? Now, this is a little confusing question, I would admit. This is more of an INI-CT question. Whenever I take regular classes or rapid revision, I always tell you that when this question comes, these are generally the 4 options that they put together. They love confusing you with these options. But this question has multiple pointers that would help you diagnose. Let's write it. First of all, it says non-progressive. So there are no changes here. It is present since birth. And I don't know if non-progressive was written. Can anyone tell me if non-progressive was mentioned in the question? It may or may not be mentioned. I'm not sure about it. It is present since birth. It is non-progressive. The color is hypopigmented. That is something that you can see in the image also. It is hypopigmented and it is not white. So please remember, this is not white. This is not depigmented. It is hypopigmented. It shows a white accentuation under the Wood's lamp. Most of the white lesions would show a white accentuation under the Wood's lamp. Diascopy is inconclusive, so we don't need it. What is the most likely diagnosis? Is this nevus anemicus, indeterminate leprosy, nevus depigmentosus, or vitiligo? What do you think is the correct answer here? Non-progressive was mentioned. Okay, thank you. What do you think is happening here? First of all, vitiligo would not be present at birth. It will not be hypopigmented. It will be white. So these are 2 points that go against vitiligo. Now come to nevus depigmentosis. Nevus depigmentosis can be present since birth. I would slightly differ with the term non-progressive here because generally nevus depigmentosis increases in size as the age increases, because the size kind of increases with the age of the patient. As the skin expands with increase in height and weight, nevus depigmentosis may also increase. So this non-progressive would be a little confusing if it was mentioned in the paper. Hypopigmented matches nevus depigmentosis. A white accentuation on Wood's lamp matches nevus depigmentosis. So all of these goes in favor of nevus depigmentosis. Diascopy being inconclusive doesn't really take us anywhere, so it doesn't help with any other options. Indeterminate leprosy would not be present since birth. Okay, it would not be present since birth. It would not accentuate under Wood's lamp. So this is out. Nevus anemicus would show us findings on diascopy. Diascopy would not be inconclusive here. Secondly, there is no white color on Wood's lamp here because this is not a pigment nevus. Remember, this is due to vasoconstriction. So you would not have any finding on Wood's lamp because this nevus develops due to the vasoconstriction in that area. The skin is pale. There is no pigment problem, so there are no findings on the Wood's lamp. So nevus anemicus is out, indeterminate leprosy is out, vitiligo is out. What is the correct answer here? Correct answer is nevus depigmentosis. For all of you who have given the exam, you should be okay. You need not eliminate. You just want to know the correct answer. But for all the others who would be watching, who are going to attempt future exams, you should know how to rule out the other options as well. So the correct answer here is nevus depigmentosis because this fits in the criteria. This fits in this hypopigmented image as well. It was very important to rule out vitiligo. Remember, vitiligo is white. V vitiligo, V white. Don't go for the W's. White. So vitiligo is white. It can never be hypopigmented lesion in vitiligo. Now, question number 4. A lady presents with oral lesions, complains of burning sensation on eating hot spicy food. Which of the following drugs can exacerbate it? Okay, so this is an oral lesion with burning sensation. That could be multiple things, but what is the image showing us? Look at the image. What is the image showing us? The image is showing a violaceous lesion with lacy white reticulate stria on the surface. So what is the image showing us? A violaceous lesion, lacy white reticulate stria on the surface, and when you look in the lesion, you would see some erosions as well. And it is these erosions which would cause the burning sensation on eating hot spicy food. So where does this diagnosis take you? Where do you see violaceous lesions with lacy white? 6 months is for this question, Dr. Aisha. It is for the oral lesions. Okay. So this complains of burning oral lesions since 6 months. You mean this is what was mentioned? And now she complains of burning sensation on eating hot spicy food. What drug can exacerbate it? So what is the image showing you? Lacy stria, erosion. Very good. The diagnosis. What is the diagnosis? Diagnosis here is erosive lichen planus. The diagnosis here is erosive lichen planus. Classic image, classic history that you are getting in the question. Now, what are the drugs that can exacerbate it? For LP, what are the exacerbations? Mercury filling in the teeth can exacerbate it. A hepatitis C infection can exacerbate it. This is an AIMS exam question. And thirdly, drugs can exacerbate it. What are the drugs? The most important group of drugs that exacerbates LP is antihypertensives. So this is the most important group that exacerbates LP. What are the drugs that come here? The two common causes here are your ACE inhibitors and beta blockers. Second, some heavy metals. Mercury I've already mentioned. Gold can increase it. Thirdly, antimalarials like chloroquine can exacerbate LP. So these are the common triggers that can increase LP. So fourth option is fluconazole I'm getting here. So fourth option is fluconazole. So these are the exacerbations. Mercury filling, which is actually a heavy metal only as mentioned here. Infection like hepatitis C, already asked in the exam. Drugs like antihypertensives, ACE inhibitors, and beta blockers. So these are the causes. Now, in the question fluconazole, I haven't told you. Ciprofloxacin, I haven't told you. Lithium exacerbates psoriasis. This does not exacerbate lichen planus. The correct answer here is option A, that is beta blockers. Then question number 5. A patient presents with photosensitivity, freckles over the face, upper arm, chest. So what is it telling you? Photosensitivity, there is a problem with the sun. Freckles, which are again present on the sun exposed areas. History of 2 basal cell carcinoma, so there is increased risk of skin cancers. What is the pathology involved? This is again a NEET PG 2024 direct repeat. What is the pathology involved? What do you see? Photosensitivity, freckles, increased skin cancers. Where does this take you? This takes you to a diagnosis of xeroderma pigmentosum. This takes you to a diagnosis of xeroderma pigmentosum, right? And what is the defect here? Homologous recombination repair, nucleotide excision repair, DNA mismatch repair, base excision repair. Tell me, what would be the correct answer here? The correct answer, the defect that we see in xeroderma pigmentosum is the nucleotide excision repair. So this is the correct answer here. I hope this was an easy and simple one for all of you. This is a direct repeat from the NEET PG 2024. Now, coming to the 6th question, this I hear was a bit confusing for some of you. And I would say this question is from INI May 2025 exam. Similar question was there in the INI. Last year, this question was in the FMG, and before that, also in INI across different exams as multiple choice or whatever. They love asking this. So, this is a question which says a patient presents with lesions on the right cheek, scarring in the center, chest x ray shows apical lobe calcification. Which of the following is the diagnostic investigation? So, what you see in the image, you see that there is this erythematous lesion on the cheek. The question says there is scarring in the center, as we can see in the image also. Plus, chest X-ray shows apical lobe calcification, which may go in favor of pulmonary tuberculosis. So, if a patient has pulmonary tuberculosis and they have a lesion with scarring on the face, where does that take you? This takes you to a diagnosis of lupus vulgaris. Lupus in itself means scarring. So a patient with systemic tuberculosis can, have the disease on the skin as well. So generally, this is like vice versa. A patient with skin TB comes, they ask in the INI, what is the next investigation you would do? You would do a chest X-ray to look for internal causes. Now, they have already given you that chest X-ray shows you tuberculosis. Skin shows you tuberculosis. What is the diagnostic investigation? Diagnostic investigation in lupus vulgaris is skin biopsy. So diagnostic investigation here, which is not mentioned, probe test, slit skin smear, Montu test, PCR is not mentioned. Remember, probe test we don't do here. Slit skin smear is done in leprosy. It is not done here, so you have to rule out leprosy. Montu test is not diagnostic. So this is not a diagnostic investigation. What is a diagnostic investigation? You can do PCR that can sometimes help you diagnose even if your biopsy findings or X-ray findings are inconclusive. So the correct answer here is option A, that is PCR to help in the diagnosis. I hope all of you got this correct. A lot of you were looking for biopsy in the options, but remember, sometimes you have to choose the best answer. So this was the best answer in the situation. You would do a PCR to diagnose tuberculosis here. Coming to question number 7. A farmer presents with a painless swelling over the foot. So this is a painless swelling, multiple sinuses, serous discharge containing black grains. A KOH mount is sent from the discharge sample based on the clinical presentation and the image provided. What is the most likely finding on KOH examination? Tell me, is this how this question was framed? Yes, there is a farmer with a swelling on the foot with discharge containing grains. So that's a typical triad. That is what we read as the triad of which disease? This is what is showing in the image also. You see there is a swelling. You see that there are discharging sinuses and there is a discharge coming out of it. So this is the typical triad of the disease, which is mycetoma. All three components are present in this patient. Now mycetoma could be eumycetoma, where it is a bacterial fungal cause, or it could be actinomycetoma where a bacteria is causing it. If you remember, this was a similar question asked last year in the exam as well. There, the diagnosis was based upon the gram stain. Here, they have done the KOH. So basically, it is again a repeat question. I can't even tell you how many times this has been asked in the NEET PG in the last 5 years, almost every year. Now, what would you get? Small spore pseudohyphae? No. Tender spectate with flowering type? No. Arthrospores? No. You would definitely get septate hyphae with 4 to 5 micron width. So the correct answer here is again option A. You will see septate hyphae in the KOH. Is this clear with everyone? Is this the question that was asked? Any change in the options? Okay, good. So the last question that we have in dermatology here, patient with facial pain, vesicles around the mouth. Zinc smear reveals multinucleate giant cells with intranuclear inclusions. So there is pain, there are vesicles. Zinc smear shows MNGs with intranuclear inclusion. What is the most likely diagnosis? Now, again, this is a NEET PG 2020 recall. This was recently asked in the INI May 25. This was recently asked in the FMG July 25 exam. Okay, so this is how many times this has been asked. Pain with vesicles around the mouth with zinc showing MNGs. this goes in the favor of this being a herpetic infection. A clear, straightforward question here. What is the most likely causative agent? CMV would not cause vesicles. HSV can cause. EBV would not cause vesicles. It will cause either infectious mononucleosis or oral hairy leukoplakia in a patient with HIV. Both is not mentioned here. Adenovirus would not cause pain and vesicles. So the correct answer here is option B, that is HSV, because this is the one which causes herpes labialis that is mentioned in the question here. Okay, so this is the correct answer to this question, herpes simplex virus. Now there's one more question here. Please let me know if this is the correct question. This is question number 9. A patient presents with pustular lesions on the hand. Gram stain of the smear shows gram-positive organisms. Culture shows McFadden's positive reaction. Which of the following is the most likely causative pathogen? Now, pustules on the hands could be in anything. That doesn't really take you. Okay, just a second, I'm getting a point here. This mentioned trigeminal neuralgia. Okay. And it was a 12-year-old child. Okay. Were there vesicles mentioned in the question? Were there vesicles mentioned in this question? Acha, so you are saying this is a patient who works in a abattoir. That means he works with animals. He works in an area where he's at risk of zoonotic infections. Presents with pustular lesions on the hand, which have now converted into an ulcer. Again, abattoir just takes you to a zoonosis. Pustular turning to ulcer could be any disease. Gram-positive organisms could be any bacteria. But what is the catch here? The catch here is the McFadden's reaction. Where is this positive seen? Very simple one. Is this with Staph aureus? No. Corynebacterium? No. Strep pyogenes? No. Well, Staph aureus can have pustules. Strep pyogenes could have pustules. But which one shows McFadden's positive? That is option D, Bacillus anthracis. So with this, we finish our dermatology questions. Thank you for your inputs. I really hope that all of you got this one correct. This is a very classic anthrax. Since patients work with hands, this is where the infection generally presents. You have small pustular lesions forming a rim around the eschar. That's a typical appearance of a Bacillus anthracis. So in this patient, you would have an ulcer in the center covered with eschar and small pustular lesions surrounding it in a rim. So this is anthrax. All the best for your result. Relax, chill, enjoy. You have earned it and you deserve it. And I sincerely hope that you get the result that you want and the branch of your dream. Thank you so much. We conclude with dermatology discussion.
So, a very good evening to my dear students who are attending this session and who will be looking at me, talking to me later when they are free. So, friends, a very good time to talk to you because now you are relieved, you are free, you are done with your NEET PG. So, guys, very happy moment for all of us. I'm sure you've done very, very well in your examination and you are kind of happy. Yes, got to know that exam was not very easy. Yes, it was moderately tough, but somebody who has read with us at DocTutorials, I'm sure he must be a happy student. So in Ofthal, I could collect almost 10 questions. Two of them was integrated questions like with medicine, with biochem. So we were expecting some integrated questions. But this time, ophthalmology was not the regular thing that they ask in the NEET PG and INSET exam. We didn't get the image based questions on retina. The fundus images were not there. Routine cataract questions, routine glaucoma questions, they asked nothing about that. So it was little unusual. This time it was little unusual. But again, good part is that we have discussed everything in detail in the DT app. So Doctor Tutorials app has covered almost everything. I would say there's only one bouncer question for the students because that question we do not generally discuss in the live sessions. Otherwise, all the questions are doable from your PYTs, from your PYQs. And the options they have given us are really beautiful options so that I don't think students have got less number of correct answers in ophthal. So let us start talking about ophthalmology. This is the first question. It is a picture based, image based question, and they have asked about 15-year-old girl with painless swelling, which is gradually progressive. Can you see there is a swelling? There is a mass on the lateral edge near the eyebrow. So most of the students got it correct because they knew that this is a kind of dermoid. It's a dermoid cyst or a dermoid tumor. Okay, few students were confused and they marked the answer to be lacrimal gland mass. So friends, lacrimal gland tumor can also present like that. Definitely, because the lacrimal gland is situated in the supratemporal part of the orbit, but definitely you will have a proptosis, you will have a abnormality in the eyelid, as in a S-shaped eyelid. And also, we don't have lacrimal gland tumors so common in children. In children, the lacrimal gland tumors are so uncommon. So the best and the easiest spot diagnosis, I would say, it is the dermoid tumor. I hope this was the question and these are the options given. Hemangioma, totally out. Hemangioma doesn't present like that. It will give you a proptosis and we don't have any proptosis here, right everyone? So this is a clear cut question about the dermoid cyst or the dermoid tumor, you can say. All right, so let's move on to the next question. So this is the bouncer, but if you use your common sense, if you use your brain, you can answer this question very easily. Guys, they have given you a question which mentions about Gatte. Have you ever read Gatte in trachoma? Have you ever read Gatte in herpes? So we have read these two topics very in detail. Have you read about these things in this topic? No, absolutely not. So I would say if you do not know anything about Fuchs endothelial dystrophy, which is actually the correct answer here, you should be able to answer by ruling out the other options. Keratoconus absolutely does not have Gatte. What actually Gatte are, guys? This is excrescences in the Descemet's membrane, usually seen in old people who do not have a good healthy corneal endothelium. So there is loss of endothelial cells and gradually there is a corneal edema which lead to corneal opacity. Okay, so this is your Fuchs endothelial dystrophy. All right, but I would say somebody who has read the topic of cornea from DT app and who has read something from keratoplasty, you should be able to know what is this Fuchs endothelial dystrophy that I have discussed in detail with my students. Okay, so this is again a very doable question for our DocTutorials subscribers. Now, the third one. So there is a little discrepancy in the options given about the question on orbital cellulitis. Kindly read the question and please correct me if I am not correct here. Guys, I need your help here. Is the option which I am getting here is correct? So they are asking you what statement is correct regarding orbital cellulitis. So you know orbital cellulitis we have discussed. This is the most common cause of uh, proptosis in children. Yes or no? This is proptosis in children. But did I ever say that this is not seen in adults? I never said that. है ना? Orbital cellulitis, though it is very common in children, it is not very commonly seen in adults, but yes, it can be seen in adults. And for both of them, ethmoidal sinusitis is the most common source of infection. Okay, that is what we have read in children, but I never said that it is not seen in adults. Okay, so probably that was the confusing part for all of us. But if you have read orbital cellulitis, you should be able to know that this is not treated by topical antibiotics, guys. This is an orbital, this is an ocular emergency, so you have to admit the patient, you have to administer IV antibiotics. This is an emergency. Inflammation, it is going to the orbit, so how can it be anterior to the orbital wall? This is straightforward to know. Now you know there is a proptosis, you know there is an infection spread to the optic nerve, so vision is also gone and pupils are also not reacting properly. So this is half correct statement. There is a proptosis definitely, but the pupils are not normal, pupils are abnormal, and ocular movements are also gone later. So this is how you know it can happen. Understood, everyone? So please remember, this is one topic which is very nicely taught. Everyone should be able to answer the question on orbital cellulitis. Okay, everyone? Now let's move on to the next one. This is the fourth question, which I said a kind of integrated question. So this is about Marfan syndrome. Everybody can answer that the patient who has very long limbs, there is a diminution of vision because there is a subluxation of lens. We know ectopia lentis. So classically, we are talking about Marfan syndrome, a PYQ. Everybody know that there is a problem in fibrillin 1 gene. Okay, so this is an integrated question. You can say pathology, सभी चीजों का integration हो गया है ना. Pediatrics में भी discuss करेंगे. Everybody would be discussing, but the idea is the students should know what is the correct answer. All right, everyone. I think the options are also clear. Easy, everyone. Now, guys, my next question is the fifth question. I'm so sorry. This is the fifth question we have. It says that a 65-year-old male presents with white deposits on the anterior lens surface, which is seen during slit lamp examination. So what is the most likely diagnosis? Now here again, the students are confused. Some of them are saying that this is pseudo exfoliation syndrome, and some of them are saying that this is a glaucoma flecken. Okay, guys, you have to analyze what was the picture. If the picture is like that, if this is the kind of picture where you see the target sign, you remember we have read target sign in detail, the ring signs, yes, so this is the typical sign that we see in the pseudo exfoliation syndrome. So if this is the picture, this is target sign of pseudo exfoliation syndrome for sure. But suppose if they have given you this kind of picture where there is a little pupillary abnormality also, where you see pigments of the iris also stuck to the anterior capsule of the lens. So guys, this cannot be your pseudo exfoliation. If this kind of picture was there, this has to be glaucoma flecken, which is a very important expected question this year. I told you we may get a question on Vogue stride, so you have to tell me what was the exact question. Yes, anyone? So was it on glaucoma flecken, this kind of picture, or was that a pseudo exfoliation? Anyone, please, if you can help me with that. All right, so considering the students are saying this is more going into the favor of pseudo exfoliation, the whole idea is, guys, you need to understand what actually can be the options, right? You should be able to distinguish, okay? This is the whole idea. Okay, bacha. So what about the next one? The next one, it's straight a PYQ. You know, there was a question in your I set about intacs. The same question was there, है ना? But अब की उन्होंने क्या पूछा? They have given you the picture and they have asked you, where are you going to use this intacs? This is your intracorneal ring segments. You know, we have read in detail about keratoconus. One question I told you, there is a question on keratoconus. Yesterday night also I told you, keratoconus पे question आएगा. So we have got a simple question on keratoconus. I don't think there is any problem with this question. So keratoconus, ICRS, this was the question. ठीक है बच्चे, ये तो सबका सही हुआ होगा, है ना? I'm sure. Intacs के बारे में सबको पता ही है. Keratoconus was very expected question. Now the next question. So guys, this is one beautifully asked question. See, another integrated question with medicine. Rajiv sir will also be discussing this question. Okay, so let us see what was that. So it says there's a 15-year-old male having a sudden growth. The height is too much, 6'4", and there's a widening of jaw, large hands, everything, large. So kya hai ye? Can I say this is acromegaly, gigantism? Can I say that? Something like that. And there is also a visual disturbance and headache. So why I am discussing this question? Because this boy also has a kind of visual field defect. And what is that? Can I say this is a bitemporal hemianopia? Yes, this image was not given, but I'm just showing you, I'm discussing the question because this is very important. So can I say that this is a question on a pituitary adenoma? Yes, everyone. If there is a pituitary tumor, you can expect a bitemporal hemianopia and acromegaly, endocrinal disturbances is expected. You know, this is the question. I think everyone, this was the question. So the options here are very nicely given because almost everything, you know, is suggestive of the pituitary tumor here. But the best option here is this. There is no decrease in GH level after glucose tolerance test. You know, normally when you have a GTT, there's a decrease in GH levels. But here in pituitary tumors, which are going to compress your optic chiasma, the nasal fibers, which leads to your bitemporal hemianopia, it actually can cause no increase in GH level. So, right, this is very diagnostic. So, Hanji, this was a confirmatory, huh? Hanji, Dr. Abhinav, I have given the option of anterior orbital septum. This was there in the option. Okay? One of the option was elevation of IG even after glucose tolerance test. Elevation was there. Okay. There was a elevation in IGF-1. So I think then also the best answer is no decrease in GH levels. And to the best of my knowledge, this should be the answer. Okay. Chalo, so this was an integrated question, a lovely question. So guys, this was the only question that we got from our neuro-ophthalmology. All right. Now, another question, beautifully asked question. I would say again, this is from your PYT. We had so many questions in the past which were related to our cherry red spot. So if somebody is missing that, पिटाई होगी उसकी है ना, because you must be knowing, I have told you that cherry red spot, you have to remember everything. We have discussed so many times, so many things about neem and pig disease, Gaucher, Sandhoff, Tay-Sachs. I told you how to differentiate between them. You know, है ना, बहुत बार हमने डिस्कस किया. We have discussed Tay-Sachs disease also in detail. So nobody should know, you know, make this wrong. So let me quickly tell you the answer. The question was on cherry red spot on the macula, and this was about a very small boy, है ना, and there was a deficiency of this enzyme. So you know, hexoneminidase deficiency is there in, you know, your Tay-Sachs disease, your Sandoff's disease. So both of them, GM2 ganglioside accumulation, very simple. They have not mentioned about A or B, तो और भी simple हो गया है ना. A और B का mention ही नहीं किया. A होता तो this has to be Tay-Sachs, B hota, A and B both hota, it has to be Sandoff. So they have not mentioned probably. Was it mentioned, beta? Was it mentioned? I don't think it was mentioned. So simply the answer is GM2 ganglioside. Okay. So you should know everything about this Tay-Sachs, the cherry red spot, and all the DDs related to that. So the last question is another little ectopic question, though we don't expect such questions in Squint because we have so much to discuss, to ask students, but they have given you a very simple question. I am sure even if you do not know this, you should be able to answer. Okay, something was like this was given. There were two different images and which were captured in one frame, or probably some students are saying there were two images like that. Okay, one was from simultaneous perception, one was from fusion. So common sense says that this cannot be just one thing. Yes or no? You know, they are giving you every option which has two things together, either fusion or stereopsis or fusion or simultaneous perception or whatnot. So if you use a little of your brain, you should be able to answer that this is, if they have given you this kind of picture, the first one is simultaneous perception, where the brain sees two different images and the brain is able to capture these two images formed by two eyes into one frame. Okay, this is your simultaneous perception, that brain is able to see these two images as two different ones. Now what is fusion? Fuse matlab kya hota hai? Fuse karna matlab kya? There is the same image, but they are different in little identities. Little things are different in these two images. One rabbit doesn't have the flower, one rabbit doesn't has the tail. So if you're able to fuse that, this is called as fusion. So if you go back, the best answer here should be simultaneous perception and fusion, है ना. Stereopsis तो हमको पता ही है, English में पता है ना, but stereopsis means depth perception. So we don't talk about depth perception here. Depth perception कैसा होता है? You see the same picture from different angles. यहाँ से देखो, so you're able to perceive the depth here. So this was it. This is not stereopsis. These two are simultaneous perception and fusion. हाँ जी, two images थे ना. हाँ जी, Dr. Alka. So I got to know that there were two images. So if you use a little of common sense, I'm sure nobody would get this wrong, है ना? So like I am a happy educator today, are my children also happy doing ophthal questions? I'm sure most of the students got all correct options. But guys, I would request if you have something more to add on, because there are less number of questions what we expect in ophthal, at least 12-14 questions should be there. If you get more questions, if you remember something, please write to me at DocTutorial site so that we can make a more constructive and more relatable recall session, so that your juniors would be helped and you will prepare better for the next INI set exam if you're planning. So guys, that's all from my side, and thank you for sharing all the questions. We love you all at DocTutorials, and we want you to talk to you, interact to you when you are free later. Take a good night's sleep again today. Be at your home, relax and enjoy party time, beta. Okay, so bye bye from my side. That's all from ophthalmology. Thank you very much.
Start.
Recording in progress.
Okay, I think we are live. So very good evening to all the students who are joining me right now. Your exam is done. First thing you need to understand, exam is done, right? So it's our human brain tendency that we tend to remember the atypical things, wrong things we have marked, or unusual things more. Easy things that you marked easily, they would not be registered in your brain. So your actual score, your actual result will be better than what you are thinking by now, right? And everyone makes silly mistakes. So my advice to you, don't fall prey to these workings of the brain. Whatever had to be done has been done. You all have done well. Coming to my subject, I'll not take much time because you have other subjects also lined up. So I will try to finish in the next 10 to 15 minutes. Pediatrics. Pediatrics this time was slightly on the tougher side, atypical. The usual things like milestones, pneumonia, diarrhea were not frequently asked. Emphasis was on CKD this time. There was emphasis on vaccines as before, and there was lysosomal storage disorders. Uh, Topics must not be missed before the exam. I had discussed at multiple forums on Instagram and social media, at YouTube of DocTutorials, and I had said, please go through the lysosomal storage disorders, go through the metabolic disorders, and this time there were at least two questions from that, right? And they were all solvable. All you need to remember is the keyword. Let us start with the discussion first of all. We'll be starting with the discussion. I hope I'm audible and visible to all of you because I can't see my own face. So I'm assuming that I'm audible and visible to all of you, right? So let us start with question number one. A 10-month-old boy presents with fever, recurrent oral ulcers, and recurrent infections. Laboratory investigations revealed reduced B cell, T cell, and NK cell counts, along with reduced adenosine deaminase level. This is the keyword. If they say recurrent infection and reduced adenosine deaminase, there is no other diagnosis which should come to your mind. Which of the following is the most likely diagnosis? The most likely diagnosis in this question is D, that is severe combined immunodeficiency. Severe combined immunodeficiency, also called as SCID. You need to understand that SCID is a combined B and T cell defect. It is a condition which is combined B plus T cell defect. So it has both B cell as well as T cell defect which is present. And these patients will be having increased risk of viral infection which will cause oral ulcer, increased bacterial infection, and not just that, increased fungal infections will also be there. There are many varieties of SCID. There are two broad varieties of SCID. One variety is called as the X-linked SCID, which occurs due to mutations in interleukin 2R gene. And second is the autosomal recessive form. In the autosomal recessive form, we have JAK3 mutation and we have adenosine deaminase deficiency, which is responsible. Western textbooks say that adenosine deaminase is the third most common according to Nelson, but in India, particularly northern and central India, this is one of the most common causes of severe combined immunodeficiency, and that is why this question has been framed for you. This is something that I have already discussed in my classes previously, and this is something that you should have marked correctly. The answer is SCID. Overthinking should be avoided. A gamma globulinemia will not have NK cell getting affected or T cell getting affected. The numbers will not be affected, and adenosine deaminase level will not be there. Dye syndrome can have T cell deficiency with secondary minor B cell deficiency. Alpha 180 deficiency does not present like that. So, answer to question number one is D. We have already discussed it in one of my classes, so I'm just sharing a snippet so that you understand that this is a previous year expected topic. Moving to question number two. Now, this was also a bit atypical question, and many people were of the opinion कि sir इसमें option. See, the answer will depend upon the options which have been given to you, right? So, question says 2-year-old unresponsive boy brought to emergency room with a history of choking due to peanut aspiration. What is the preferred management? देखो पीनट एस्पिरेशन करते हुए चोक हुआ है सो इट इज अ सस्पेक्टेड फॉरेन बॉडी कॉजिंग ऑब्स्ट्रक्शन ऑफ द एयरवे दिस हैज ऑलरेडी हैपेंड. Now, the important word to notice here is unresponsive boy. If the child is responsive and conscious, the management is different. And if the patient is unconscious, the management is different. What does Nelson say? What does SPARS guidelines say? They say that any conscious infant, because we don't have time and we want to do it fast, I am just giving you authentic references from standard books, not my opinion. So, Nelson says for conscious infant, conscious, not unconscious, not unresponsive, conscious infant, अगर infant है less than 1 year, तो what you will do? 5 back blows and 5 chest thrust alternately you will administer to the child. If it is a conscious child older than 1 year, you will be giving 5 abdominal thrust, which is also known as Heimlich maneuver. This is for responsive conscious child. If it is an unconscious child, if it is unconscious child with airway obstruction, begin CPR starting with chest compression. Some people said sir CPR tha, some people said nahi sir CPR was not there, chest compression was given, and chest compression, dear friends, is your likely answer. So answer to this question is D. Now people may think sir A nahi karenge, B nahi karenge, intubation to kar sakte hain. You need to understand that intubation, this is an unresponsive boy. He's prone to or almost gone into cardiac arrest. And in these patients beyond the neonatal period, starting CPR followed by giving ventilation along with ventilation. And while doing intubation, if you find some foreign body, you can remove it. But intubation is not the precedent here. The precedence is taken by the compression part because it is unresponsive child. Studies have shown that mortality is reduced when CPR is done before doing ventilation, before intubating the child, and intubation takes time. We don't want the child to go into cardiac arrest. All these are reasonings given in the textbooks, which I am telling you. Answer to this question without any doubt, if this was the question, is D, that is chest compression. Agar responsive word tha, 2-year-old child, then you would be giving abdominal thrust. That will be your answer. So answer depend upon the options given to you. It was a tough question, but if you know precisely, you will know the answer. Moving further, question number 3. A child presented with high-grade fever and seizures, what is the drug of choice for emergency management? Something I have already done. That any child with fever and seizure, if the duration of seizure lasts more than 5 minutes, whether it is febrile seizure or not, abort by benzodiazepine. Which is the benzodiazepine given in the option? It is diazepam which is given in the option, and that is your answer. So Grace Sharon is saying, sir, CPR was not in the option. If chest compression was there, that would be the answer. Right? Chest compression would be the answer. It is directly mentioned. I have shown you the references also. So third question, idiopathic seizure, drug of choice, benzodiazepine. Status epilepticus, first management, drug of choice, benzodiazepine. Febrile seizure or any seizure with fever where cause is not known, the drug of choice to abort the seizure, first drug to give, benzodiazepine. And which is the benzodiazepine given among the option? It is diazepam, and that is your correct answer. Moving further, we have question number 4. This is something, and I'm quite happy if you have solved DocTutorials Q Bank. Very similar question and explanation we have discussed in the DocTutorials Q Bank. So question number 4. Pregnant woman is diagnosed with HIV infection at 34 weeks of gestation. Her viral load was 1200 copies per ml. 1200 copies per ml. देखो क्या करते हैं, any HIV positive woman at or beyond 32 week, we check for viral load testing. If the viral load testing is more than 1000 copies, we call it as high viral load. So this lady is having high viral load. She was started on antiretroviral therapy. She delivers a normal kg baby, 2.5 kg term baby, 38 weeks. What is the appropriate postnatal prophylaxis for the newborn? This is not a gynae question. This is a pediatric question. बच्चे को क्या देना है? Now, बच्चे को management will be done by me, the pediatrician. What I will do? In any baby delivered by, according to NECO guideline, any baby delivered to HIV mother, you should be starting nevirapine from day one. If it is a high risk infant, what is a high risk infant? High risk infant will be the one where the pregnant female is not on ART despite a HIV, or she is having a high viral load. There are other criteria which I have discussed in my theory lectures. You can go through them. They are there on DocTutorials Q Bank, QRP, as well as the detailed videos. So pregnant female not on ART or having high viral load, you have to give combination therapy. And combination therapy is always in the form of nevirapine along with zidovudin, nevirapine along with zidovudin, and the duration will be for 12 weeks if the baby is breastfed. If the baby is on replacement fed, formula milk, then you give for 6 weeks. Yeah, otherwise, it is given for 12 weeks. And breastfeeding is not contraindicated in Indian setting. So answer to this question is A. That is your correct answer. So answer to this question is A. NECO latest guidelines you are supposed to remember. Some of the older guidelines where 6 months tak dete the, or you would be giving for 6 weeks in even in high risk baby. Those are discarded, and this is what examiner was testing in this paper. Right? So remember the funda: low risk infant where the mother is on ART, viral load is controlled, and viral load is not detectable. Baby is born. You start the baby on nevirapine alone. Dena to hai, but for 6 weeks. But if the baby is high risk, because mother is not on ART, high viral load, or just detected in the mother, there was no time for ART to act. In such patients, combination therapy is given. Or combination देंगे 6 weeks if breastfed baby, 12 weeks if for 6 weeks for exclusive for replacement fed baby, and 12 weeks for formula filled baby. Regarding duration of ARV prophylaxis, this is something you need to remember because इस पे बार बार question आ रहा है. This may be important for your future INI CET MCQ also. So duration of ARV prophylaxis, if it is low risk infant, you will be giving nevirapine daily, and that will be given for 6 weeks, irrespective of whether the child is on breastfeed or formula fed, that is top fed. If it is a high risk infant, then you will be giving nevirapine plus zidovudin. Nevirapine plus zidovudin, and that duration will be 6 weeks if formula fed, and it will be 12 weeks if breastfed. And which is to be preferred? Breastfed is to be preferred. So that is your answer. I'm taking some time because it's a concept which can be repeated in your future exam. Let's move further. Question number 5. A newborn is admitted to newborn ICU within 24 hours with severe dyspnea, respiratory distress. His chest X-ray finding is given below. What is the probable diagnosis? What is the probable diagnosis? Now in this photograph you can see that there is severe distress in the newborn period. Can you see that there are air fluid levels which are present on the left side? Left side you have the diaphragmatic hernia. Herniation of the loops causes mediastinal shift. There is some mediastinal shift also happening, and a newborn with distress. The first and important cause on chest X-ray that you will think of, that you will look out for, is congenital diaphragmatic hernia. More common on the left side, posterolaterally. Congenital diaphragmatic hernia is also known as Bowdalex hernia. These are the patients who require immediate intubation followed by nasogastric decompression. But urgent surgery will not be needed in these patients. And this is something that I have already discussed. It's a repeat question. It's a repeat previous year topic. I have already shown similar X-ray and discussed how you are supposed to remember. If you have seen that video, I have clearly said that newborn with the distress anytime, if there is air fluid level on the left side, which represents intestine, and diaphragmatic shift happening, it is congenital diaphragmatic hernia unless proven otherwise. You may ask कि सर बाकी क्यों नहीं है? Congenital lobar emphysema के अंदर there will be a localized emphysematous swelling, and it generally affects the लेफ्ट अपर लोब. So left upper lobe के अंदर black color का swelling होगा. Congenital pulmonary AV malformation can have a similar presentation, but congenital pulmonary AV malformation generally is localized again, and it does not have air fluid level, and the onset of distress is not as dramatic as seen in these children. So a combination of these features virtually rule out other options in this question. Dr. S square, it is difficult to do it clinically, but if you have a scenario where both of them are mentioned and some of the student sets are very similar, X-ray was there, this is congenital diaphragmatic hernia. CPAM, also called as CCAM, that will be relatively localized. It can be on the left side, it can be on the right side, and mediastinal shift is less prominent is that. Also, that will be, if it is involving this part, it will be restricted to this part. The upper part of the lung will be relatively normal. Look at this X-ray, you will find that the air fluid levels are reaching all the way till top and they are obscuring the entire pulmonary shadow. This is intestinal loop and nothing else. This requires a bit of experience to identify. Always go for likely common answer in the MCQ. Don't look for exotic answer. Congenital pulmonary malformation. In my 10 years of being pediatrician, I have seen one case. Diaphragmatic hernia, more than 100 cases I have seen. Right? So which is more common? Always go for common things in the exam. Let us move further. Yes. Again, would CDH child not be symptomatic at birth? No. CDH children can have symptoms at birth, or they may have a honeymoon period. What is honeymoon period? Honeymoon period means disease is there, but it is not manifesting. So basically, Nelson says marriage is a disease. Nelson does not say it, but what Nelson means, marriage is a disease. But people after marriage go for honeymoon, so they are very happy. Only when they come back, the signs and symptoms of marriage start. So that asymptomatic period is called as honeymoon period. So CDS can have a honeymoon period ranging from 6 to 24 hours before symptoms appear. And this is what is happening in this patient, right? So not every CDS will be presenting at birth. Okay. Right side chest black tha. Right side chest black tha. Right side chest black tha. It means there was not significant mediastinal shift. Again, you have to watch out for intestinal loop. If you have done your radiology class well, you would know how intestinal loop differs from air fluid level present in a pulmonary system. This is air fluid level if this was the X-ray. Again, it will come down to what exactly the X-ray was given. As far as I discussed with my colleagues, and I discussed with Khaleel sir also in radiology, sir was also of the opinion this is diaphragmatic hernia and nothing else, right? But if you have marked CPAM, let's hope that CPAM X-ray had been shown. Moving to question number 6. Question number 6. A 12-year-old boy with CKD presents with anemia. What is the drug of choice? Patients of CKD have low levels of erythropoietin and they are prone to get anemia. In the new ObGyn 10th edition, I had mentioned that role of erythropoiesis stimulating agent has been highlighted. And in my videos, recent videos on DocTutorials, I had mentioned ये आ सकता है, देखो मैंने स्टार भी लगाया है. So erythropoietin stimulating agent, that is recombinant erythropoietin or darbepoetin, are the therapy of choice in anemia patients with CKD. Are they available in our country? Yes, they are available. You need to add oral iron if there is iron deficiency, but iron alone will not be sufficient to produce any improvement in the HP level. So this is darbepoetin alpha. That's your correct answer. Moving to question number 7. A term newborn is delivered, umbilical cord is examined. Which of the following combination correctly represents normal level of vessels in the umbilical artery? 2 arteries, 1 vein. That is your correct answer. Is easy one. ये गलत नहीं होना चाहिए. So there are always 2 arteries and 1 umbilical vein. If there is single umbilical artery, that increases the risk of renal and cardiovascular malformations in the patient. Question number 8. Which of the following condition shows mode of inheritance as depicted? ये handmade photograph है. It has been shared by one of the students who said कि sir almost similar photograph had been shown. Now I'm not sure कि ये similar photo था कि नहीं. Now what you see here is this is a lady who's manifesting the disease and she's all the children are affected. This is an unaffected lady they've shown, right? So all the children are affected and male is not transferring the disease to the children, but female is transferring to every generation. So all children are affected, females are affected and females are transmitting to all the babies. This is mitochondrial inheritance. And mitochondrial inheritance is typically seen in patients with Kearns-Sayre syndrome, KSS. Prader-Willi syndrome shows genomic imprinting and the type of inheritance is non-Mendelian. Non-Mendelian होता है, उसको आप इसमें नहीं show कर सकते, right? There are certain inheritance which is called as non-Mendelian. So it shows genomic imprinting, uniparental disomy. This cannot be the answer. Achondroplasia autosomal dominant होता है. विलियम सिंड्रोम भी ऑटोसोमल डोमिनेंट होता है. अब ये कॉमन सेंस लगाओ, थिंक ऑफ इट लाइक दिस, देयर कैन नॉट बी टू करेक्ट आंसर्स इन द क्वेश्चन. विलियम सिंड्रोम या तो स्पोरेडिक है या ऑटोसोमल डोमिनेंट है. Achondroplasia is also autosomal dominant. So B and D cannot be the answer. A is non-Mendelian. So what are you left with? This is Kearns-Sayre syndrome, provided the options have been correctly recorded and provided the uh, pedigree chart has been correctly given, right? This is all based upon recall. If the recall changes, options change, the answer is also liable to change. Moving to question number, so ये मैं already discuss कर चुका हूँ ये वाला फंडा. Question number 9, it's an easy one. A child with developmental delay, seizures and cherry red spot on fundus examination is evaluated. Enzyme assay reveals deficiency of hexosaminidase A. Cherry red spot, CNS involvement, and hexosaminidase deficiency. What are we looking at? We are looking at Tay-Sachs disease. And Tay-Sachs disease is GM2 gangliosidosis, where GM2 gangliosides tend to accumulate. So look at this. GM2 block hexosaminidase deficiency produces the disease known as Tay-Sachs disease. So GM2 gangliosides tend to increase. The answer to this question is B. Question number 10. A child with developmental delay has coarse facial features and there is deficiency of alpha L iduronidase. Coarse facial feature is also sometimes called as gargoylic face. So gargoylic facies is there along with deficiency of alpha L iduronidase. This is nothing but Hurler syndrome which is being talked about, also called as type 1 mucopolysaccharidosis, and which is the glycosaminoglycans and ground substances which accumulate in this patient. Let's have a look. In Hurler syndrome as well as Shy syndrome, that is type 1 MPS, you have heparan sulfate as well as dermatal sulfate which accumulate. So that is your correct answer. If you remember the table, it's an easy one. If you don't remember the table, it's a tough one. But you basically need to reach the correct answer. Question number 9 and question number 10 are integrated biochemistry and pediatric questions. If you have read in biochemistry but read it properly in a clinical way, good enough. If you have read in pediatrics and just remember the enzyme, good enough. But if you have not read in either of the two, then these questions become tough for you. Two metabolic disorder questions were directly asked, at least from pediatric and biochemistry overlap perspective. And lastly, there was one question, options could not be recalled. I have been told just now in the message box that there has been another question on CKD, लेकिन उसमें calcium values were given. So when that recall comes, options come, I will be doing the recall of that, and detailed recall we will be putting up in a proper way in the coming days. But which vaccine with vaccine vial monitor can be used? So different options were given. One alone, 1, 2, 3, 2, 3, 4. Such options were given. The inner box should always be lighter than the outer box. If they are of the same color or if the inner one becomes darker, it cannot be used. So this one can be used. This one can be used. This one cannot be used. This needs to be discarded and this one not to be used. So all you have to see is ये A or B या 1 या 2 जो भी था, these are the two options that you can mark depending upon how question has been framed. Is it an easy question? It is an absolutely easy question, overlap between PSM and pediatrics. So I have been told that there are two more questions of pediatrics which have been asked. One on Katori spoon feeding, options have not been recalled. One another on CKD related to calcium deficiency and calcium values were given. So those two recalls, as soon as they come, I will be putting it up in the recall section and I will be adding them in the comment. So I hope all of you did well. Dinesh Reddy is saying, sir, corneal opacity was given. If corneal opacity was given, again, corneal opacity, Hurler as well as Hunter. Hunter does not have corneal opacity. Hurler has corneal opacity and corneal opacity. बोथ दोनों के अंदर heparin sulfate and dermatan sulfate दोनों accumulate होते हैं. See, चाहे Hurler हो चाहे Hunter हो, आपके अंदर HS and DS are what are getting accumulated. So answer will not change in the question. So these are 11 questions. Out of these 11 questions, let us assume कि 12, 13, 14 नहीं हुए भी recall. 11 के अंदर, if you leave out two questions, 9 out of 11 are solvable questions. So pediatrics was atypical this time. No milestone, no malnutrition, no diarrhea, no dehydration, still solvable. So remember the funda that pediatrics in every exam is solvable. And when the typical topics come, you can reach as close as 100% in the exam. But whatever has been done has been done. You have given your best shot. Be proud of yourself. Listen to the recall and enjoy. Pray a bit and fingers crossed. May you get your branch of choice. My prayers and best wishes with all of you. Thank you so much. We don't have done. Yeah.
Hello everyone, good evening. Good evening to all. Yes. So today we will be discussing the ObGyn questions that came from this NEET PG exam as such. How did you guys find the questions? Yes, I feel in ObGyn, majority of the questions were core expected areas. Many of the previous year topics as such were there. We see some clustering of areas as such, like there were so many questions from gynae oncology as such. Obstetric emergencies were asked in detail. We did not get much questions from contraception, vaginitis, ectopic, all those areas were not covered, but obstetric emergencies like postpartum hemorrhage, cord prolapse, shoulder dystocia, all those things were covered in detail as such. But all in all, it was not a very tough question as such from ObGyn point of view. Relatively, we got less number of image-based questions as such in this exam. So I would be discussing all these core areas quickly. I know you might be too exhausted after the exam. You just want to know the answers and what it is. I'm going to have a brief, quick discussion of the questions from ObGyn. We would be having a detailed discussion as such. If there are any changes that you find in the questions, you can definitely tell me as well. Any options or any modification? Yes, these are the recall questions as such. So we'll have a quick discussion, and soon within the upcoming week, we are going to have a detailed discussion on each of the topic. But I won't be dragging you too long with any of the topics. Yes, let's go through the questions one by one. So magnesium sulfate Pritchard's regimen, a very much expected question. You cannot go to exam without dealing with hypertension, magnesium sulfate. Magnesium sulfate, what is the loading dose? Loading dose is 14 grams. How do we give this 14 gram? We give 4 gram IV and 5 gram intramuscular in each buttocks. That is 5 gram into 2. That will be total 14 grams. Then even after that, you keep on giving 5 gram intramuscular every 4 hours. Every 4 hours, we continue it for 24 hours. This is the Pritchard's regimen. Apart from this, we have even the Zeuspan regimen. What is Zeuspan regimen? As per Zeuspan regimen, we initially give a 4 gram IV loading dose, followed by 1 gram per hour. Again, continued for 24 hours. So the correct answer here is 14 grams. Yes, let's move to the next question. This was from amenorrhea chapter. As such, a patient has presented 32-year-old with 6 months of secondary amenorrhea. You see that her FSH level is 36, LH level is 56, and her AMH level is 0.05, low levels of AMH. What is the most likely diagnosis? In this woman, you have high levels of FSH, high level of LH with secondary amenorrhea. This is merely pointing towards an ovarian problem, such as an ovarian insufficiency or ovarian failure. The normal level of FSH is between 5 to 10. Any level more than 20 is suggesting toward a diminished ovarian capacity or a poor ovarian function as such. Anything more than 40 is suggestive of an ovarian failure. So here you are dealing with primary ovarian insufficiency. If you have a problem at the level of hypothalamus or pituitary, you will see that FSH, LH levels are decreased in that. Whereas ovarian pathology such as premature ovarian insufficiency, these levels will be increased. Estrogen levels will be low. Even AMH levels are low. The normal levels of AMH is 1 to 3.5 nanogram per ml. These two are the most typical of ovarian insufficiency. About the other option, what do you get in polycystic ovarian syndrome? In PCOS, we have slightly higher level of LH and lower levels of FSH, due to which LH to FSH ratio is raised. LH to FSH ratio is raised. Yes, here the correct answer is POI, premature ovarian insufficiency. Let's have a look at this question. A 28-year-old female who has presented in labor on per vaginal examination. You have a pulsating umbilical cord below the presenting part. What is this? This is a case of cord prolapse. Patient presents to you with cord prolapse. What is the definitive management that you're going to do? Definitive management is cesarean section. But in the meantime, you're going to do some temporary measures. These temporary measures are basically directed so that the pressure over the cord is reduced. What can you do? Either you can manually elevate the head, or you can even fill the bladder. Retrograde filling of the bladder is done, and this bladder will push the fetal head up. Or you can position the patient in Trendelenburg position. Again, gravity will do the job for you. Or even knee chest position. What do you see here? Elevate the buttocks if it is breached, push the presenting part upwards and fill the bladder. This is what you're going to do. Should you attempt to reposition the cord inside, the key point is don't touch the cord, don't manipulate the cord. The moment you touch the cord goes into spasm and there is more fetal distress. Do not touch the cord. You are not going to do that. If you wait and watch, as option C, baby will die soon in the meantime, you cannot wait and watch. Augment the labor with oxytocin. Again, we don't prefer to go ahead with vaginal delivery. You are going to relieve the pressure on the cord and then go ahead with the definitive management, that is cesarean section. Here the correct answer is A. Yes. So let's move to the next question. A woman has presented in active labor. There is sudden onset of fetal bradycardia and there is maternal tachycardia and suprapubic pain during contraction. On examination, cervix is 8 centimeter dilated, head is high, head is -1 station. What do you suspect here, guys? What do you think about when you saw this condition? There is fetal bradycardia, maternal tachycardia, and even suprapubic pain during contraction. Why should there be suprapubic pain? This is slightly pointing more towards a uterine rupture as such. And again, even if you had severe bradycardia, high station, you cannot go ahead with a vaginal delivery such as with forceps. What will you do in this scenario? You will go ahead with emergency cesarean section. Stripping of membrane will not help for this. Stripping of membrane is a method used for induction in the initial stages. Augmentation of labor with oxytocin. Already you are having fetal bradycardia, there is suprapubic pain. If you again augment, again there will be more, the rupture, the complications are much more. Instrumental vaginal delivery, you're going to only attempt if the station is more than or equal to +2. Again, this is more pointing towards a rupture scenario as such. You are not going to go ahead with, again, any form of instrumental vaginal delivery or any form of vaginal delivery. Correct answer is cesarean section. Any doubts or questions, feel free to ask in the question section as well. I'll be just having a look at the questions that you have in the meantime. Yes. Let's move to the next question. This was from episiotomy. They are basically asking you a very basic skill whether you have observed episiotomy repair as such. How do we repair the episiotomy? Initially, we repair the vaginal mucosa, then the muscle layer, finally the skin closure is done. So it is vaginal mucosa, then the muscle, and finally the skin closure is done. Usually vaginal mucosa we do in a continuous manner. Skin muscle is usually done in an interrupted sutures, and skin we can use a metra suture as well. Yes, this is how you go in the order. Next question, a woman has presented with enlarged breast, linea nigra, and bluish discoloration of the vaginal mucosa. Bluish discoloration, that is the Chadwick sign, is present in the pregnancy. These signs are best categorized as, all these signs are the probable signs of pregnancy. These are the probable signs of pregnancy. We have other presumptive signs like the nausea, vomiting, all those things which are the presumptive signs. Positive signs like the positive urine pregnancy test, or maybe the ballotment that is felt, the fetal movements which is felt. Yes, these signs are the probable signs of pregnancy. Even we have various other early pregnancy signs as well, such as Hagar sign. Hagar sign, you have the softening of isthmus. Softening of isthmus. We have other signs such as Chadwick sign, or the Chadwick sign is we have the Jacquemus sign as such, which is the bluish discoloration, which is seen in the ectocervix and vagina. We have the Palmer's sign, where there is rhythmic contraction of uterus. Palmer's sign, where you have rhythmic contraction of uterus. Osiander's sign, pulsation that is felt in the vaginal fornix. Yes, Chadwick sign. So many other early pregnancy signs which is commonly asked as well. Let's go to the next question. So a 28-week menstrual cycle, a patient has presented, she has 28 weeks menstrual cycle. And what this best describes the hormonal profile between day 21 to 25. Day 21 to 25, you have the secretory phase. And in secretory phase, you have corpus luteum. Post-ovulation, the corpus luteum will produce progesterone as well as estrogen. What else is produced by corpus luteum? It also produces inhibin. And this inhibin that is produced is inhibin A. The inhibin A is produced as well. So the corpus luteum produces progesterone, estrogen. This progesterone and estrogen will give a negative feedback, due to which you will see that the levels of LH is low, FSH is low. So you will have increased levels of estrogen, progesterone, and decreased levels of LH as well as FSH. What do you see in the beginning of the cycle? In the initial part of the cycle, we see that we have slightly higher level of FSH. FSH stimulates the follicles. The follicular stimulating hormone. The follicle keep on growing, and this follicles produces estrogen. Estrogen gives a negative feedback to FSH. High levels of estrogen actually causes an LH surge. Sustained high levels of estrogen actually stimulates an increase in LH known as LH surge. Nearly 36 hours, 24 to 36 hours after LH surge, or 10 to 12 hours after LH peak, you have ovulation happening. Post-ovulation corpus luteum is there, and corpus luteum will produce these hormones. Just a quick summary of the menstrual hormones as such. Yes, let's have a look at this question, carcinoma cervix staging. This is a much expected question. As such, CA cervix, the management staging, definitely, at least the screening part, they will ask. You can't go to an exam without covering carcinoma cervix. They have asked there is involvement of ureter. What is the stage that is involved in it? When you see that in the cervix, the lower part, carcinoma cervix is involving the lower 1/3 of vagina, that is 3A. It is involving the parametrium till the pelvic side walls, that is 3B. Involvement of lymph node, pelvic para-aortic lymph node, that comes in 3C. Not only the parametrium till the side wall, even the ureters are involved in 3B. Yes, correct answer is 3B. Whereas what about the other stages? CA cervix, the stage 1 is confined to cervix. Stage 2A is upper 2/3 of the vagina. Stage 2B is parametrium, but not till the side walls. 3A lower 1/3, 3B till the side wall, 3C is the pelvic para-aortic lymph node. 4A is bowel bladder, 4B is distant metastasis. Yes, correct answer is 3B in this. Let's move to the next question. So a woman presents with abdominal distension and ascites. On examination, you see that the abdomen is enlarged, the CA125 is elevated, and the imaging shows a large multicystic ovarian mass with irregular septations. What is the most likely diagnosis in this? So a woman, elderly female, presents with abdominal distension, ascites, elevated levels of CA125. You are thinking about ovarian cancer. Especially the most common ovarian cancer as such is epithelial ovarian cancer. Among this, most common is serous cyst adenocarcinoma. Serous cyst adenocarcinoma typically has high levels of CA125 as well. Yes, we are dealing with serous cyst adenocarcinoma. Again, this is more ascites, distension, all these are there. This is not a simple serous cystadenoma as such. It is more towards a serous cystadenocarcinoma. In mucinous cystadenoma, you have tumor markers such as CEA and CA19-9. A very similar question came even in the recent INI exams as well. Yes, in granulosa cell tumor produces estrogen. The patient can have precocious puberty if it's a young girl, or even postmenopausal bleeding can be there. The tumor marker in granulosa cell tumor is inhibin. You will have inhibin B. And often we see that the patients, there is called Exner bodies. In the histopathology, often you get called Exner bodies, which is pathognomonic. Okay, so the next question was again on another obstetric emergency, that is postpartum hemorrhage. We always discuss the algorithm of management of PPH as such. Yes, this is often asked. Often they will block you at one of the steps and ask you what will you do next. So any patient comes to you with postpartum hemorrhage, first and foremost is call for help. First is call for help. After call for help, next you are going to resuscitate the patient. You stabilize the patient. What all are included in the stabilization? You put into wide bore IV cannula. You are going to arrange blood for her, start fluid, send investigation, all those things. Next, after this, you will start massaging the uterus. You will massage the uterus. Next comes the uterotonics. Uterotonics. In the uterotonics, we initially give oxytocin, next methergin, carbopros, misoprostol, and even tranexamic acid as an adjuvant. So question is already giving that she is not responding to all these initial management, and option does not have any medical management. They are asking you, what will you do next for the patient as such? What can you do next for the patient? Next, either you can go for compression methods, that is mechanical compression, either by bimanual compression, or even you can use an intrauterine balloon tamponade. We have various types of balloon tamponades such as Bakri balloon. Even condom catheter is commonly used in majority of the labor rooms. That is the next step. Still bleeding is not controlled with these mechanical measures, then you are going to shift the patient for surgery. Examine under anesthesia, and you will move ahead with either compression sutures. If it is not controlled, then you proceed with stepwise devascularization. Finally, hysterectomy. So among this, please note that what will you do initially after the medical management, everything has not worked for the patient. Initially, you go ahead with the mechanical methods such as intrauterine balloon tamponade. Correct answer is A. Yes, the next question was on shoulder dystocia. Again, in shoulder dystocia also, we discussed this management algorithm as such. what you have to do in shoulder dystocia. The beauty of this time the question came was they gave such relevant, important obstetric emergencies as such. It was much of a predicted, important scenario-based questions that they have asked as such, not something very rare or atypical as such from ObGyn. And many of the students had found that it was easier. Yes. Ma'am, operation room was given. Operation room was given. So was it the option that shift the patient to operation theatre and examine under anesthesia? Yes, can you just confirm that? If the option was shift the patient to OT and examine under anesthesia as such, that comes after this step there. After the tamponade as such, you are going to mechanical method, that is, then you are going to shift the patient to the operation theatre and examine under anesthesia. So if both those options were given, that is examination under anesthesia after shifting to OT, still this balloon tamponade will come first. Yes, that is the next thing that you're going to do for the patient. Yes. So about this shoulder dystocia, first and foremost that you're going to do is again call for help. After call for help, next you will position the patient in McRoberts maneuver, where you flex and abduct the leg. Next is McRoberts maneuver. After McRoberts maneuver, you are going to apply suprapubic pressure. And the suprapubic pressure is also known as Rubin's 1 technique. So after McRobert, you have suprapubic pressure, which is known as Rubin's 1. This is a less used name as such for Rubin's maneuver. After this, you will go for internal maneuvers. You have various internal maneuvers, and among the internal maneuvers, we initially go with internal rotational maneuvers. Internal rotational maneuvers such as wood corkscrew and even Rubin's 2 maneuver. Either wood corkscrew or Rubin's 2 maneuver. If it fails, then we move ahead with delivery of posterior arm. Then we deliver the posterior arm. If still the delivery does not happen, then we go ahead with either positioning the patient in Gaskin's maneuver, that is in all 4 position. She will be on her arms, hands, that is palms, as well as knees, that is all 4 position, which is known as Gaskin's maneuver. Still, it is not corrected. Finally, we go ahead with destructive maneuvers. Destructive maneuvers example are Zavanelli's maneuver. Even we have the symphysiotomy, cutting the pubic symphysis, pleodotomy, cutting the clavicle of the baby as well. Yes, so among this, the order is Rubin's, the McRoberts maneuver, next Rubin's maneuver. Even if you consider both Rubin's, either Rubin 1 or Rubin 2, that comes before the Gaskin's maneuver. Finally, the destructive maneuvers such as Zavanelli's maneuver. Yes, this is the correct order in which you are going to go ahead with it. Yes, moving ahead. A woman para 2 living 2 with history of difficult vaginal delivery conducted by an untrained attendant now presents with complaint of something coming out per vagina. On examination, there is a uterine prolapse. Even students said that there was an image of uterine prolapse as such which was given. Injury to which of the following ligaments is most likely responsible for this condition? So for prolapse, you know the main supports of prolapse. We have muscular support which is given by the pelvic floor. Of this, the main component is levator ani muscle. You have levator ani muscle. You have ligamentous supports. Among the ligamentous support, the important ones are the McInrod's ligament as well as the uterosacral ligament, even pubocervical ligament. Yes, these are the ligamentous support, and even the position of the uterus, that is anteverted, anti-flex position. Finally, the ligaments that does not give a support, please note broad ligament, no support at all, and round ligament gives a secondary support. So among the ligamentous supports, the important ones are McInrod ligament, apart from that uterosacral ligaments, and even the pubocervical ligament. And even the position, that is the mechanical support, is due to the position anteverted, anti-flexed. Uterus is anteverted and anti-flex. The correct answer here is McInrod's ligament, whereas round ligament is only a secondary support and no support from broad ligament as such. Yes. So a term newborn is delivered and the umbilical cord is examined. Which of the following represents the correct, the number of blood vessels in the umbilical cord? It looks like a smiley. Now, our umbilical cord is like a smiley. They're smiling to you like this. There are 2 arteries. There are 2 arteries and 1 vein. Which vein is this? Initially, we have right umbilical vein and left umbilical vein. It is the left vein which is left behind, whereas the right vein will regress. So the right regresses and the left is left behind. And in between, you have this Wharton's jelly. Wharton's jelly is the protective jelly around these vessels, which again prevents any form of compression or injury to the blood vessels as such. Umbilical artery will carry the deoxygenated blood. Umbilical vein will carry the oxygenated blood. So there are 2 arteries and 1 vein. The most common vascular abnormality that you see in the umbilical cord is single umbilical artery, yes, which can sometimes be associated with other congenital anomalies as well. Yes. So next question was on breeds. Regarding the delivery of breeds, they had showed an image and they showed that while delivering the baby, you see that there is winging of scapula, which is pointing towards an extended arm as such. And what is the maneuver that you will do for extended arm? For extended arm, we have Lausset's maneuver. For extended leg, we have Pinard's maneuver. This is for extended leg, where you give pressure over the popliteal fossa so as to flex the leg. The Burn Marshall technique as well as the Mauritius smelly weed technique, they are used to deliver the aftercoming head. That is for the head delivery in breech. Aftercoming head or the head delivery in breech. Correct answer here is Lausset's maneuver. So in the next question, an elderly female presents with a high blood pressure of 170/100 and she complains of blood-stained vaginal discharge. What is the most appropriate next step in her management as such? She has blood-stained vaginal discharge. She's an elderly female with postmenopausal bleeding. What are you going to do for the patient who has presented to you? You will perform a pelvic examination, and whenever a postmenopausal female presents to you with this increased discharge, especially in a setting of hypertension, we are more thinking in terms of the endometrial cancer as such. You have to evaluate for endometrial, you have to evaluate the endometrium with an endometrial biopsy. Any postmenopausal female, the initial evaluation steps, you will do a speculum examination, look at the cervix. If you see that there are any abnormality, take a biopsy from the cervix. If cervix is normal, still you go ahead with a pap smear. Then you evaluate the endometrium. You initially go with an ultrasound. Then if it is thickened, we go ahead with endometrial biopsy for the patient. Yes. So endometrial biopsy is very important so as to rule out endometrial hyperplasia and endometrial cancer. Another question had come from this similar concept as such. A 46-year-old nulliparous woman has presented with abnormal uterine bleeding. The ultrasound shows that endometrial thickness is 24 millimeter. What is the next best step in management? Patient comes to you with abnormal uterine bleeding. The initial thing what you're going to do is urine pregnancy test. After urine pregnancy test, once you have ruled it out, we do some basic blood tests such as first is UPT, then we have some basic blood tests such as hemoglobin, the platelet is SS, the TSH. We often go ahead with prolactin. Coagulation profile only if it is required. We do an ultrasound to look at the endometrial thickness and any other structural abnormality. What is the next investigation? A very important investigation is endometrial biopsy. When do you go ahead with endometrial biopsy? Any patient comes to you with abnormal uterine bleeding and patient age is more than 40 years as per Indian guidelines, that is FOXI guidelines, whereas as per Western guidelines, when you take the RCOG guidelines, ACOG guideline, the cutoff taken is 45 years. Or any woman who has come to you with AUB, abnormal uterine bleeding, who is less than 40 years, associated with risk factors. What risk factors? Risk factors such as previous history of PCOD, obesity, family history of endometrial cancer. Wherever there is risk factor for endometrial hyperplasia and cancer, again you proceed with endometrial biopsy. Finally, if you have a patient who has failed medical management, you again proceed with endometrial biopsy. In this patient, especially you're having a thickened endometrium, abnormal uterine bleeding, what will you do for the patient? You have to assess her, rule out endometrial cancer, only then you can start any form of hormonal treatment for the patient. You will never start an hormonal treatment for a patient who has undiagnosed abnormal uterine bleeding. Yes, again here the answer is perform an endometrial biopsy for the patient. Scheduled hysterectomy not indicated directly. You can't just reassure, especially with such a thick endometrium. Again, ossiples, any form of ossipals, undiagnosed abnormal bleeding is a contraindication to start those techniques. Yes. Pap smear was also there. It is 18 millimeter. She has heavy bleeding. Okay, even if it is 18 millimeter as well, in this scenario, you're going to still proceed with endometrial biopsy, dear. 65-year age was mentioned in the previous question. Yes, 65. Thank you, dear. Ma'am, but in labor room, won't the sutures help as well? Is I think, Tariq, you're mentioning about the PPS, postpartum hemorrhage access, dear. Yes. The sutures as such will definitely, whatever sutures we are going to do, we are going to do it in the operation theatre as such. But this balloon tamponade can be done even in the labor room there itself. Examination under anesthesia. If that point was done, that comes after this balloon tamponade. You will give the balloon tamponade, then only shift the patient to operation theatre and do examination under anesthesia as such. Yes, the suture comes after that, dear. Then next you will proceed with compression sutures. If that's still not working, then you go ahead with stepwise devascularization and finally hysterectomy as a step. So after the initial management, if you have an option alone of balloon tamponade, that will definitely be a better option rather than examination under anesthesia in the operation theatre. Yes, examination under anesthesia in operation theatre comes as the next step after this balloon tamponade. Pap smear was also given in the option. Yes, if pap smear was given in the option along with endometrial biopsy, that's much better. Yes, that's again, thank you for contributing that, Abhinav. Abhinav had mentioned along with endometrial biopsy, even pap smear. Evaluation with pap smear was given. Yes, as we discussed in the algorithm, pap smear is there initially. That is how you evaluate any patient with postmenopausal bleeding. You evaluate the cervix, you evaluate for endometrium. Cervix, if normal, we go ahead with pap smear. Cervix is abnormal, we go ahead with the cervical biopsy. Next, do an ultrasound, check the endometrial thickness, then proceed with endometrial biopsy. Yes. Thank you for contributing that bit. Yes. All right. The next question, a 32-year-old female with BMI of 38, an obese female after a surgery, that is elective lower segment cesarean section, has presented to you and she has preeclampsia as well. You have these risk factors, history of surgery, high BMI, preeclampsia. Which among the following is the best method for DVT prophylaxis in the patient? In these patients, whenever you are giving this post-operative prophylaxis for DVT, the preferred anticoagulant that we give for the patient is low molecular weight heparin. Aspirin alone will not help. Warfarin is not generally given for DVT prophylaxis. Here the patient has risk factors such as high BMI, preeclampsia, post-surgery, especially after postpartum. This patient is post-delivery. Postpartum is again a risk factor with a high risk of thromboembolism or coagulative problems as such. So you're going to start this patient on low molecular weight heparin, especially considering that she's postpartum, post-surgery, BMI of 38 and preeclampsia history as well. You will start her on low molecular weight heparin. Yes. A 65-year-old female presents with bleeding. Hysterectomy is done and the gross examination is shown below. I did not get the exact image as such, but from what the students recall, they told that there was a growth which was arising involving the inner part of the uterus as such, especially the endometrium and towards the myometrium. And especially considering this age, 65 years, the patient has presented with hysterectomy specimen. Yes, the diagnosis point more towards endometrial cancer. Whereas endometriosis, even some students were thinking about endometriosis you will see in a much younger age group. The typical age group is 30 to 40 years. Even fibroid is 30 to 40 years. Adenomyosis is 40 to 50 years. And in endometriosis, we don't generally go ahead with hysterectomy. It is a last resort as such done for females where we do hysterectomy as well as bilateral salpingo-oophorectomy. Considering this history, bleeding PV, 65-year-old female, hysterectomy is done. Yes, even with the description which I got from the students, it is more pointing towards endometrial cancer. Correct answer is endometrial cancer. Identify the image that is shown over here. Yes, you can see a controlled contraction. In the active management of third stage of labor, we give a controlled contraction. This maneuver that you are seeing is the Ridgen's maneuver, where we give a controlled traction with a counter traction with the other hand so that the uterus inversion does not happen or the uterine inversion does not happen. So in the active management of third stage of labor, first and foremost is oxytocin. Then you are going to do a delayed cord clamping and controlled cord traction. If you see that the tone of uterus is reduced, you go ahead with the massage of the uterus, uterine massage. Yes, this was a simple direct question on controlled contraction. Yes, controlled contraction is given over here. So these were the various questions that I could get from this exam. We would be doing a very detailed review as such, even considering this, the inputs that you gave regarding the pap smear, the age group, everything. Yes, these were the important questions that came. Overall, I felt that ObGyn was quite a doable paper as such. It was not very tough. Majority of the expected questions had come directly from the class notes as well as from the videos. Hope you found the topic as well much doable. Any other doubts or questions we'll take for a few minutes? Yes, then we'll go to the next session. Any more doubts or questions? No? Okay. So thank you so much for staying with me. I know you might be quite exhausted after the exam as well. So this is the time, just leave everything from your mind. Just go through the questions and everything, that's fine. But after that, enjoy this time. Don't think too much. Whenever we recollect questions, now we tend to remember those questions which we made wrong rather than those other multiple questions which we made right. There might be some questions which we made wrong, which tends to come back again and again to our mind. Yes, don't focus on these things. There was one more image-based question. Can you please give me what was given there, dear? Any description of that as such? An image was given from MRI. Yes, we'll try to collect that as well. Any more? Anything else from the clinical history? Was there an MRI-based question from ObGyn? Was it anything related to the Mullerian anomalies? Hopefully, we'll get that question soon too. But if possible, we can definitely send it to me or we'll try to get it. And anytime you can connect to me as well. My Insta ID is obg underscore with underscore Gayathri. One option was intramural fibroid. Okay. So we'll have to get more details on it. MRI image of uterus with fibroid or adenomyosis was given. How to identify whether it is fibroid or adenomyosis as such? Adenomyosis, you will get a more of an uniformly enlarged uterus. Whereas even you can see the small cyst as such, the myometrial cyst, all those things might be there. Whereas in case of fibroid uterus, you have this irregularly enlarged, multiple fibroids might be there, which is seen as such. Yes. We'll try to get that question too, and we will put in the detailed discussion as is. Thanks for contributing that extra question. Okay, with this, we are coming to the end of the discussion as such. Oh, so over to the next faculty. I know we have all 19 subjects to be discussed. So that's all. Thank you, guys.
Hello, my dear students. Now let me speak on some of the recall questions. Okay, all the options may not be right because I have got around 7 questions. Number one, from Dermatology chapter, which of the following statement regarding the Zasco phenomena is true? You know very well, after death, Muscles may live up to 1 to 2 hours. And if you take one knee hammer and hit about 10 centimeter above the patella on the quadriceps, there will be mechanical stimulation of the quadriceps muscle that is known as Zasco phenomena. One of the easy question. Okay. It is related to postmortem tendon reaction. Okay. Number two, mechanical asphyxia. A 26-year-old woman is brought dead to the emergency department. On examination, there were scratches and bruises below the right angle of mandible with 3 bruises over the left side of the neck, along with deep bruising of neck muscles on internal dissection during autopsy. The superior horn of thyroid cartilage is fractured on right side and hemorrhage is seen in strap muscles. Abrasion and bruises are also seen on left shoulder, shoulder blade, and iliac crest. What? Which of the following is the most likely cause of death? Very easy question because you know very well. In both ligature strangulation as well as hanging, there should be ligature. There is no ligature mark at all. You can rule out ligature strangulation as well as hanging. Mothering means closure of both respiratory passages, the mouth and nostril. There should be injury around the mouth and nostril, but here injuries are found mainly over the neck. At the same time, on internal examination also there is bleeding into the strap muscles as well as fracture of the superior horn of the thyroid cartilage. All goes in favor of manual strangulation or throttling. At the same time, you may think why there are bruises around the left shoulder, shoulder blade, and iliac crest. Maybe due to it all. These are signs of struggle. So answer is throttling. Number three from sexual jurisprudence chapter. It is also a very, very easy question. As per the Protection of Children from Sexual Offences Act 2012, who is legally considered a child under the law for the purpose of protection against sexual offences? Some of the students may think that the POXO Act 2012 is only for females. You're wrong. It is for both females as well as males, whoever is less than 18 years of age. So the answer is C, all children under 18 years of age. Number four again from sexual jurisprudence. Again here I don't know. So some students are telling the exact options are not there. Like the mother has filed a case that her 15-year-old daughter was kidnapped and raped by a 25-year-old man. Man is saying that he loves her and wants to marry her. Girl is also saying that it was a consensual sex. Finding of recent sexual intercourse was present. What is the legal aspect? You know very well. Minimum age of a girl who can give valid consent for sexual intercourse is 18 years. Even with consent, if the girl has sexual intercourse with a man, the man will be punished for rape. Minimum 10 years of imprisonment. Generally, we call it as statutory rape. At the same time, if her age is less than 18 years, it amounts to kidnapping also. And whenever a case of suspected rape comes to a doctor, you have to inform the police. So here, man cannot be punished as he loves her and wants to marry her. No, 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 nothing doing. Consent is valid. No, consent is 100% invalid. Mother has to prove that they are lying. All this will be proved in the court of law by the public prosecutor or assistant public prosecutor. Trial should be done as the girl is underage. Definitely, the police will charge him under case of rape and kidnapping. Trial will take place in the court of law. Then judge will decide how much is the punishment. So easy question. Number five from forensic psychiatry, a 35-year-old man was arrested for attacking a co-worker. During interrogation, he appears disheveled and expresses paranoid delusion, stating he was not in the right state of mind. Which of the following is the most appropriate next step? Here, only thing what they say is the person was like mentally ill. Now, what is the next step in case a suspected mental ill person or a mentally ill person assault somebody or involves in a crime? Release him as he was not in the right mental state. No, nobody has the right to release. Investigation has to be done. Psychiatric consultation to assess fitness for trial and proceed to trial. Convict him? No. The questions of conviction will not come soon after the crime. Now, trial has to take place. But the question is whether the person is fit to undergo trial or not is very, very important. Say, for example, if a person is totally mentally ill, then he will not understand the nature and consequences of the trial. For example, he doesn't know what is the meaning of trial. So, look here, a defendant's mental state is assessed to determine if they can understand the charges what is put against him, and at the same time, he should know what are the exam court proceeding, and he has to assist his lawyer. That's why always the assessment of the mental state is very important before trial. Once he is deemed to be fit, then only trial will take place. If the defendant is found mentally unfit, the trial is suspended until they are deemed competent to proceed. So, answer is psychiatric consultation to assess fitness for trial. Number 6 from toxicology. 22-year-old male patient is present to the candidate issue vomiting and diarrhea after consuming something. The vomiters had garlicky odor. Garlic odor you can get in case of phosphorus poisoning, arsenic poisoning, thallium poisoning. There was pain in the throat before vomiting, you know very well. There are difference between acute arsenic poisoning and cholera. In case of cholera, first there will be vomiting followed by pain in the throat. But in arsenic poisoning, first there is pain in the throat, later there will be vomiting. Diarrhea had blood and mucus in the beginning where it turned black and later clear rice watery stools. What is the diagnosis? Garlic odor, rice water stool which mimics cholera, acute arsenic poisoning. Acute arsenic poisoning. Number 7, again from toxicology. You are at home when you hear a loud siren and see news alert that a chemical leak has occurred in a nearby fuel slash chemical plant. A strong odor begins to spread in your neighborhood. What should be your first and most appropriate response? It is like how we have to behave in a mass disaster or in case of chemical factory or in case of busting of any gas chamber or chemical chamber or whatever it is, you know very well it is clearly mentioned that the leakage of chemicals, once there is leakage of chemicals, the aerosol comes through the air. Only thing you have to see that your body will not get in contact with the chemical aerosol. So now already got the answer. If at all you are inside the house, what best you have to do is you close all the doors, including the ventilators or windows, whatever it is. And definitely sometimes even there will be a gap. Even if you see any gap or anything, if you have plaster or tape, anything, you have to close the entire. So answer is close all doors and windows and seal your home with plastic and tape. So these are the 7 questions what I've got. After 7 you can answer easily, or at least 6 you can answer easily. Okay? Okay. Enjoy your day today. Bye bye.
हाय फ्रेंड्स आई नो दैट यू मस्ट बी टायर्ड आज बहुत थके होगे तुम लेकिन स्टिल बहुत ज़्यादा लाइक विल आई विल नॉट टेक मच ऑफ योर टाइम एंड विल टेल यू in fact I already told you that this particular subject what is the importance It's directly, indirectly. This time also in the exam, the microbiology have touched over 30 questions. Okay. If I get very deep into integrated way and all that. So 30 questions does matter in the rank listing. And you know, in the last, even one mark matters. Okay. Even one questions matters. So without wasting much of your time, and obviously these are recalls, they are not the perfect ones. With the perfect ones, will come back. But still, we have tried up that the options are optimized, they are real. You can also tell up in the comment section that this was there, that was not there. So we'll start up with the first question. And I will tell you that what was the crux by which you need to find that this is the answer. Okay. I think I'm audible to everybody. So as you can see, the first question, a farmer presents with an ulcerative skin lesion with central necrosis surrounding edema. A smear for the lesion stained with polychrome methylene blue shows capsulated bacilli positive for which reaction? McFadden's reaction. So you know guys, McFadden's reaction is for what? It is for the capsule demonstration. It is done using what? Polychrome methylene blue. Okay, and the condition which they're talking about in this is cutaneous anthrax, also termed as Hyde-Potter's disease or malignant pustule. And why it is termed as malignant pustule? Because of the edema around. Okay, so obviously we're talking about what? Bacillus anthracis. And if you have attended my lectures and all, you must be knowing also, I have made you remember like this, McDonald fries. They are very good. बहुत अच्छी हैं. Okay, so this proves up that this reaction was being discussed. Okay, so McFadden's reaction is for this and Kuhling reaction is for pneumococcus. You know that. So this was the first question. Is it fine? Now, other than that, guys, let's talk about the second one. In the second one, a 32-year-old farmer presents with high-grade fever, severe myalgia, especially in the calves, redness in the eyes, and this redness is termed as what? Conjunctival suffusion. I told you, conjunctival suffusion, this particular word, what is the meaning of this? Red eyes without inflammatory exudates. Okay, along with the mild jaundice. That is there in this particular one. So red eyes without inflammatory exudates along with the jaundice is a clear-cut feature of leptospirosis. Okay, so this is a repeat actually, and I've told her that this will be again asked. So remember guys, conjunctival suffusion is an important entity. Along with the jaundice, they are talking about the Weil's disease. And the answer is leptospirosis. No doubt in that. Is it fine? Now, coming to the third one, a 19-year-old college student presents with sudden onset fever, headache, vomiting, rapidly spreading rash. See, if you have done my lectures, no cough pain was given. They mentioned only conjunctival suffusion. I told you brain fog. If conjunctival suffusion is there, that is towards the leptospirosis. Triple R. Okay. That is in the rainy season, rice field workers, they tend to get it by the rat urine contamination. That is what is triple R. Is it fine? So guys, here the purpuric rash in this particular question, and he's toxic and confused. Vitals are low, 80/50, BP, heart rate is increased, temperature is there, petechiae, purpura are there over the lower limbs. The individual have landed into what? Into shock. Okay, and this is what is termed as purpura fulminans, a very bad complication of meningococcal meningitis in which death is certain. Okay, Waterhouse-Friderichsen syndrome, bilateral adrenal hemorrhaging cricosis, along with this purpuric lesions, is a typical feature of that particular purpura fulminans. And that's why the answer is towards what, guys? Neisseria meningitis, that is meningococci. Is it fine, guys? Other than that, if you remember, there was a question in which it was asked that what is the drug of choice for the prophylaxis of meningococcal meningitis? I told up ciprofloxacin, that is the better answer, but they have asked the previous one, that is the rifampicin. Okay, so rifampicin is also used, but obviously we prefer nowadays what? Ciprofloxacin. And I think ciprofloxacin was not in the options. Is it fine? So answer is C in this particular one. Now talking about this, a 35-year-old man presents with 2 weeks history of low-grade fever, non-productive cough, weight loss, and fatigue. Okay, the typical features which they try to mimic it the TB way. The chest X-ray shows bilateral hilar lymphadenopathy with a patchy infiltrate, a lactophenol cotton blue. Guys, whenever they talk about LPCB and all, you should focus upon what? Fungus. Okay. From a sputum culture shows the following structure. What is the most likely diagnosis? Okay. I told you the mold form. Mold form of which guy? Histoplasmosis. Done by Histoplasma capsulatum. And this is the mold form of that. Which looks like what? Which looks like a sunflower. Sunflower-like or tuberculate macroconidia. Okay. And if you have attended my live lectures along with the lectures of the DocTutorial app, I've told them that this particular one, because I've been to various South Indian states like Surya Gandhi. So I told you it is a feature which is observed in the histoplasmosis, and on this the question will be asked, and they will give it mimics the TB and all. Okay, so chronic histoplasmosis mimics TB. Guys, remember that. And obviously, the answer is histoplasmosis. That is a Darling's disease with a narrow-based budding E cells. With a narrow-based budding E cells. Okay. Now coming to the fifth question, and the fifth one is Group A streptococcus is the most common cause of what? Bacterial pharyngitis in the school-aged children. Which of the following bacterial components is primarily responsible for its attachment to the fibronectin on the epithelial lining of the pharynx? Okay, so what should be the answer? That is the lipoticoic acid. And if you remember up in the lecture, I've told you the positive people, they persist in life. They persist in life means tikte hain. And the gram negative fellows, they get out of the life race. That is the outer membrane. Okay, so this particular feature was also been discussed up in my lectures. So that is there. Lipoticoic acid will be a better answer, and that's why the group A strepto, that is the streptococcus pyogenes, leads to what? Acute pharyngitis. Okay, that is the pharyngitis, which later on leads to non-suppurative complications like ARF and AGN. Okay. Now coming to the sixth one. A child presents with perianal pain and intense itching, especially at the night. On examination, especially at the night, perianal pruritus, typical feature of what? Antrobius vermicularis. Thread-like white worms are seen in the perianal region. Which of the following is the most likely causative organism which have done that? And I suppose in this, they have given up the picture of the egg also. And guys, the picture of the egg is towards what? Obviously, Antrobius vermicularis. And that particular one looks like a plano-convex having a tadpole-like larvae. Having a tadpole-like larvae. Okay, they gave the image of the egg. Okay, brain form. Fine. So I made it that plano-convex along with tadpole-like larvae. That is typical feature of what? Antrobius vermicularis, which is also termed as threadworm, okay, or seat worm and oxyurus. Another thing is that this also associates with what? Auto-infection. This also associates with what? Auto-infection. And most of the feature is perianal pruritus. And this particular egg is bile stained or non-bile stained? This particular one is non-bile stained. Okay. This comes in the mnemonic Neha. Okay. This comes in the mnemonic what? Neha. So sixth answer is A. Now, the seventh one. A patient presents with persistent red lesion on the lateral border of the tongue. The biopsy confirms up the squamous cell carcinoma, which of the following viral infections is most strongly associated with this particular malignancy. So guys, on the lateral border of the tongue, oral hairy leukoplakia also happens, but that is not the red lesion and all. That is the whitish stuff. Important is that Epstein-Barr and HPV, they are the two which associates mostly with the cancers in the DNA viruses. And here the answer will go towards the oral cancers, along with the cervical carcinoma, the oropharyngeal carcinomas, okay, and anogenital carcinomas. They are also being done by whom? Human papilloma virus. So answer would be what, guys? The answer would be HPV. And you know those particular genes, E6 and E7. E6 leads to the loss of what? P53, and E7 leads to the loss of RB gene, that is the retinoblastoma gene. So answer to the seventh question will be what, guys? D, human papilloma virus, HPV. And they are there, which leads to, these are the early regions of the human papillomavirus, which leads to the loss of which particular gene, guys? One is P53, that is E6. This leads to the loss of P53. And E7 leads to the loss of RB gene. Okay, this leads to the loss of RB gene. And you know they are tumor suppressor genes. Their loss will lead to cancer. And that's what the question is. And in this, the answer will be what? That is the HPV. Fine. Then a child or a young adult was there, I don't know what exactly was there in the question, presents with a facial pain and a painful vascular lesion in the mouth. Okay. The Zank smear showed up the multinucleated giant cells. If you observe the alpha Virni members, HSV1, HSV2, okay, they associate with the formation of Zank cells. And what is Zank cells, guys? Multinucleated giant cells with intranuclear inclusion bodies, also termed as Lipskull's body. They're also termed as what? Lipskull's body. Which of the following is the most likely causative agent of this particular one? Okay. So basically, obviously, the answer is towards the herpes simplex 1. And these particular ones are typical of herpes simplex virus, mostly done by HSV1 more than the HSV2. You know, HSV1 causes infection above the waist and HSV2 causes infection below the waist. Is it fine? Now, ninth one. A male patient is there with fever, cough, hemoptysis. Okay. The microscopic examination of bowel fluid shows up septate hyphae with acute angle branching. So, if you have seen up the videos proper, I have told up this is one of the questions which have come around 15 to 20 times. It's a favorite of examiner. The examiner must have suffered from it. Okay. So, that is what aspergillosis. Okay. A, aspergillus is septate. Okay. And mucor is non-septate. And this is that typical 45-degree or 60-degree acute angle branching. This is what is termed as septations for this particular one. Is it fine? So remember this particular aspect also regarding the aspergillus. Now you know all those aspergillus flavus, fumigatus, niger. Okay, those were there. But this is straightforward, I suppose, if that would have been in the exam. 10th one. A patient presents with recurrent diarrheal gonococcal infections. Okay, which of the following investigations is most appropriate to evaluate the underlying immunodeficiency? If somebody is having gono infections, if somebody having meningo infections again and again, that is Neisseria infections are common. Which particular complements are deficient? C5 to C9. What is C5 to C9? MAC. What is C5 to C9? MAC. C1 esterase inhibitor deficiency leads to hereditary angioneurotic edema. And this nitro blue tetrazolium test is done in what, guys? It is done in CGD, chronic granulomatous disease. And this particular test comes what? Nitroglutazoline test. It comes negative in the CGD patients, chronic granulomatous disease patients. This particular one comes what? Negative. Okay. So remember this particular aspect also. The question number 10, the answer is D. C5 to C9 complement deficiency leads to what? Recurrent Neisseria infections. Okay. Now talking about this, a middle-aged man from the endemic region presents with progressive swelling of the lower limb. A peripheral blood smear shows the following structure, which is the most likely cause of this particular limb swelling. Obviously, it is due to the lymphadenitis, lymphangitis, which leads to what? Lymphatic obstruction. Okay, which leads to what? Lymphatic obstruction. And this is what is the basis of acute filariasis. First, it happens and later on chronic filariasis because of that constant lymphangitis and lymphadenitis. And this obstruction happens obviously in the chronic. And that's why the surgical intervention is needed to cure that. Is it fine? The 12th one. Achha, can you tell in the comment section if you are there that in the tail tip of microfilaria of this Wuchereria bancrofti, how many nuclei you observe? Tell me in the comment section if you are there. Okay. There is no nuclei. There is a ban on the nuclei, and that is what is sometimes the question that is also being asked. Because in the Bruchia malaria, we have what? Terminal 2 nuclei. Now coming to the 12th question, guys. A patient presents with chronic meningitis. Okay. Chronic meningitis means TB. The lab findings reveals gram-positive, might be chronic meningitis. One of the common one is TB. Others are also there because the question changes from the lab findings. Gram-positive filamentous branching bacteria. Positive for Zeden stain. Important. I told you this will be asked. And it is asked this time. And there was a confusion with the actinomyces in this particular culture on paraffin bait is a clear-cut indication that the answer is towards what? Nocardia. Okay. So answer is Nocardia asteroids, and they are talking about what? They are talking about what? They are talking about the Nocardia various species. And if you remember that in the class, I told you that you can make a mnemonic for that. Nauka per bat. Okay, Nauka, this Nauka per bat. So that is what is paraffin baiting. Paraffin baiting is actually a carbon rod to which this particular organism attracts and gets cling to that. Okay, baiting. Baiting means to allude somebody to attach. So that is what is C, Nocardia asteroids. If anything else is there, do tell me that also. Okay, question number 13. In a village, several people developed dysentery after consuming the raw milk. The lab examination of the stool reveals gram-negative curved rods. You remember, guys, I told you gull-wing shaped bacteria which is curved. Predominantly polymorphonuclear infiltration is observed. Which of the following is the most likely causative organism for this particular entity? So guys, if you have attended my lectures, you know that curved rod, that is important. Entity of which fellow? Campylobacter jejuni associates with poultry bird products along with the milk products, even water, and associates with what? GBS. That is the Guillain-Barré syndrome. Okay, Guillain-Barré syndrome. It have a strong association. Okay, so this is regarding the Campylobacter jejuni. Now, 14th one. A patient presents with long-standing swelling and the discharging sinuses. I told you numerous sinus and swelling is a feature of actually actinomycetoma. Okay, actually actinomycetoma. I don't know this question came in which way. If it was numerous sinus and swellings, it is actinomycetoma. The answer would have been filamentous branching bacteria straight away. But if there is a confusion that it is towards the eumycetoma and something else was being asked, that can be seen. Okay, that can be seen. And interestingly, if it is towards the fungus side, na, eumycetoma, if you're telling that that was asked, in that also the answer can be towards the septate hyphae with dichotomous branching. Now you will say, why, sir? Because sometimes aspergillus can also do the mycetoma. Okay, do you know that? Aspergillus nidulans is one of the species which associates with causing a what? Eumycetoma. So that can be a twister in the exam if that was there. Otherwise, this is a direct forward, that is filamentous branching bacteria. Which filamentous branching bacteria? Actinomycetes and the nocardia. Actinomyces and the nocardia. Is it fine, guys? Along with that, I have seen up certain questions were there. Like, if you see, there was a question regarding the SCID, severe combined immunodeficiency. And if you see the lectures, I have covered that the second most common cause of SCID is what? The deficiency of adenosine deaminase. That is the enzyme required in the salvage pathway of purine synthesis. And this is a combined B and T cell disorder. You need BMT for this. That is this particular SCID. That is severe combined immunodeficiency. And most common is interleukin receptor gamma. That particular one is deficient. Black granules were there and they asked about what you see in the KOH mount. Black granules were there. Okay. KOH mount. So guys, I told you, this might be a tricky question. This might be towards the Aspergillus, because in Aspergillus, nidulans, a species, can lead to eumycetoma. So that is like in the doubt. This particular question is in the doubt. And regarding the SCID, I suppose somebody have told me question came. Another is regarding the disorders of this MPO, myeloperoxidase, MPO. deficiency. This is there, and the person could not able to have the hypochlorous acid and could not able to kill the organism. So that was also there, the myeloperoxidase deficiency. Okay. So this is a disorder of what? Disorders of phagocytosis. From one a single chapter, two questions came regarding, one is KID and one is regarding the MPO deficiency. Okay. So guys, somebody told up that there was a question regarding the toxoplasmosis also. In the toxoplasmosis, the question was like some lady was there having this IgG antibodies. Okay, some lady was there having what? IgG antibodies, and in the present pregnancy, these particular one were discovered. So what we should do? And if you remember up in the lectures, I have discussed this also, that if you get IgG, there is no need to panic. Previously, she was having, but now there is no problem. Okay, previously she was having, but now there is no problem. So that also is important to be remembered. That also is important to be remembered. And like this, a lot of others were there. Like, you can tell me if you remember any other question regarding the micro, like somebody was saying that something was there. So regarding hepatitis A, something was there. So if you know regarding hepatitis A, what was asked, so that can be included up. In total, I found these from the students, and a lot of students were telling, so a lot of integrated stuff was also there in some of the ways, and the micro was being asked in some integrated fashion also in some of the questions. So you can tell those also if you are there in the comment section. So if you have any doubt and all, otherwise this much I have, and if you tell more, I will be dealing with them later on in the main videos. Okay. Okay, guys. So I suppose if you have done my lectures well on the DocTutorials app, you must have done all of them correct. Okay. I find one trend that nothing came from the journal Microbiology. So any culture medias and all, nothing came of that sort. So that's my question to you. If any other questions regarding culture media and all that was there, do tell me. Okay. Something about plasmodium and all, if it is there, do tell me. And the rest of all, we'll discuss up in the main ones. And be positive. Again, I'm telling up, those which remains positive in life, वही persist करते हैं life में, वही टिकते हैं. Ticoic acid is a feature of gram positive, and those which gets negative in life, they get out of the life race. Okay, this is one of the exams. If it would have gone good, a wonderful thing. Okay, a slight bit altered from your expectations, don't worry. Okay, this is not the last thing. I know it's simple to tell, but not easy to digest. But this is what is there. The now the exam is over. Take a deep breath, take a chill pill, and good night. See you.
So, good evening, my dear doctors. I know you all are very tired, and hats off to your consistency. Even now you are watching the videos. See, I will not take much of your time. So without further ado, let me start with the discussion. This time we have seen that most of the questions were indicated with the pharma or medicine. So let me take the example of first question. A patient is on flight from Delhi to Leh. So again, altitude physiology. Every year they're asking one question from high altitude physiology, and above the sea level, he experiences headache, nausea, shortness of breath, and dizziness. What is reason behind it? Last time they have asked about respiratory alkalosis and carpopedal spasm. What they have asked this time? So we know when we go to mountain, there is hyperventilation causing carbon dioxide washout. This we know already. And hypoxia also causes vasodilation everywhere except pulmonary. You know that. And here, because of increase in the proton, it causes cerebroarterial vasodilation. It is vasodilation. See, at high altitude, the partial pressure of oxygen will drop. There will be again hypoxia, leading to hyperventilation. This we know, and this will cause washout of the carbon dioxide, causing respiratory alkalosis. So, of course, it is going to cause carpopedal spasm. However, in tissues like in the brain, it is leading to anaerobic metabolism, and lactic acidosis will lead to increase. It will increase, and CO2 from metabolism, it will accumulate locally, and this will lead to increase in the proton where in the cerebral interstitium. HAPE and HAZE, the physiology of HAZE and HAPE. High altitude cerebral edema, high altitude pulmonary edema. It is again of acute mountain sickness. So this increase in the proton is going to cause cerebral arteriovasodilation, increasing the blood flow to maintain oxygen supply. So, but this vasodilation can increase ICT. So, main crux is we know increased proton will cause cerebroarterial vasodilation. Then, this is a very straightforward question. A patient present with the muscle cramps, fatigue, salt craving, what would be the underlying diagnosis? Again and again, they are asking a question about Addison disease or the Cushing disease. So, here it is a hypo or hyper. See, there is a muscle cramp, salt craving. It is hypo. So what is the answer? Of course, Addison disease. See, fatigue and muscle cramp because of what? Electrolyte disturbance, decrease in the aldosterone. Salt craving, classic sign of aldosterone deficiency. Okay. You can also message if you want to improve any option over there. Okay. So, Addison disease, decreased cortisol, decreased aldosterone, and this lead to increase in the ACTH. And of course, increase in the ACTH causes hyperpigmentation. There was one more question regarding hyperpigmentation. So, the question here is about muscle cramp, fatigue, and salt craving. And answer will be clear cut: Addison disease. Now, a patient presents with complaints of amenorrhea, galactorrhea. Investigations revealed a pituitary tumor. So pituitary adenoma and high prolactin level. So the triad of prolactinoma. So why there is amenorrhea in prolactinoma? Everyone knows prolactin inhibit ovulation. Prolactin inhibits ovulation. Okay, why this is happening? Because of decrease in the GnRH. GnRH. Again and again, I am discussing this in a multiple level. Even in hypothyroid, there are the menstrual abnormalities. And what is the reason? Because of the increase in the prolactin. So whenever there is prolactinoma, there is low GnRH. And low GnRH is going to cause amenorrhea. Of course, galactorrhea is because of prolactin level. So answer is again very straightforward. It is low GnRH. Next question. A patient comes with the nausea, vomiting, muscle cramps, hyponatremia, hyperpigmentation. See, from the same concept, there are two questions. Okay. Yes, option D was down regulation of estrogen receptor. Okay. There was one more question with this option, down regulation of estrogen. I will come to that. So, what is the reason of hyperpigmentation? So, if you remember, CRH, corticotropin releasing hormone, is stimulating not ACTH. It is stimulating POMC, preopio melanocortin hormone, and this is the precursor of ACTH also, and MSH, melanocyte stimulatory hormone. Okay, MSH, melanocyte stimulatory hormone. So whenever ACTH is more in amount, it start behaving like MSH, and that will cause hyperpigmentation. So whenever ACTH is high, it can cause hyperpigmentation. Why so? Because both are from same precursor. And what is the precursor? Pre-opio-melanocortin hormone. This is divided into ACTH as well as into MSH. So answer will be of course ACTH. So in addition disease, cortisol is low, more of ACTH, it start behaving like MSH, and this will cause hyperpigmentation. Now this question, I have seen that normally questions were from genome, but for the first time I have seen lot of images are from Guyton. If you remember this image, yes. So this image is actually from Guyton, and this is asking about optimum length. It is a collaboration of two concepts. One is what is optimum length, and second is what is Frank Sterling law. There are two concepts which are collaborated in this single question. So Frank Sterling law in the skeletal muscle is actually tension is proportional to the initial length under physiological limit, or you can say force of contraction or tension, both are proportional to the initial length. So more is the initial length, more will be the force of contraction or the tension. So you can see here in the diagram, as you are increasing the length, tension is increasing. Up to certain level, only up to a certain level. After that, it start decreasing. You can see here. Only up to this level it is increasing, and after that it start decreasing. So what is the concept of optimum length? Optimum length is the minimum length. Remember the word. Optimum length is the minimum length. It is the minimum length when tension is maximum or force of contraction is maximum. So that length which has maximum tension but minimum length, can you point out what is the answer? A, B, C or D in that? What is the optimum length? Option is B. C. Yes, you are correct, doctor. Option was B. Point number B. Point number B is optimum length. You are absolutely correct. Optimum length is the minimum length at which force of contraction is maximum. So you can see in this diagram, force of contraction is maximum means what? Shortening of the sarcomere. Okay, they are two Z line are closer with the minimum length. So can you see in the B? Can you see here? The length is minimum. B and C both are having equal tension. As a graph, you can see both are having equal tension, but B is having minimum length. Okay, some of you students are saying that C was also there, but C is actually length will increase. It is around B is 2.25 micrometer. Again and again, I am putting emphasis on this diagram. In my every offline class, if you see the videos of the DocTutorials, I have put a lot of emphasis on this diagram. Optimum length is the minimum length at which force of contraction is maximum. Now see this diagram very carefully. Force of contraction is equal in B and C, but length is minimum is B. So option will be B because it is the optimum length. Is this clear, doctor? So this image is directly from Guyton actually. A female who has a regular 28-day cycle, which of the following hormone levels are expected at day 21 to 25? I hope these options are correct. This is again integrated from gynae. So high FSH, high LH, down regulation of estrogen receptor. Some option, I don't know the exact option, but I will show you the image from where this question is derived. Question is about day 15, sorry, 21, what is the day? You can see here, 21 to 25. Day 21 to 25. It is around this. You can see the red one. The red one is showing about the progesterone, and the blue one is showing about the estrogen. So normally what we are thinking, that after 14 days, estrogen will come down. Of course it will come down. But there is second peak again. Now this is a crux of this question. Normally we are thinking that progesterone is a pregnancy hormone. Progesterone will be more in the luteal phase. It is correct. Progesterone is more in the luteal phase. There is no doubt in that. But estrogen is also increasing in the luteal phase. So that question was exactly diagram from this diagram. You can see here, this is the red one is the progesterone. The blue one is the estrogen. Can you see around 21 to 25 day, there is one more peak of the estrogen? So don't think that estrogen will come down. Both, yes, high estrogen, high progesterone, very good. Sabi, you are correct. High estrogen, high progesterone. You can see here, and this is about the LH. LH is low, FSH is low. So this question was derived from these three images from the genome. So the first was for inhibin. A is after ovulation, B is before. B is before ovulation, A is after ovulation. So A will be more after ovulation and B will be more before ovulation. So A was for inhibin, it was not given in the option. The second diagram is showing the progesterone and estrogen. Both are more during 21 days. Can you see that? Because
Recording in progress.
most of them are saying, sir, estrogen will be less. Of course, estrogen start coming down after 14 days, but there is one more peak. But here you can see FSH, LH both are low. So you are very correct, Dr. Sabir, that high estrogen, high progesterone, low FSH, low LH. Absolutely correct. Your answer is absolutely correct. Of the following values, capillary hydrostatic pressure 18, oncotic pressure 27, interstitial oncotic 7. What will be the interstitial hydrostatic pressure if 0? Fluid will come out of the capillary. So this is from the single concept. You know about that. There are only two types of pressure. One is called as hydrostatic, other is called as oncotic. Hydrostatic will cause movement of the water. Oncotic called the retention of the water. So these are the direction. These are the direction. This is the net flow. If it is 0, if you put the value, it is coming here -2 according to the whatever options I am getting here. So it is a simple concept of the edema. The same concept will be in the edema and same concept will be in the glomerular capillary. Okay, so NFP, net filtration pressure, will be equal to hydrostatic pressure of capillary minus interstitium plus oncotic pressure of the interstitium minus capillary. So by applying this formula, you will come to the value. A 15-year-old boy has sudden growth spurt over 2 years, present with the height of 6 foot 4 inches, coarse faces, headache. What is the confirmatory diagnostic test? Yes, what is the answer? What is the diagnosis? Acromegaly. Acromegaly. So because growth hormone is fluctuating. It is a pulsatile, it is fluctuating, you know that. T half is very less. And even IGF is also, it can be used as a screening, but not confirmatory. So what Harrison is saying, it is again integrated with the medicine, that age matched, it is from Harrison, age matched serum IGF level are elevated in acromegaly. Okay, correct. Consequently, IGF level provides a useful screening measure. So some of you are saying that IGF is correct. It is only screening. Okay. Owing to the pulsatility of the growth hormone, measurement of a single random is not useful. So what is the best? The diagnosis of the acromegaly is confirmed by the demonstrating the failure of growth hormone suppression less than 0.4 microgram per liter within 1 to 2 hours of an oral glucose load. So this will be the answer. So what is the answer? Growth hormone level after OGTT suppression, not IGF. Okay, so this is from Harrison. You can see here, you can check. Okay, so answer is not IGF. I'm telling again, although growth hormone is pulsatile, but you can do confirmation of the acromegaly by doing this, the failure of growth hormone suppression to less than 0.4 microgram per liter within 1 to 2 hours of OGTT. It is the confirmatory, okay? Yes, brain fog, you are correct. IGF was the option. Okay, many of the students were confused the IGF and the growth hormone, but this is the confirmatory answer. I have confirmed this from Gerong as well as Harrison. Both are saying the same thing. Clear? So identify point where pulmonary embolism completely blocks vessel. Again and again, we are discussing pulmonary embolism and airway obstruction. 3 points only we discuss. Okay, so in case of pulmonary embolism, I will not take much of your time. This is your pulmonary embolism. Of course, there is no blood over here. So, whatever is your PiO2 will be same will be your P capital AO2. Normally, in the atmosphere, we have 160 mmHg. In the inspired air, it is 150 mmHg. In the alveoli, normally it is 100. Normally. But here, there is no exchange of gas. So again, here will be 150 mm of Hg. Are you getting me or not? Only then there will be complete obstruction. It is called as alveolar dead space. Pulmonary embolism is called as alveolar dead space. Okay? And there are only 3 points to remember. Number one, pulmonary embolism is called as alveolar dead space. Number two, V by Q ratio will be infinite. Last year MCQ, and this time they have asked P capital AO2 will be equal to PiO2, and it is not going to reduce, so it will be 150. If you see this diagram carefully, dead space. Okay, it is 150. P capital AO2 equal to 150 because 100 is normal. Normal it is 100 because pulmonary capillary will take the gas and it will come down. Air will be PO2 will become down. It will from 150 become 100. But because there is no gas exchange, answer will be this point. This point it can be A, B, C, whatever is the option given in your exam. Okay. Now, a very controversial question again. Lot of questions, lot of students are giving different options. So I am not taking the option, but this diagram from Guyton. See, exact word from Guyton were taken in your exam. Increase in the plasma insulin concentration after a sudden increase in glucose to 2 to 3 times the normal range. The exact MCQ language was this. It is called as biphasic. It is called as biphasic release of insulin. First will be in the 10-minute and then up to 90-minute it keep on increasing. This will be from preformed insulin. Preformed. And this will be from new formed insulin. So it is called as biphasic release of the insulin. First will be in the 10 minutes, other will be up to 90 minutes. So what is happening? What is the answer there? Initial rapid surge in the insulin concentration and then a delayed but higher and continuing increase in the concentration beginning 15 to 20 minutes later. So this will be the question and answer both are in this image of your Guyton. This is from Guyton only. It is saying that there is biphasic release of the insulin. Clear? And the same language they have used, that 2 to 3 times the normal range, and this is going to be the answer. So first it will become high and then after that again it will take this shape. It is called as biphasic release. Is this clear? Okay. So this is it for physiology and a lot of indicated were there. So I will make a separate video of recall afterwards and I will share. Thank you. Thanks a lot.
Okay.
Hello, friends. Good evening. I know you have been waiting for so long, and I'm here with PSM. By the way, guys, how was PSM? I know PSM was very simple, very easy this time, right? There were around 20 to 25 questions from PSM, and few were integrated, which I will not be discussing here because that will be discussed by other faculty in those specializations. And there were around 20 questions which were pure questions from PSM, and those were expected questions, right? Don't say it the other way around. Those were expected. Okay, and we have learned all those questions, but of course, I agree that few were a little bit confusing. But don't worry, we'll discuss all the questions. And let me tell you, first of all, that the intention of this is not to teach you anything. I'm not going to teach you anything here. I know that many are having a lot of confusion. Am I audible? I'm unable to see the chats. Am I audible? Are you able to hear me? Are you seeing me? Because I'm checking the YouTube and I'm not seeing any. It's stuck kind of. Okay. Can you hear me, guys? Okay, okay. Okay, brain fog. Abhina, thank you. Okay, so like I said, I'm not going to teach you anything. When I was scrolling through your messages, I found that there were many PSM questions which you are still confused. So you are asking, few were asking, is it 3? Is it 5? Okay, so those 3, 5 doubt I know is from PSM. And so the main intention of this particular session is to give you an overall view of which were the questions and what are the most probable answers. And as you all know, this is just to recall, the first impression question. So based on which we are assuming that, okay, this is the most appropriate answer. Okay, so just the question, the answer, and why. Let me keep an eye on the time. My intention is to finish it off in half an hour. And this will be later in 2 to 3 days, followed by a good discussion of all these. Okay, so you can wait for that later. So let's start. Interval between a host receiving an infection and a period of attaining maximum infectivity is. What is it, guys? As you all know, the answer is generation time, right? It is generation time. Communicability period is infectivity period, right? The time gap between a person, or it's the time when a person becomes infectious and give disease to another person. Incubation period, of course, you all know. The time between the receipt of infection and showing the first sign. Serial interval is the time gap between primary case and the secondary case. So the answer is generation time. No doubt there. Moving on to the second question. In experimental study, which of the following is the correct sequence? Randomization, manipulation, statistical analysis, follow-up. Guys, this we have discussed multiple times, many times with the help of this picture in class, right? Not only in class, in YouTube, in so many places, we have discussed this in detail. And you know, what is the step? First, you are randomizing, right? You're taking a group of patients, you're randomizing them into treatment arm, control arm. Then you are giving the intervention. Then you are doing the follow-up to see what is happening. And at the end of the follow-up time, you're taking the results to do the statistical analysis, right? You know it. So what is the step, guys? Or what is the correct step? It is 1, 2, 3, 4, like this, right? So it is, the answer here is, what is it? 1, 2, 4, 3. No doubt. Okay, moving further. See one question, problem-based question. Even I'm not very sure what was the exact question. This is what I have received from majority of students. For a population of 70 lakh, slum population is 30,000. Total urban residents were 70 lakh. Number of urban PHCs to slum according to NUHM. I got a lot of doubts from this, madam. What is it? And these were the appropriate options that I could recollect from my group. Okay, 23, 32, 42, 52. Okay, and I think you all will agree with me. These were the options. Okay, so the question is number of urban PHCs to slum, right? See, there are 70 lakh people. So first you have to calculate what is the number of slum population, 30% of the 70 lakh, right? That means 21 lakh, right? 30% is 70. Now you want to know what is the proportion of UPHCs for this 21 lakh? How many UPHCs will be there? Do you know, in INI last year, not this year, INI last year, there was a question. The population, urban PHCs per population, it's usually 30,000 to 50,000. Okay, but if it is a slum where you get a concentrated population, densely populated population, you know, they'll be close together. So there, one UPHC, you can say it is for 50. Okay, so there are total 21 lakh people who are in slum. So per 50,000 people, one UPHC. So it is 42. Okay, guys. So the correct answer here is 42. 42. Okay. Moving to the fourth one. De facto census. Individuals are counted based on, my God, I was expecting this question for so long because we have discussed it many times, but never it came. I said, okay, you can keep it as a reserve. Someday it will come. And this is the day, guys. It has already come. See, all these are from our classes. Okay, so these, whatever I'm showing you is from the classes. You know, census, we have de facto system and de jure system, right? De facto means, as a matter of fact, where you are found, you will be considered as a person belonging to that place where you were found at the time of enumeration. Okay, whereas de jure, you know, as per the jurisdiction. Wherever you are found, you will be counted as a person belonging to your jurisdiction, right? So what is the answer? Place on date of enumeration. If you are found in Delhi, you will be counted as a person in Delhi. If you are found in, you know, Chennai, you will be counted as a person in, you know, there. Okay, Tamil Nadu. So like that. What is the recommended reduction in dietary cholesterol intake to prevent cardiovascular risk? See, this is from PART. We know that it is said that per, you know, when you are taking, see, the total, the cholesterol should be less than 10%, right? Less than 10%. Your dietary intake should be less than 10% of your total calorie, right? So it is this. Moreover, we know that it is 300 that is recommended. Should be less than 300 when you are taking a, you know, when you calculate for 2,500 calorie. So considering all that, it should be 100 milligram per 1,000 kilocalorie. Okay, moving to the next. Simple question. A person from Chittoor, Andhra, he is presenting with outward bending of leg and is diagnosed with osteoporosis. Okay, outward bending means genu varum, right? So this is a case of genu varum. So the question is genu varum. Patient has genu varum, osteoporosis. Which is the following public health measure you will not do? That is a question. Okay. There are some clues. One, Andhra. It is known for endemic fluorosis. Do you know that? It is known for endemic fluorosis. Moreover, all these are, you know, genu varum, osteoporosis, all these are pointing towards endemic fluorosis. That means there is increase of fluoride or increase of fluorine in water. Okay. So which of the following will not be done? You don't have to give fluorine supplementation, right? Fluorine supplementation is not required. This is not required. Okay, sorry. This is not required. Whereas all others, you do to remove fluorine, because all these are because of excess of fluorine. You don't give any extra fluorine. Instead, you have to remove. Like, you know, provide running surface water. You know, new source. Change the water source. It is again same. Use of alum and lime. This is your Nalgonda technique to remove excess fluorine, right? So B, C, and D will be done, whereas A you will not do. Okay, guys? me just refresh my. I'm not seeing your chats. I'm not seeing anything in YouTube. I'm so sorry. I'm unable to see anything at all. Okay, now I can see. Now I can see. So sorry. Okay, now only I'm seeing your messages. Okay. What next? See, this is from the class. You all know we have discussed everything. And as you can see, skeletal fluorosis, all these fluorosis is happening when the fluorine content goes about a particular cutoff, right? Question number 7. Which of the following tests is most appropriate to compare mean hemoglobin between two independent groups? There shouldn't be any doubt because we have discussed this in and out, right? Two different groups, outcome, mean. They have directly given. You don't even have to guess that it is mean. Okay, they have directly given. You can't expect any more of simpler question from this. So two different groups, outcome, mean. What is it? Oh, I think you're unable to see if I write in this color. That's the, I don't know what background to choose. I mean, which color to choose because even I myself can't see what I'm writing. Okay, if I write in, are you able to see, guys? Okay. Or it's better I don't write anything. Okay, so two different group, outcome, mean. It is students t-test, right? But they don't have given students t-test. Is there any other name which is suggesting students t-test? It is unpaired t-test. Okay, paired you do when you're same group before, after. ANOVA, more than 3 or more than 2, right? 3 or more. And chi-square when the outcome is proportion. So the answer is B, students t-test or unpaired t-test. Moving to the next. A patient diagnosed with fever and dry cough was confirmed to have COVID-19. He died in a district hospital later, 7 days later, his death was reported. What is the answer? I'm not waiting for your answer because I know it will take some time. Write with white. Okay, Pradhan. Sorry, no option for white here. It's okay. Anyway, I think, this is okay. I'll use this pink color hereafter. What is it? Someone is dying in the hospital. So naturally you have to, as a natural process or as per the, existing guideline within 21 days, you have to report it. So that is passive surveillance, right? Passively, something is happening in the hospital and you're reporting it. That is passive surveillance. Active means you're actively going in search of something and you're trying to find it out. Syndromic, like you have in STD, it is syndromic surveillance. Sentinel surveillance is something that you do in HIV. You know that, right? So that is different. You're selecting some sentinel sites and you're doing, this is just passive. Okay, deaths, births, all these are being reported. Okay. What next? What is the recommended weekly dose of iron and folic acid for adolescent 10 to 19 years? I know there is a confusion among you guys because in group, I have seen two different answers coming. Okay, guys, the correct answer is, we have already discussed in class. It is 60 milligram of elemental iron and 500 microgram of folic acid. So this is from our class. Okay, from the class, we have already seen. Okay, for adolescent, it is 60 milligram of elemental iron and 500 microgram of folic acid. And the doubt was that few were saying it was discussed as 100 in some places. I don't know. In some platforms, you said it was discussed as 100. I don't know. So since you have a confusion, what I did was I took a picture. Okay, so the first picture is something that I took from my hospital 2 hours before. Okay, 2 hours back, I took it. Okay, that means, see, this is what you give for the one you give for adolescent. As you can see, it is 60 milligram of elemental iron and 0.5 milligram. That means 500 microgram of folic acid. That means while you were writing this exam, I can ensure you that it is 60 milligram of elemental iron and 500 microgram of folic acid. No doubt about it. Okay. It's not 100. Okay, image-based question. Okay, so simple. I don't want to discuss because you already know it. Vaccine vial monitor. The same picture I have taken in QRP, in HIT sessions, in usual classes, everywhere. See, this is the picture that I always use. And same picture they have shown in the exam, right? So you shouldn't be having any doubt. Which all you can use? We know this is stage 1. This is stage 2 of vaccine vial monitor. This is stage 3, stage 4. And you know which all can be used. Stage 1 and 2 can be used, right? So the answer is 1 and 2. If the question was which all can be used, it is 1 and 2. Okay. Which all cannot be used is 3 and 4. 3 and 4 you cannot use. You have to discard it. Mosquito larva is examined under a hand's lens. Very, very simple question. No siphon tube. Look at this. No siphon tube. There is palmate hairs and it is resting parallel to water surface. What extra you want to answer this? Which is that mosquito? I'll show you what I have shown, what I have taken in the class. In every class that I take, I'll show you this picture and this table. Exactly what I have written. See, the same key points they have shown. They have given in the question. Okay, see, Anopheles. It is Anopheles. There shouldn't be any doubt. And I'm sure you don't have any doubt. Okay, so this is Anopheles. Oh, okay, Avinash is saying 400 microgram was given, but it's not 400, Avinash, it is 500. Okay. I think there is a delay I'm using a different platform, you're using YouTube. So there is a small delay. Okay, a study was found that breast cancer screening increases 5-year survival rate, but there is no change in the overall mortality. What type of bias does this suggest? This also we have discussed. What bias? In screening, the main bias that you see is lead time bias, right? You know what is lead time. So that means the people are dying as usual, but there is a, apparent increase in survival rate, which is because of lead time. I'm not going to tell you what is lead time. We have discussed. See, using this particular question, we have discussed. This is from the class. Okay. And I've told you what is lead time bias. So nothing more, nothing less. Very evident is lead time bias. During a community medicine demonstration, medical students are instructed to perform Nalgonda technique. It's a nice way of asking question. They have asked about Nalgonda in a different way. Each student is asked to bring 2 material bags for the set shown below. So they have shown some pictures like bag A, bag B, C, D. And bag A was having alum, then gypsum, charcoal, lime. Which all combinations will you use to correctly perform Nalgonda technique? Which all? See, I'll show you the picture. This we have discussed in class, right? With the same picture, we have discussed what is Nalgonda technique. By the way, what you know, Nalgonda is for defluoridation, right? There was a question, someone from, some question was there from fluorosis, right? There they have discussed about lime and alum. So in Nalgonda, you are adding lime and alum, then you are flocculating, sedimenting, filtrating. Then you are adding bleaching powder. That is what you do in Nalgonda. So what is the answer there? Guys, which all will you add? You have to take bag A and bag D. So the answer is A and D. Okay. I know I'm going very fast, but you're understanding, right? We don't have that much time. A 3-year-old child presents with bowing of leg. Again, genu varum. Okay. Which of the following nutritional supplementation program specifically covers children under 6 years? Whenever you hear under 6 years, of course, the one flagship program we have is ICDS, right? Integrated Child Development Services. You know that. Okay, there is no doubt about it. And I don't think anybody has any doubt here. Under 6, see, this is vitamin D deficiency, right? The child is having vitamin D deficiency. That means it is a nutritional deficiency. Bowing of leg is because of nutritional deficiency. The question is, so which is the nutritional program we have for tackling under the children below 6 as far as nutrition is concerned? It is ICDS. Of course, it can't be midday meal. That is for school-going children, right? They are above 6. Anemia Mukbarak, that also, that is iron folic acid. National Nutritional Deficiency Program, that is not a standalone program. It is integrated with so many other programs. So the answer is ICDS here. A community level intervention is being evaluated. Researchers randomly allocated 20 primary PHCs to receive a standard care, another 20 PHCs to receive some other intervention. Okay, the most appropriate classification of this study is, what is it? Of course, this is not case control. This is not cross-section, right? So this is RCT. Which RCT? See, it's an experimental study design. What is it? It is not people, but PHC. That means a cluster. PHC is it's a unit that has got a cluster of people, right? So this is cluster RCT. Quasi is half cooked experimental study. There you are not doing any proper randomization. This is properly done. Only thing is that instead of patients, if it is had it been patients, then you could have said, okay, this is RCT. Since it is PHC, it is cluster randomization. Okay, see, in cluster randomization, you are allocating in one group some social groups like, villages, schools, hospitals. In this question, it was PHC. That's it. So it is cluster randomization. That means cluster RCT. We are almost done. Which of the following is the most appropriate method used in health planning to assess the objectives and targets are being fulfilled and to evaluate the quality of outcomes? Of course, this is the definition for. This is again from the class. If at the end of the planning, if you want to know how far we could achieve the set objectives, you're going for evaluation. So here the answer is evaluation. I don't have to tell you anything more. You know it is evaluation. Then how far we could achieve the objectives. A 7-month-old. Okay, I know there is a confusion. Now, if this is the question, we have an appropriate answer. A 7-month-old child is on complementary feeding along with continued breastfeeding. The child is given a katori of semi-solid millet food. What is the recommended frequency and amount per day? See, for a 7-month-old child, the recommended is usually half katori. Okay, half or 3/4 katori, and around 3 times is what the recommendation. Okay, so half katori usually 3 times. Okay, so this is the answer. Okay, this is as per our various major guidelines. Okay, we'll have a proper discussion later. There is a report of toxic fumes leaking from a nearby chemical factory. What should be your immediate action? Oh, this is something which you can do even with your common sense. Okay. In class, I have told you, with the help of this web series, I have explained what to be done. Railwaymen. It is based on the Bhopal gas tragedy, right? There, KK Menon, he is asking all the people in that, in that railway station to close the door. When someone is trying to open the door and get out, he's saying, don't do that. That will let the toxic gas in, right? So what is the thing that should be done? Guys, open windows for a ventilation. Don't do that. Okay, this is wrong. Give a call to a friend. That is okay, but that is not what you should do immediately. But what can a friend do when there is a toxic fume coming in? Seal the cracks and windows. That is what you should do, because you should avoid this toxic gas getting inside your room and escape without instruction. Okay, that is up to you to decide. So guys, see, this is the guideline as per NDMA and WHO chemical hazard poison. Okay, stay indoor, seal all the cracks and crevices and wait for official instruction. Okay. A pregnant woman is diagnosed with infection at 34 weeks of gestation. Her viral load was 1,200 copies per ml, and she was started on ART. She delivers a 2.5 kg baby at 38 weeks. What is the most appropriate postnatal prophylaxis for the newborn? This we have discussed many times. Moreover, in yesterday, I gave you a few tips and few important topics. There as well, we have discussed this, right? We know the treatment or the prophylaxis is based on whether it is a low risk infant or a high risk infant. Now, can you say whether this is a low risk or a high risk infant? See here, the viral load of the mother is more than 1,200 at 38 weeks of gestation. So that is the point that will help you to know whether it is a high risk infant or a low risk infant. For a low risk infant, after 32 weeks, the viral load of the mother should be less than 1,000 copies, right? So naturally, this is a high risk infant, right? And for high risk infant, you have to give dual prophylaxis with nevirapine and zidovudine. And how long it should be given? If it is a breastfeeding mother, you have to give it for 12 weeks, right? So what is the answer, guys? It is both nevirapine and zidovudine for 12 weeks along with exclusive breastfeeding. Okay. And the last question. Again, from what we discussed yesterday. Many questions, almost out of this, almost 15 questions we have discussed yesterday. A patient recently diagnosed with HIV presents with TB symptoms. What is the most appropriate initial management? Again, from class. This we have discussed in class. Under HIV TB co-infection, right? If someone is found to have HIV TB co-infection, which one you have to start first, ATT or ART? You have to first start ATT, right? Then you have to reduce his signs and symptoms, make him non-infectious, wait for minimum 2 weeks. Thereafter, you start the patient on ART, right? Because of IRIS, immune reconstitution inflammatory syndrome, right? So what is the answer here? Start ATT first, then initiate ART after 2 weeks. It's all straightforward questions. So I think now your confusions have come little bit down. If you have any doubt, you can always contact me. Okay. So guys, thank you for your patient waiting, patient listening, and best wishes for the results. Keep your expectations high. My prayers for your success. Okay, bye.
Wasting any time. So the first question was a stat question, which I'm sure all of you would have marked it correctly only. So this was a male patient with headache. MRI showed a CB angle mass, and the biopsy was shown. All of you know these are verrucate bodies, and your diagnosis here was schwannoma. I'm sure all of you would have marked it. Yeah, so that was schwannoma. Let's go to the next question. So this was an elderly male with cervical lymph node and bleeding tendency. So basically more than 20% blast and microscopy was shown of faggot cells. Okay, so they were actually bundles of rods. So these were faggot cells. So whenever you see faggot cell, the diagnosis is acute promyelocytic leukemia, and the answer is translocation 1517. So there was no doubt in this. I'm sure all of you did it correct. Coming to the next, this was the question number 3. So this was a second. So yeah.
Okay, so question number 3 here. Question number 3 was, is my screen moving? Yeah. So next is a patient present with midline neck swelling. Histology shows a myeloid deposition. IHC shows synaptophysin positivity. Which of the following is diagnosis? So once you see a myeloid and they give you synaptophysin positivity, this is so typical of medullary carcinoma of thyroid. Don't overthink it. Okay, once you see a myeloid deposition and your neuroendocrine markers positive, it is medullary carcinoma. That's it. Okay. Coming to the next one, the gross specimen of the liver shows a well circumscribed lesion. And what is the diagnosis? So once you see the central scar, all of you know, once you see central scar, this is focal nodular hyperplasia. I've told you so many times, central scar is seen in very few conditions. There are 4 basic conditions you should remember. But here, for now, we're just discussing the answers. So the answer to this is focal nodular hyperplasia. It shows you central scar, okay? Next one, it's an elderly male presents with bilateral cervical lymph node enlargement and immunohistochemistry shows 10 and BCL2 positive cells. All of you know, whenever there is CD10 positivity along with BCL2, this is so characteristic of germinal center. In germinal center, normally BCL2 should be negative. Agar BCL2 is positive in the germinal center along with CD10, it has to be follicular lymphoma. And the answer is definitely translocation 1418. That is follicular lymphoma. So that is clear in this. Coming to this, caspases are central mediated of which program cell death. So everybody should be very clear on this point, that whenever we are talking about caspases, they are mediator of which death. So one, apoptosis, everybody knows. Now next you have to think of it. So pyroptosis involves caspase 1. So this is pyroptosis and apoptosis. Necroptosis is caspase independent apoptosis. Necrosis में तो होता ही नहीं है, ferroptosis में भी नहीं होता है. So the answer is pyroptosis and apoptosis. A patient presents with mild anemia and jaundice, and then they had typically showed you elevated MCHC. Again, guys, I've told you so many times, elevated MCHC. Once they give you elevated MCHC, the diagnosis is hereditary spherocytosis, because spherocyte is the only condition apart from dehydration where your MCHC is increased. Okay, so that has to be very clear. So once they give you this, you know the answer is spherocytosis. And if you have studied, I've told you so many times, raised MCHC with increased red cell distribution width is characteristic feature of spherocytosis that you should remember. So the answer was that. The young female presents with long marfanoid habitus and ectopic lentis. Everybody, this is a googly question. Everybody would have done it correctly. This is Marfan syndrome and fibrillin 1. Okay. Next, coming to this. So this also we had discussed in the Zoom session. I have discussed this before the exam. If you have attended that Zoom, you know this. We have discussed this, that CNS may craniopharyngioma is one of the questions that they always give you, and especially they mention one term called wet keratin. Okay, so that is the term that they always use you. So supracellular mass, wet keratin, and I told you, if you get a net like structure somewhere, okay, so they give you net like structure, then it is all craniopharyngioma. So all these are pointers towards craniopharyngioma, which you should be very clear. Other options were clearly out, so you could have ruled that out. Coming to the next, this is the easy pedigree. All of you did it correctly. So I'm happy to say you know it. This is mitochondrial. So when mother has a disease, all children had the disease. When the father had the disease, no child had the disease. But when mother has, all the children had mitochondrial. So you have to identify out of these which is mitochondrial. You know, Kearns-Sayre syndrome is a typical mitochondrial inheritance. There are very few disorders with mitochondrial inheritance, and we should know all of them. Right? Prader-Willi of imprinting, we know that. Achondroplasia is dominant, autosomal dominant, and Huntington's is trinucleotide repeat mutation. Coming to this, a patient presents with pain and swelling of the knee. This also we discussed in the Zoom session, and I posted on my Insta also so many times. Gout should always remember the code PCR I told you. Okay, so PCR and gun. Okay, so I told you, whenever you have pseudo gout, remember that it is due to calcium pyrophosphate, and it has rhomboid shaped crystal, and it has a positive birefringence. So this was typically given rhomboid shaped crystals. So you know rhomboid shaped crystals has to be pseudo gout. Gout is urate crystals and negative needle shaped crystals and negative birefringent. Okay, so that has to be super duper clear. So which of the following laboratory technique is most commonly used to compare and quantify CD markers? So this is actually immunophenotyping. But if immunophenotyping was not given in the option, it is flow cytometry. That is what you have to be very clear. It is flow cytometry that you have to know. ELISA, Western blot, and immunohistochemistry not. Immunohistochemistry is with protein. Western blot is also for protein. ELISA is for antigens or antibodies. Okay. Right. Come to 14. So, anti-SCL70 antibody, that is anti-topoisomerase antibody, is associated with which of the following complications? So, this is so typical of interstitial lung disease. Okay, so you have to be very, very clear of interstitial lung disease. This is typically. Arsh, Amira, Dheere, bacho. Okay, so anti-SCL antibodies typically associated with interstitial lung disease that you have to be super duper clear with. Okay, so I've just made a chart for you here. You should remember we have discussed it. Anti-centromeric antibodies typically associated with CREST. That is what you have to be very, very clear. And as anti-SCL antibody, if you see, look at that, so that we know that it is associated with interstitial lung disease. Now, there was a doubt which students said, ma'am, interstitial pulmonary fibrosis was given or interstitial lung disease was given. Suppose if these were two separate options, you have to be very, very clear. Your answer should be interstitial lung disease more than interstitial pulmonary fibrosis. Okay, so interstitial lung disease may be more commonly, it is especially non-specific interstitial lung disease which is there. Okay, IPF can be associated, but it is less common. Remember, CREST is typically associated with anti-centromeric antibody. So this is out, and GAVE is associated with RNA polymerase antibody. So that also is out. Okay, so that is what you have to be very, very clear. Okay, anti-mitochondrial antibody is typically associated with which of the following conditions? You already know this was a googly question again. It is primary biliary cholangitis. You know that primary sclerosing cholangitis, if they give you, it is basically associated with P-ANCA. So I hope you have not done that wrong. Autoimmune hepatitis with ANA antibody, and Wilson's is not there. So it is primary biliary cholangitis that you should be clear. Coming to the next, patient presents with 1 month history of cough, chest pain, dyspnea. Imaging shows bilateral hilar lymphadenopathy, non-caseating granuloma. Asteroid bodies was given. Some people told me, ma'am, stellate bodies was given. So whatever was given, non-caseating granuloma with star-shaped bodies inside it, it is asteroid body, and the answer is sarcoidosis. Okay. Now, this is a 45-year-old male presents with rapidly progressive swelling, pain, foul-smelling discharge, discoloration of the hand following a traumatic injury. What is the diagnosis? So, this is a classical example of wet gangrene. You know that there is swelling. There is no demarcation between the normal and abnormal. So, it has to be a wet gangrene. So, the answer has to be wet gangrene. Okay. So, dry gangrene does not look like that. Dry gangrene, where tissue becomes shriveled. So, there is a very well demarcation between normal and abnormal. Okay, a patient presents with frothy sputum, hemoptysis, paroxysmal nocturnal dyspnea. On exertion, lung biopsy shows you hemosiderin-laden macrophages. You know, they're typically talking about chronic venous congestion of the lung. So which of the following is least likely to be associated with it? So you know that most of the time, you know, I am sure this was one question which would have made you confused. So typically associated with left heart failure, which causes backflow and causes chronic venous congestion, that everybody knows. Okay, so now what you have to mark is, so out of these least likely, if they're asking it, so volume overload can do this. Now pulmonary vein constriction, pulmonary hypertension can also do this. Now doubt was right heart failure or protein losing enteropathy. Both are tricky questions, both are tricky options. So what I will choose more with is protein losing enteropathy. So protein losing enteropathy has no direct connection with your CVC lung, whereas right heart failure can lead to left heart failure and it can cause CVC lung. So both of them are actually not correct. Okay, both of them are actually not correct. Both of them are actually wrong. But if you have to choose one more wrong than the other, then I would preferably choose protein losing enteropathy. I'm not sure what will be the exact key with people, but yes, I would choose protein losing enteropathy as a better option than right heart failure, because right heart failure can indirectly lead to volume overload, congestion, and left heart failure and cause your CVC lung. Protein losing enteropathy direct connection nahi hai iska. Okay. So coming to this, a middle-aged female presents with dry eyes and dry mouth. The laboratory shows you a typical anti-Rola antibodies. So what are we looking at? So you know this very well, guys. Whenever we are talking about Rola antibodies, you know we are talking about Sjogren syndrome, and you know Sjogren also was it is a PYQ. It has been asked earlier also, so you have to be very, very clear with this. So remember, what was it? There were lymphocytic destruction of the exocrine glands or minor salivary gland. It is not by the neutrophil. It is lymphocytic infiltration and destruction of the minor salivary gland. So that is one thing which you have to be very, very clear. So that's the key mechanism here. They ask you most likely mechanism. So that's the most important mechanism. Coming to the next, which of the following is immunophenotyping? This was a repeat question which came from your FMG also 2025. So you know that 523 is a typical marker for CLL. So I had posted a PDF also for the FMG recall in my groups. So I hope all of you would have seen that. And so this was a direct question from there. Again, this was also a direct question from the FMG 2025. We had posted and discussed this in group also. So this is basically lateral border of tongue. They showed you cancer. This is squamous cell carcinoma in the tongue. So oropharyngeal. Some people told me, ma'am, it was at the base of the tongue. So oropharyngeal and oral cancers are very classically associated with HPV. So they are very, very characteristically associated with papilloma virus. Okay. So remember, some people say why it is not Epstein-Barr virus. So Epstein-Barr virus basically causes nasopharyngeal carcinoma. That is more common in that. Okay. So remember that. So HPV is typically associated with oropharyngeal and oral cancers. Okay. So that is one thing you have to be very, very clear, especially HPV 16 and 18. Okay, so this was again a tricky question which many of you did wrong. So in which of the following condition there is a factor 9 deficiency and curable by injection, vitamin K injection. So you know that 2, 7, 9, 10 up. So these are vitamin K dependent factors. So देखो factor 9 deficiency या hemophilia में we will not give vitamin K injections. Vitamin K injection we'll give whenever there is a chance of approval. So if a patient has hemophilia, you would like to give him factor 9 concentrate. You would not like to give him vitamin K injection. You will give vitamin K injection where there is non-absorption of vitamin K dependent factors. So this is typically seen in vitamin K bile duct obstruction. So whenever there is a bile duct obstruction, that leads to malabsorption and vitamin K dependent factors are not absorbed. So if you give vitamin K from outside, it improves it. So the correct answer to this is bile duct obstruction, that you have to be clear. So that's all, guys. So I think this is the time for you to rest, recover, and enjoy. And yeah, you know my Instagram. You can follow me, and all the very best. Take a good rest now.
Okay, guys, I hope I'm audible. I hope everything is clear right now. Please put a thumbs up or say that you're actually hearing me in the chat box. Yes, I hope my voice and video are clear. Okay. Thank you. So we'll start with the session, buddy, without any further delay. Don't worry, I will not be taking too much amount of time off because you're having a very important time right now. You might be very much tired from the morning. Congratulations, you have finished off your exams. And this is like the most important step, which most of the students are not able to do that, right? People tend to get feared of the exams, but you have crossed it. So of course, you're having enough amount of times. In like few minutes, I think all these sessions is going to be over. We'll start with the first question with Famak. Again, this is primarily based on a recall from certain students who used to think of it. But again, there'll be lots of issues. There might be lots of issues. We try to make sure that we're around maximum correct options has been put up in the questions. We'll start with the first one. A diabetic individual with HbA1c 8.8, HFrEF, heart failure with reduced ejection fraction. In metformin and insulin glargine, drug to be added is pioglitazone, empagliflozin, glibenclamide, and sitagliptin. Here the take-home point is this patient is a known diabetes mellitus. Patient is a known diabetic individual, and his HbA1c levels are not under current control, and he is currently under therapy with metformin and insulin. Yep. Also, the additional point to be noted is this patient is also having heart failure with reduced ejection fraction. So in these cases, the primary take-home point is you have to think of the options. First option, pioglitazone. It is absolutely contraindicated, guys, because this drug might induce fluid retention leading on to heart failure. Empagliflozin, that is the answer for this question. Understand that, because gliflozin drugs, which comes under a classification named as SGLT2 inhibitors, are currently the treatment of choice in terms of heart failure with diabetes mellitus, because it has got lots of advantages. It might decrease the fluid volume also, but please note down, SGLT2 inhibitors are contraindicated in type 1 diabetes mellitus patients because they are more prone to land up in diabetic ketoacidosis. That's the take home point over here. The next one, glibenclamide. Why this is not the answer in this point? Glibenclamide is a good drug. It has got a powerful hypoglycemic producing capacity, but it will produce very severe hypoglycemia when given along with the insulin. And that's why, because this patient is already under insulin, the question is clear, which drug is to be added in this patient, not changed, which drug is going to be added. In those conditions, I cannot add glibenclamide along with insulin. It might produce very severe hypoglycemia. The next one, sitagliptin. Yes, it is a good drug, but unfortunately, it is not like shown any proven efficacy against heart failure. So the answer for this question, is empagliflozin. Well, that's the answer for this question. Moving on to the next one, guys. If you have any doubts, please put it up in the chat box. Very much happy to answer this. And as usual, within maximum 10 minutes, we'll finish off our mark. Don't worry. Mechanism of renal calculi formation in a patient with hydrochlorothiazide. According to me, I will say that this is one of the most important, very twisty questions and mind-bending questions which has been asked. Because we all know that thiazide diuretics can be used for the prophylaxis or prevention of development of renal stones. But unfortunately, here they have asked this drug like thiazide diuretics might induce development of renal calculi. What might be the reason behind? I'll explain the concept here. So consider here is where your glomerulus is, and here is where your proximal convoluted tubule. Good. Inside, we have calcium molecules, like 1, 2, 3 calcium molecules are there. Just for an example, I'm saying I have drawn 3 calcium molecules here. And what happens is we have phosphate, like phosphate molecule might be binding up with that, or oxalate molecule might bind with that. These two molecules, whenever it is formed, whenever it is binding up with calcium molecules, it might induce stone formation. Calcium oxalate crystals and calcium phosphate crystals might be formed inside the urine. And what about the other molecule? This is prevented from binding up with oxalate or phosphate because it has been binding up with citrate. Okay. Whenever calcium is binding up with citrate, the binding with oxalate and phosphate is prevented from happening, right? So simply put, only if it is binding up with oxalate and phosphate, we can expect the stone to be formed. Here, there is no oxalate and phosphate which is binding up with calcium because one calcium molecule is bonded with citrate molecule. Now, when you have administered your thiazide diuretics, we all know that thiazide diuretics are involved in calcium reabsorption. So these two calcium molecules will not be there. Calcium is going to get reabsorbed. So at the same time, one calcium molecule will still be there. Not all the calcium is going to be reabsorbed. Some calcium will still be there inside the urine. So how come the stone is getting formed? Already is bonded with citrate, right? But the issue here is thiazide diuretics will not only increase the reabsorption of calcium, it also prevents the excretion. It also prevents the excretion of citrate. So we have this citrate molecule which is accumulated there inside the blood. So there is no citrate there inside the urine. So what about that one molecule of calcium? This will form a bond with the oxalate. This will form a bond with phosphate leading on to stone formations. So here the take home point is mechanism of renal calculi formation in a patient with hydrochlorothiazide, increased calcium excretion, no, decreased calcium excretion, that might be the reason. If the question, that might be the answer. If the question is mechanism of how thiazides can be used to prevent development of renal calculi. But here increased oxalate excretion, no, decreased citrate excretion, well, that is the answer for this question, guys. If this recall is right, if this recall regarding mechanism of renal calculi development due to hydrochlorothiazide is right, then the answer would be option D. If the recall is there is some issue like what might be the mechanism of how thiazides can be used to prevent development of renal calculi, then the answer would be option B, like decreased calcium excretion. I hope the recall is right. If you have any issues with the recall, please put it up in the chat box, guys. Okay, very good. We'll move on further. Patient on hydrochlorothiazide for 10 years complains of bilateral lower limb swelling for the past 2 months. Horizontal nystagmus, bilateral symmetric motor sensory neuropathy, heart failure, not an alcoholic, deficiency of which can cause this. This is more of a biochemistry related question, guys, but of course, we have lots of pharmacological inputs here too because of the single drug hydrochlorothiazide. I'll be explaining that, don't worry. See, the patient is under thiazide therapy for a very long and the patient has developed like sequence of symptoms over here. We look into the first option, selenium. Selenium is associated with cardiomyopathy, guys. Selenium is associated with cardiomyopathy, which is, we used to call them as Kishan's disease. That is not associated with heart failure because here, this is the primary statement. As you can see over here, heart failure, only certain drugs will be inducing the development of heart failure. We'll look into that. Vitamin B12 might be producing neuronal deformity, like your bilateral motor sensory neuropathy might be developed because of B12 deficiency, but it will never induce heart failure. It will not induce failure rates. What about zinc? Zinc, if the patient is having decreased amount of zinc, patients might not be developing any neuronal or cardiac abnormalities. So there will be no neuronal or cardiac or heart failure abnormalities seen with zinc. All of these symptoms which has been explained about is primarily oriented towards thiamine because thiamine deficiency might lead on to the patients developing wet beriberi. Well, that's what this patient is suffering from. This patient is suffering from wet beriberi because of course there is fluid overload inside the body leading on to wet beriberi, which is a classical feature of vitamin B1 deficiency. Now we'll look into the pharmacological perspective. How come a patient who is under thiazide therapy might develop B1 deficiency? Thiazides are actually what type of drugs, my dears? Diuretics, guys. Diuretics means it's going to be excreting out water from the body. If water is getting excreted out, more water-soluble vitamins are also going to be excreted out from the body. Well, that's the reason one of the most important water-soluble vitamins, vitamin B1, is getting lost, and the patients might land up in wet beriberi. This is seen not in acute therapy, as we can see clearly in this question. On a long-term therapy with like thiazides or any diuretics, patients might develop this adverse effect. So the answer for this question is option C, thiamine. The next one, guys, child with high-grade fever and seizures, drug of choice for emergency management. Most of you would be knowing it. This is clear-cut, no, taken up from a PYQ. Febrile seizures. What's the drug of choice? Febrile seizures, what might be the drug of choice? Diazepam will be the drug of choice. Clear? Ethosuximide is a drug which is used for absence seizures, guys. It is not used for febrile seizures. Fosphenytoin can be used for status epilepticus as a second-line therapy, not as a first-line therapy. First line is always going to be benzodiazepines, like your diazepam, which we have given. Valproate can be given, but it cannot be used for acute therapy. Again, valproate can be used only for chronic conditions. So the answer for this question is clear-cut, diazepam. By which route do we give, my dears? Intravenous, or it can be given in terms of per rectal route. Either we can give it via IV or per rectal based on the age of the patient. Because this patient is a child, we can give it via per rectal route of diazepam. If the option is per rectal diazepam and IV diazepam, well, I will choose per rectal diazepam because the patient here is a child. Okay, we'll jump on to the next question. Patient in haloperidol for schizophrenia develops symptoms of orofacial dyskinesia. That's it. I don't want to look into the other forms in the question. Be it tics or coriform movements or dystonia, anything it's going to be. We have this magical terminology from our sessions. We have explained that multiple times. Orofacial dyskinesia itself is going to be explaining what? This is what orofacial dyskinesia means, and that is nothing but tardive dyskinesia. Yep. Actually, I'm not suffering from anything. I just explained that how patients might be explaining. So tardive dyskinesia, well, that is the answer over here. Treatment for tardive dyskinesia is valbenazine. What's the concept here, buddy? Valbenazine is a VMAT2 inhibitor. VMAT2 inhibitor. The primary reason for tardive dyskinesia is increased release of neurotransmitters into the synapse. Usually what happens, those neurotransmitters will be reuptook back inside the presynaptic terminal. It will be accumulated there in the cytoplasm. But it cannot be accumulated for a long time in cytoplasm because monoamine oxidase will break it down. To prevent that, these molecules will gain entry into the vesicles via this VMAT. So whenever this VMAT2 is getting blocked, All these neurotransmitters will be accumulated where? Inside the cytoplasm. Monoamine oxidase will quickly break down all these neurotransmitters. This valbenazine will produce reversible depletion of monoamines. Reversible depletion of monoamines. Well, that's a beautiful point regarding this. Well, that is the answer for this question also. Option A is the answer. Why not the other options? Acute dystonia and ropinirole. 1 minute. Yeah, acute dystonia and ropinirole. Acute dystonia is nothing but, yeah, this is what acute dystonia is like. There is a contraction of muscles on one side and the patient cannot be able to turn their head back, torticollis, and there might be upward movement of eye muscles called as oculogyric crisis, classically seen, earliest symptom to occur with antipsychotic drug overdose. Acute dystonia treatment of choice is an anticholinergic drug along with some antihistaminic properties, not ropinirole. Perioral twitching, rabbit syndrome, perioral twitching is their rabbit syndrome, for which we can treat with benztropine, but here this condition is not belonging to that. Parkinson's, of course, we can treat the patient with the promethazine. We know drug-induced Parkinson's, drug of choice might be anticholinergic with antihistaminic, but here this is not about anti-Parkinson's, this is about orofacial dyskinesia. Okay, let's jump on to the next question. Treatment of PSVT, long-term management. Here is what the question comes over. See, we have a famous doubt that whenever the recall has happened, whether it is going to be acute treatment for PSVT or prophylaxis or long-term therapy for PSVT. This major doubt has happened since very long, and I've been asking questions to a lot of students. They're saying some different options over here. But anyhow, if the question is regarding acute management for a PSVT, then the answer would be IV adenosine. If the question is just treatment for PSVT, the answer would be intravenous adenosine. But if the question comes long-term management or prophylaxis therapy, then there should be oral verapamil will be the answer in this question. Okay. Just treatment for PSVT is going to be IV adenosine, but when you land up in like prophylactic therapy, then we have to opt for oral verapamil. Esmolol cannot be given, guys. Esmolol is not currently being used for PSVT. Phenytoin cannot be used. Adenosine can be used only in terms of acute conditions. Good, Mega, you're right. Adenosine can be given in terms of acute conditions, not in terms of long-term management. Long-term management, the answer is going to be oral verapamil. Esmolol can be given for rate control. Only for rate control, we can use beta blockers like esmolol, but that is not the treatment of choice for long-term management. Here, the answer would be oral verapamil. And I just want to say it up, please use it as a heads up. Even if you find some questions wrong over here, right? Most of the students believe completely on the recalls and they feel like, oh my God, I'm completely lost. Till the results comes, you are under complete depression. Don't feel bad. All these questions are primarily based on a recall. It is not the questions which are released from the NB itself. Right, so there might be lots of issues in how the questions has been framed, lots of issues in that. So we don't worry about whether you get a positive or a negative markings from the analysis which you get. This is just for a heads up. If you could remember this question, this might be the answer. This is not the exact question because no one knows. The next one, okay, female with migraine with aura. Migraine, of course, is going to be aura. 4 to 5 episodes per month, frequent episodes, each lasting 24 to 48 hours, typical concept of acute migraine. Partial relief with over-the-counter NSAIDs. Patient has taken ibuprofen with paracetamol. Partial relief has occurred. Started on sumatriptan prophylaxis, but developed chest tightness and flushing. I think there might be some issue with how the question has been framed because usually we don't use sumatriptan for prophylaxis. But anyhow, if the question is going to be like that, sumatriptan prophylaxis, but developed chest tightness and flushing. Okay, no history of cardiac illness, but has family history of cardiovascular disease. Drug of choice for prophylaxis, not for acute treatment. They asked for drug of choice for prophylaxis. Here, naratriptan cannot be given. Both are triptans. Triptans are powerful vasoconstrictor agents. It might induce development of like again chest tightness and palpitation. Ergotamine, again, absolutely contraindicated. That also will induce severe vasoconstriction, progressing on the diseases further. Topiramate can be used, but it is not the first line drug, my dears. It is one of the second line drugs. Good Dr. Medicovers, you have guessed it right. Topiramate is a second line drug, not a first line drug in these conditions. Here, the first line drug is going to be propranolol, and that's why this is the answer for the question. Propranolol is the answer for this question. Good, very good, superb. We'll move on. The next question, okay. CKD with anemia, symptoms of failure, drug of choice. Okay, there might be some like case scenarios associated with that, but we'll just keep it as simple as that. CKD, simply, it is chronic renal failure patient presenting with anemia. Okay, what might be the drug of choice? That's what the question here is. See, CRF, chronic renal failure with anemia, the primary reason is due to decreased erythrocyte levels. Yep. Also, erythropoietin levels. Decreased erythropoietin, which is released from that because of the renal failure, patients might land up in anemia. So we need to supplement the patient with erythropoietin stimulating agents, ESA, that's what we call it as, erythropoietin stimulating agents like darbepoetin alpha. This is the drug of choice in this condition. What about parenteral iron? We cannot use it because parenteral iron can be used only for iron deficiency anemia. Unless otherwise it's proven, parenteral iron cannot be used in it. Folic acid can be used, but it is not the primary treatment over here. Filgrastim is a granulocyte colony stimulating factor analog that can be used for neutropenia, not for anemia. Here the patient is developing anemia. That's why, as most of you have guessed, the answer is option D, darbepoetin alpha. Fantabulous. We'll move on. Benralizumab used to treat asthma acts against which of the following? Benralizumab. Okay. See, we have already discussed this multiple times in our sessions. I don't want to see. All of the questions are mostly PYQ and PYT based. Very much little questions are taken out of it. So if you just put it up around all the 200 questions would have been there in your notes itself, right? So don't worry about it. The point here is we can expect a higher cutoff. Again, we have to wait till the galley is getting released. Benralizumab, first of all, what is the options over here? Interleukin 1. What is the drug which is acting up at interleukin 1? Anakinra. Interleukin 1, we have canakinumab, anakinra, rilonacept, and diacerin. Remember that CARD, CARD drugs. We have given that mnemonic. Interleukin 7 has got no role with asthma body. That's for lymphocyte. It is related to lymphocyte proliferation. It has got no role with asthma. TNF alpha, you remember that adingosur drugs, right? Adingosur drugs, adalimumab, infliximab, golimumab, and certolizumab. Ortho, we have etanercept. Also, we have etanercept. All these drugs are acting up at TNF alpha. Here, the answer for the question is interleukin 5 actually. If this recall is right, this particular question is as you have to be given grace marks for this particular question because the option is wrong. It is not actually targeting interleukin 5, it is actually interleukin 5 receptor. Interleukin 5 target is different, interleukin 5 receptor target is different. Benralizumab, usually if a drug name contains RA, that is targeting a receptor. This is targeting interleukin 5 receptor, but anyhow, if the recall is right. If the recall is wrong, again, it might be interleukin 5 receptor. If the recall is right, this question has to be a grace mark for you, don't worry. You're having 4 marks just in the screen right now. The next question, a patient administers sevoflurane succinylcholine for an abdominal surgery, develops post-op muscle contractions. Simple concept. Sevoflurane and succinylcholine, both of these drugs might induce malignant hyperthermia. Malignant hyperthermia. Fantastic. Okay. This malignant hyperthermia can be seen again. Both of these drugs are more prone to develop that. If a patient develops malignant hyperthermia, that's primarily due to ryanodine receptor, due to abnormal contraction, due to twitchings and fasciculations, patients might die because of respiratory failure. In those conditions, we have to treat the patient with dantrolene. That is the treatment of choice. Good doctor, the answer is option A. Yep, doctor, yes, right. The answer is option A, dantrolene. Paracetamol cannot be used. Of course, it can be used for treating fever because malignant hyperthermia might induce fever. So for that, we can give paracetamol, but that's not the absolute treatment of choice. Diazepam again can be given. These are additive therapies. The question is drug of choice. The drug of choice is going to be dantrolene. Propranolol, again, here it has got no role over here. Okay, moving on to the next one. A 38-year-old female with pounding headache, palpitations, sweating for 2 months, episodes lasting 20 minutes each. Okay. 5 per week, triggered by stress, physical exertion. BP is very much shooted up, guys. 180, 100, even both systolic and diastolic. 1 minute, there is one ant which is running just before my eyes. Okay. Pulse rates 1112, 112 beats per minute. Urine shows VMA and normetanephrine. That's it. Diagnostic of what? Pheochromocytoma. This is what diagnostic of pheochromocytoma. MRI shows right adrenal mass. We have confirmed it. Which drug can be used pre and intraoperatively? Here, 1 minute. Okay. Why is my chat box gone? Yes, I can see the chat box right now. Okay. Good, Dr. Kalyan. Good, Dr. Kira. I can hear that. Okay. See, here, most of the students were asking me, like, say, why not esmolol? I told that the answer is phenoxybenzamide. Some students told that, sir, I have given esmolol as the answer. Why can't it be? Esmolol can never be given in pheochromocytoma. Understand that? Because pheochromocytoma, the concept is there is increased release of this nephrin. These nephrins, be it epinephrine or norepinephrine, these nephrins in turn will bind with alpha receptors. Thereby, it will stimulate alpha receptor, producing intense vasoconstriction, leading on to hypertension, increased blood pressure. In those conditions, just imagine what if you administer a beta blocker, it will produce something called as unopposed alpha action. Unopposed alpha action, because whenever the same nephrin is interacting with beta 2 receptor, that might produce a little bit vasodilatation that might somehow save the patient. But when you administer a beta blocker, that beta action, that saving concept itself is being gone, because it is producing vasoconstriction. Because of beta 2, it is stopping up like that. When you give a beta blocker, complete blockade tend to happen, and that's why esmolol can never be given in terms of pheochromocytoma. Nifedipine has got no role. It's a calcium channel blocker, dihydropyridine calcium channel blocker. Conidine can be given. It's an alpha 2 agonist agent, but it has got no role as a treatment for pre and intraoperatively. Phenoxybenzamide, please note it down. Phenoxybenzamide might induce. It has got a very long duration of action, guys. That's why patients might develop post-op hypotension. Post-operative hypotension might be developed because of this. An important adverse effect of it, please note it down. The next one, this is one question, guys. Again, if the recall is right, there might be some issues in the question right now. In which phase of action potential amiodarone acts on? I heard that it was an image-based question. It might be like phase 0, or phase 1, or phase 2, or phase 3. If you think of it in a bookish concept, if you think of it in a bookish way, amiodarone belongs to class 3 antiarrhythmic agent, which tend to block or which tend to prolong phase 3. Okay, this is what the answer when you come across in a bookish way. Very good. But when you think of it in a logical way, amiodarone is a drug which has got multiple different mechanisms. The major mechanism is going to be sodium channel blockade, which is there in open and active state, and potassium channel blockade. Two mechanisms are there. Sodium channel blockade and potassium channel blockade. Two mechanisms are maximal. Amiodarone has got a wide spectrum of activity. Name it, I got it. Sodium channel blockade, calcium blockade, potassium channel blockade, beta blockade, alpha blockade, all the blockade will be there. But maximally we can see SCB and PCB. So when you think about that open and active state, phase 0 will be prolonged, also phase 3 will be prolonged. But there is no, if there is no option phase 0 in the options, then the answer would be like phase 3. But if there is, for example, phase 0 in the options, then both will be the answer in that question. Is that clear? So phase, it might be both like phase 3 and phase 0, but if phase 0 is not there in the option, then we can click on to phase 3. Okay, good, Dr. Kalyan, Medico, Dr. Jai, thank you so much. Okay, we'll progress on further. Please pass my wishes to your little buddy. Okay. Drug that can be used in GERD that increases tone of LDS and increases gastric emptying. Some students told me that vonoprazan was the answer. Unfortunately, I'm very much sorry. If the recall is right, vonoprazan will not be the answer in this question. Vonoprazan is a drug which is a potassium competitive acid blocker. We used to call them as PCAD drugs. Potassium competitive acid blockers. But unfortunately, these drugs will be decreasing the gastric acid secretion alone. It will not have any role in LES, or it will not have any role in gastric emptying. Is that understood? That's why this drug cannot be the answer. Sodium alginate is an antacid gel. It has got no role with lower esophageal sphincter or gastric emptying. Pantoprazole, good drug for decreasing the gastric acid secretion. Again, no role with lower esophageal sphincter or increasing the gastric emptying. The answer for this question, as most of you have guessed, good Dr. Medico, Dr. Kalyan, the answer is metoclopramide, option C. Mechanism of action of pegloticase. Mechanism of this is the last question to be discussed, guys. Mechanism of action of pegloticase. Most of you, again, it was little bit on the outward reach. If you have learned something from your biochemistry, this question would have been very much easier for you. Everything was there in the notes, don't worry. So pegloticase is a drug which tend to inhibit an enzyme named as uricase. It's an uricase analog agent. Okay, it's an uricase analog. What's the function of uricase? Is to break down uric acid to allantoin. Break down uric acid to allantoin. Well, that's the function of uricase enzymes. Okay, but this uricase enzyme is not actually seen in human beings. It is seen only in mammals and birds, other mammals and birds. So what we did, we took out that uricase enzyme and we administered it for human beings. Human beings started converting uric acid to allantoin. The advantage is uric acid is a water insoluble metabolite. Allantoin is a water soluble metabolite. So we are converting the water insoluble uric acid to water soluble metabolite so it can be easily thrown out from the body. But unfortunately, the point, not fortunately enough, the point here is uricase is nothing but oxidation of uric acid. That's why the answer for this question is simple: uric acid oxidation. There is no reaction named as uric acid hydrolysis. Xanthine oxidase inhibitors, yes, but it is not coming under pegloticase. That will come under allopurinol and the related drugs. Urat inhibitor, yes, but it will not come under this. The example of that is probenecid. Right, guys, with this, we have completed the questions which has been pertaining to pharmacology. We have lots of integrated questions. We had a good discussion with all the faculties, and we have made sure that the questions are having least repetition with the other subjects also. And the other questions which has been direct relationship with pharma and medicine will be dealt with medicine faculty, Dr. Rahul sir. And all the best, guys, and make sure that you have a good sleep tonight. And please don't like run behind how much marks, how much ranks. Don't do that. You have finished off all your controllables. From this second onwards till the result is going to be coming, there is nothing which you can control. Yep. So don't think about it. If you can control it, you can think and do something. You can't go back and change the answer which you have put. So don't get stressed out. Be happy enough. Good night. Have a deep sleep. Bye-bye.
Hi everyone, very good evening to all of you. So yes, I hope you people have done a very, very good job in today's exam because exam was actually moderate, right? So we are going to discuss all the questions of psychiatry which they have asked today. So like in total, 6 questions they have asked. First question, right? I'm showing you first question here. Like, see, this question is related to psychiatry and forensic medicine, right? A 35-year-old man was arrested for attacking a co-worker. During interrogation, he appears disheveled and expresses paranoid delusions, stating that he was not in the right state of mind. He said that he was hearing some voices in his mind that his co-worker was about to kill him. So basically, he was having some kind of, psychiatric symptoms here, right? Which of the following is the most appropriate in terms of legal aspect? So first of all, before we start the trial, most important thing is that we need to understand whether he is mentally fit to understand the language of the trial or not, right? So here in this case, answer will be psychiatric consultation to assess fitness for trial. Right, chalo. First question was easy. Second question now. A schizophrenia patient on haloperidol who was responding well for the last 2 years now presents with orofacial dyskinesia, coriform, and the tick-like movements and possible dystonia. What is the most probable diagnosis and appropriate treatment? So first of all, we need to understand that patient was on haloperidol, means antipsychotic, first generation, typical antipsychotic for last 2 years. So EPS, the extrapyramidal symptom, what we are seeing here in the options here. So this EPS is not at all acute. So it is long term. Actually, this will be chronic. Right now, so symptoms say what's the orofacial dyskinesia, coriform, tick-like movement, same like rabbit-like features. When I see here all 4 options, option number B is what? Acute akathisia, which is most common EPS. Okay, that is fine. See, after that, option number D, acute dystonia, earliest EPS. Right, for that we were using what? Anticholinergic, antihistaminic drug. But here this is situation like rabbit-like features, no? So rabbit-like feature, which is called the tardive dyskinesia. For that, yes, we can use valbenazine. So this was the right answer. I hope you people have marked the right answer. Next question. A 34-year-old man is brought to the casualty and appears confused. After extensive efforts by a social worker, it is discovered that he is from a nearby town. He has no recollection of his identity or how he ended up traveling 110 kilometers far from his location. So one more sentence was added there ki just after earthquake hit, like he was found by the social worker. But this was the question. Okay, so there is no history of any substance abuse. Family members are actually concerned about his condition. Which of the following is the most likely diagnosis? Right. See here, first of all, we can understand, okay, this is a case of dissociative disorder. What is the meaning of dissociative disorder? Psychological stress can produce physical symptoms so that a person can get love, respect, attention, or whatever he needs. Basically, your mind is using defense mechanism, which is called as dissociation. Only dissociative amnesia means what? Like suppose if a rape victim who has forgotten about the incident, that is dissociative amnesia. But unexpectedly, if a person is going to travel from one place to another place without recalling his own identity and without recalling anything about his life, this is called as dissociative fugue. This is called as dissociative fugue. Multiple personality disorder, that is called as dissociative identity disorder. Only memory loss, that will be called a dissociative amnesia. Next question. A 20-year-old girl underwent a traumatic experience 2 weeks ago after witnessing a road traffic accident and the death of her father. One more sentence was there. She was facing some kind of amnesia episodes after the horrible accident. Okay. She now experiences flashbacks of the event. Which of the following is the most likely diagnosis? Some of you might have marked PTSD because symptoms are like what? PTSD, trauma only, no. But remember here, flashback and nightmare, avoidance, insomnia, all these symptoms should be there for more than 1 month. More than 1 month is required to diagnose PTSD. Here examiner has mentioned only 2 weeks. Same symptoms like PTSD, but duration is less than 1 month is called as acute stress disorder. Answer was acute stress disorder. Same symptoms like PTSD, but duration is less than 48 hours. Okay, then answer will be acute stress reaction. So in this question, answer was acute stress disorder. Next question. An individual comes to the OPD to talk about his friend Mr. K. Mr. K is extremely perfectionist and often misses deadlines because of this. He has been described as rigid since adolescence and is unable to discard items even without sentimental value. Mr. K is obsessed with his schedule. Yeah, this was the question about Mr. K. Mr. K, that like basically he was obsessed about perfection, right? About perfection, but he was actually denying the fact that like he was having any problem. So which type of personality disorder? We have learned about cluster A, cluster B, cluster C. So in cluster C, a person can be anxious and fearful. There we have learned about obsessive compulsive personality disorder. Means when a person is showing only about what? See, every time he talks about, see, the perfection, perfection, perfection. Person will be looking for micro details. Because of this, most of the time he will be late in delivery of the task. So in this question, answer was obsessive and compulsive personality disorder. Last question in psychiatry. A patient sitting outside his home believes that whatever a bird is chirping and flapping the wings, he has to follow the birds. He says that he is getting instruction from the God that if he will be like he will be harmed if he does not follow the words. What is the probable diagnosis? Okay, some of you might have marked delusion of reference or visual hallucination. No. Remember here, see here, one type of the primary delusion here, one type of the primary delusion which we have learned in first rank symptoms given by Curtis Snyder. First rank symptoms of schizophrenia. There can be 3 thought phenomena. There can be 3 made phenomena. There can be 3 auditory hallucination, somatic passivity, and delusional perception. What was a delusional perception? With a normal perception, with a normal view, with a normal perception, one delusion can be associated. Same example I have given you during my class also. Okay, what is the use of omnicar as per movies? As per movies, like most of the time you would have seen ki, like see, there can be kidnapping with omnicar. So when I'm looking at the omnicar, this is normal perception. But when patient will be looking at the omnicar, oh my God, they are going to kidnap me. Oh my God, they are going to kidnap me. So with the normal perception, delusion of persecution. Okay. So same situation examiner has given you with the birds, right? So with the normal perception, one delusion was associated. In this case, here answer is delusional perception. I hope you have done a great job in psychiatry. I wish you all the best. Thank you so much.
Hi friends, Dr. Rajendran, surgery faculty here. So sorry to disturb you at this late night. I hope all of you will be in a different mood after the exam. But I'll finish the surgery recalls, the basic recalls from the students recall. I'm making a fast recall, just 15 minutes only, not more than that. I'm going to discuss around 19 to 20 questions asked in surgery. So all questions in surgery are very simple and straightforward questions. So you can see now, a 65-year-old male with a stab injury in the abdomen with the features of peritonitis. So penetrating trauma in the abdomen protocol, the answer is straightforward emergency laparotomy. So when there is a feature of peritonitis, shift the patient for laparotomy. An easy question, simple question, straightforward from trauma. A patient presented with a cancer anal canal, and cancer anal canal is a very commonly asked MCQ because the treatment of cancer anal canal will be asked, that is negro regimen chemoradiotherapy has been asked many times. No need of surgery for cancer anal canal. We can give chemoradiotherapy. Now the new question which is asked now this time is, which is the first node involved in anal canal? This is a new question, but if you are very strong in anatomy, anal canal drains into superficial inguinal node is the answer for this question. So anal canal will drain into superficial inguinal node. Especially the squamous part of the anal canal will have inguinal nodal mets. So please don't forget, this is the first time asked a new question from cancer anal canal. 7-year-old boy with a non-retractable foreskin, okay, non-retractable foreskin and tense white preputial skin. So tense white preputial skin, there are two important things. We don't know whether it's an image-based question or a straightforward question. If it is an image-based question showing you Balanitis xerotica obliterans, this is a very common condition. Balanitis xerotica obliterans is a condition where there is whitening of the prepuce. White prepuce will be seen. Full prepuce will be white in color. So BXO is a very commonly asked image-based question. So please remember this Balanitis xerotica obliterans. So the answer is, best answer is Balanitis xerotica obliterans, but the choice is it is an image-based question. So image-based question means definitely they will ask you always BXO. BXO is a favorite image-based question of National Board examiners. There will be white foreskin. That is a point. You have to cut and remove it because it can go for future cancer penis. So BXO needs resection by circumcision. So this is a procedure which is already discussed in burns. A patient having a circumferential burns anywhere in the upper arm or in the abdomen and the trunk or in the lower limb, we have to go for a procedure called as escharotomy. Please remember the escharotomy procedure is shown in this image. So it's for circumferential burns. We have to go for escharotomy. So this is a picture showing you escharotomy image for a circumferential burns. So fifth question is a question on varicose veins. So simple question, 25-year-old with a 5-year history of left leg unilateral varicose veins. Identify the correct statement. Please understand, many times, many recalls will not be perfect. Once you see a question, you might be having a better recall, but this is not the time to explain you everything. So most common causes, not pelvic tumor. Okay, most common cause of varicose veins is not pelvic tumor. And this varicose vein is not graded as C6. C6 is active venous ulcer. Active venous ulcer is the C6 grade. So recommended treatment is sclerotherapy. Sclerotherapy is a type of treatment. I heard that the question paper was mentioning best treatment is sclerotherapy. No, best treatment of choice for varicose veins now is endovenous laser ablation is the treatment of choice. So the question is explaining what is the true statement in this question. Means the question is not asking false statement. True statement is it can cause eczema and pigmentation and lipodermatosclerosis. So lipodermatosclerosis, eczema and pigmentation are the common findings seen in varicose veins. I hope if you have any much better clarity on this question, you can post in this. But please remember the points are sclerotherapy is not the treatment of choice. Endovenous laser ablation is a treatment of choice. Grade C is active venous ulcer and common cause is not a pelvic tumor. Okay, it is not a commonest cause and it can cause skin changes. That's correct. So T grading of the cancer breast is asked about the PUD orange. So PUD orange image was given in the exam. PUD orange limited breast means it goes for T4A. If it is extensive breast means, so T4 is go for, anyhow, PUD orange is standing for T4. Okay. So there is a new update in T4D is for extensive PUD orange. When it is involving more than 2/3 of the breast, it is called as extensive PUD orange. So in the choice, if you had T4D with an extensive PUD orange, you should go for T4. But just if there is no specific T4 asked, you just go for T4D if it is extensive. If it is very limited, you can go for T4 A or A for that cases. Okay. So depending upon the grade, I don't know what is the exact grade which is asked, but we will do a proper recall later. But just remember it is T4D. Patient was being operated for bleeding duodenal ulcer. So you all know very well, there is an epibloic foramen related applied anatomy question. So what is related to epibloic foramen? So please understand, epibloic foramen is a foramen seen behind the three important structures, portal vein, bile duct, and the other one is hepatic artery. So these are the three structures which are seen anterior to epibloic foramen. So epibloic foramen anteriorly, these are the three structures. So when we are doing a duodenal ulcer surgery, the vessel which comes very nearby over that area will be common hepatic artery giving a branch of gastroduodenal artery. So there is a chance when I'm going for a surgery, I might puncture a hepatic artery. So its hepatic artery may be punctured. Okay, hepatic artery may be punctured. They are just asking what are the three structures in the porta hepatis in front of epibloic foramen. So hepatic artery may be punctured commonly. when we are doing surgery. But usually this never happens. This is just an applied anatomy question. So please remember this question. So the fistula A is shown here. What is fistula A? So type A fistula is an intersphincteric fistula. Please understand, this is type A intersphincteric fistula. This is type A called as intersphincteric fistula. So type B is transsphincteric, type C is suprasphincteric, type D is extralevator. So they asked about the choice was asking about intersphincteric fistula. It's straightforward. Most of them wrote it correctly. And this question is again another easy question. From the knot, there are many knots given in the book. The easiest to remember for exam is surgeon's knot because the first done knot is double throw. Therefore, it is surgeon's knot is the answer for this question. So it's again an easy question and a repeat question. And this question is an external angular dermoid, very common over the bony places where it can cause denting in the bone. So this is an external angular dermoid cyst. So I didn't even put the other choices because it's a very straightforward question. External angular dermoid. This type of dermoid cyst can be seen on post-auricular region also. This is a classical MCQ. Repeat question. And they have mentioned in the choice as polydioxanone suture. The polydioxanone suture is the longest absorbable suture. That is a common MCQ every time asked in exam. Longest absorbable suture. But this time they made a confusion. They made a question to make you confused whether it is a monofilament or multifilament. Please remember, it's a monofilament material. Polydioxanone is a monofilament material, not a multifilament material. So don't forget, polydioxanone is a longest absorbable suture material, which is monofilament. And this is a Strasbourg classification question, very commonly asked question every exam. Strasbourg A is cystic duct leak plus ducts of Luschka leak. So this question is very classical. It is a leak from the ducts of Luschka and cystic duct leak is mentioned in this question. So this picture is type A, but at the same time, I am not sure with what picture is being asked in the exam, but type A is cystic duct leak. So if you have an image showing you cystic duct which is leaking from the cystic duct, go for type A. So there are other gradings you should go through, whether it is B, C, D and all, but usually the common MCQ asked for NEET PG level is type A leak is commonly asked. Already asked repeat question. So 45 years old male baby with 45, sorry, that's a typing error, 45 days old male. This question is again a controversy whether it is a 45 days or a 45 hours, something. The patient was having difficulty in swallowing, weight loss, and a chest X-ray showing bronchiectasis. Patient presents with below X-ray. So from the X-ray, this is a classical, this is a classical 45 years male. The patient is having a barium swallow showing achalasia cardia. This is an image of achalasia cardia. So achalasia cardia, the investigation of choice is very classical. High resolution manometry is the investigation of choice. So please don't forget, investigation of choice is high resolution manometry. So if they have asked posterior to epiboloic foramen, the answer will be IVC. So some of you are mentioning posterior to, Kira is mentioning the injury seen posterior to epiboloic foramen. So if it is posterior from the question, usually we don't go such posterior and injure in a duodenal ulcer surgery. That is the point. So when I'm doing a duodenal ulcer surgery, I will not go such a posterior and I will not go and injure any structure posteriorly. But if it is posterior to epiboloic foramen, means the structure is IVC. So if it is posterior to epiboloic foramen, it is IVC. Anterior or very near, close to the epiboloic foramen, it is hepatic artery. So there are two options which is purely based on your recalls. So this is a achalasia cardia. So the straightforward question, you have to go for high resolution manometry. And this is another applied anatomy surgical question. So which nerve is closely related to submandibular gland area? So when I'm doing a incision here or lifting a submandibular gland, two nerves are very commonly injured superficially. One is marginal branch, another is cervical branch superficially. Deep nerves which are injured are lingual nerve. I heard from the students recall, they told that after lifting the gland, there was a nerve shown that is usually lingual nerve. If it is shown after lifting the gland, means it is lingual nerve. If it is shown without lifting the gland, means marginal mandibular nerve. If you just open the skin and see, that is marginal mandibular nerve. If you lift the gland, after that gland inside, it will be lingual nerve. Please remember this point. So this is a classical image from anatomy books. So lingual nerve is seen deep to the gland, and when you go superficially, marginal mandibular nerve will be seen. So the patient presents with dark and blackened fingers. What is the most likely diagnosis? It's a dry gangrene. So it's a dry gangrene shown in this picture. Okay, it's a dry gangrene. 25-year-old patient had an RTA and was initially conscious but later became unconscious and subsequently died. Post-mortem examination showed multiple petechial hemorrhages in the corpus callosum. This is a direct line from Bailey and Love. When you go for Bailey and Love and read this topic, CT scan shows multiple hemorrhage, petechial hemorrhages in corpus callosum is seen in diffuse axonal injury, a direct line from Bailey and Love. So usually the investigation of choice for diffuse axonal injury is MRI, but they have mentioned a line in Bailey and Love as a CT scan showing multiple small petechial hemorrhage. So it is also seen in postmortem also. Answer is B. So carpopedal spasm is a complication of thyroid surgery due to hypocalcemia, due to parathyroid, loss of blood supply. So a patient with jaundice, anorexia and weight loss since 2 months, this is a Courvoisier law. Patient having jaundice and weight loss for 2 months, gallbladder is palpable, soft and not tender. What is the most likely diagnosis? See, this is a very classical Courvoisier law. Whenever gallbladder is enlarged, it is not due to stones. In a stone disease, gallbladder will not be enlarged. If there is a cancer here, gallbladder will be enlarged. Common cancers are CA pancreas, periampullary cancer, bile duct cancer, all these things can cause enlargement of the gallbladder. So the answer here is head of pancreas is the answer for this question. So barium, swallow this question already discussed. So a newborn with the breathlessness, the classical image showing you a lot of bowel loops in the left side chest. So this is a case of congenital diaphragmatic hernia. And some images I could not get the questions, but I could get the images. So this is a renal cell cancer image. So we don't know whether this question was asked or not. So this is a renal cell cancer image. And this is a picture asked again. This is a carotid body tumor showing. Carotid body tumor showing. This is called as Lier sign. This is called as Lier sign, is splaying of common carotid arteries on an angiogram. On an angiogram, you can see the splaying of common carotid arteries called as Lier sign. And there is one more question which is asked. I heard this. There is a drug of choice in GRD is asked. This I was telling in the classes itself. Vonoprazan is a new drug which is updated in Bailey and Love. This is a potassium competitive acid blocker. Potassium competitive acid blocker is updated in new edition Bailey. So this drug was asked in the exam. So these are the surgery questions. So we will have a detailed recall, better recall with the proper references and proper choices soon. Just have an idea of what are the questions being asked and how many mistakes you have made. You can get a conclusion at the end of our sessions. Thank you.
Dear students, good evening. So as we are on to anatomy now, anatomy recall questions. You will see that we are taking care of around 15 MCQs here. And the very first question which you see is a histology slide based question. Mention the location where the shown epithelium is found. So as we are talking about this epithelium, you can see there are some cells which are at the top and they are globular, large globular cells. In an epithelium, which is quite a stratified kind of epithelium, a lot of cells are there. But since the cells which are towards the surface, towards the lumen, they are larger, we'll know that this is transitional epithelium. So multi-layered, but the topmost cells are quite large. Sometimes they can be umbrella shape also. Now, giving you other details, if you had some cells which were again multi-layered, but the superficial cells were flat or they can be globular. Nuclei are smaller, not as large as transitional. Then you can say it will be stratified squamous, non-keratinized epithelium, but then stratified squamous, non-keratinized epithelium in esophagus. And this is not a slide for esophagus. Here you see that we have quite large amount of cytoplasm above the nucleus. So that means it is basically the columnar cells, oval basal nuclei are there. And you also see there are goblet cells. These are goblet cells. Plus you notice that there are microvilli which are creating this striated border. So this is how the duodenum will be appearing. When you are talking about the duodenum, duodenum will be having striated appearance because of the regularly arranged microvilli, and it is a simple columnar epithelium. So when you are saying that, yes, duodenum. So what about this? As we are comparing the three, you can understand this was our slide, and it was basically transitional epithelium. Now, as you proceed further with the ciliated epithelium here, goblet cells also with a lot of mucus, and pseudo stratification because nuclei are at various levels. Pseudo-stratified ciliated columnar epithelium, pseudo-stratified ciliated columnar epithelium with goblet cells, and this is respiratory epithelium. You may see that in the trachea, or you may say it is maybe bronchus, so trachea and bronchus. So that is how we are going to identify the different types. But anyway, they are asking for location of the epithelium, which is found here. It is transitional epithelium, and your answer will be ureter. It can be, starting at the tip of the collecting duct, and then it can be minor major calyx, ureter, urinary bladder, proximal urethra also. If you're talking about esophagus, it will be non-keratinized stratified squamous epithelium. If you're talking about duodenum, it will be simple columnar epithelium with striated border. And if you're talking about trachea, it will be pseudo-stratified ciliated columnar epithelium with goblet cells. So we should keep our answer as ureter. Now, moving on to the next question, as you see, which of the following is the neural column not carried by the marked nerve? So which nerve are we talking about? You see, this is a transverse section which is given, or maybe it was a dissected specimen where you will find that they have given the internal jugular vein and the common carotid artery, and vagus nerve was marked actually inside carotid sheath. So inside carotid sheath, this is the carotid sheath. Inside carotid sheath, the outside is internal jugular vein, and inside is the common carotid artery, which will continue as internal carotid artery. And between the two, behind the two, is the vagus nerve in the carotid sheath, and that is what they were marking. And vagus nerve, what they are asking is whether it is having all these neural columns or not. So your diagram could be, this carotid sheath and marker here in a transverse section of the neck, or it could be a marker here because this is internal jugular vein, common carotid artery becoming internal carotid artery. Again, it will be in the carotid sheath, and they're asking for vagus nerve. Understand that what is GSA? General somatic efferent. Like, you're touching the external auditory meatus or doing the syringing at the floor of the external auditory meatus, you can activate the auricular nerve branch of vagus. So that is general somatic sensation, GSA. So vagus definitely carry that. What about GVA? General visual sensation. General visual sensation like, carotid body, carotid sinus, chemoreceptor, proprioception, they are carrying the general visual sensation. So definitely vagus nerve carry general visual sensation, but it does not carry GSC. GSC are basically the general skeletal muscles like the muscles of the eyeball and tongue, which do not develop in pharyngeal arches. So the nerve 346 for eyeball or nerve 12, which is for the tongue, they are GSC. When you're talking about the GSE, it is the number 346 for the eyeball, the number 12 for the tongue. These are the muscles which do not develop in pharyngeal arches, and they are GSC. Otherwise, pharyngeal arch muscles, they must be considered SVE. So vagus nerve is not GSC, it is SVE. What is SVE? Special visceral efferent. Special visceral efferent are the muscles which are developing in pharyngeal arches, like the trigeminal mandibular nerve for muscles of mastication, first arch, facial nerve for second arch, number 346 for the arch number 346, you have the muscles of palate, pharynx, larynx, and the nerves are vagus nerve and even glossopharyngeal nerve. So basically, the vagus nerve is SVE for the muscles of palate, pharynx, and larynx, but it is not GSC. So that comes as the answer of exception. If you're talking about GVE, GVE is the parasympathetic system, which is controlling the smooth muscles and the glands also. So vagus nerve, of course, it is going to take care of cardiac muscles also. They are all GVE. So cardiac muscles, smooth muscles, and the glands also. That is under vagus nerve, general visceral efferent. So that means the answer of exception will be GSC, because the vagus nerve is not GSC, it is actually SVE, special visceral efferent. When you talk about the arch number 4 and 6, where you have vagus accessory complex, the number 10, 11 together, controlling the muscles of palate, pharynx, and larynx for speech and swallowing. So it is not GSC, it is SVE. That is the point. Looking at this question number 3, patient presenting with muscle wasting, reduced tone, hypotonia, and weakness in the right hand. The patient is even unable to do dough kneading. Aata gundne mein mushkil hai. So this kind of appearance is actually element type of palsy, where you have hypotonia and you have hyporeflexia, you have weakness also. So where are the lower motor neurons? Lower motor neurons can be in the brainstem, can be in the spinal cord. In the spinal cord, it is anterior horn cell. That is why we'll take our answer as anterior horn cells of the cervical spinal cord, because it is brachial plexus. Brachial plexus has 5 root values starting with C5, 6, 7, 8, and T1. So that is the brachial plexus, and most of them are cervical values. So if a lesion is in the cervical spinal cord, anterior horn cell, lower motor neuron type of palsy can be seen. Why not brainstem? Brainstem is definitely having lower motor neurons, but they are for the cranial nerves. So it is not a case of cranial nerves. What about the internal capsule? Internal capsule, say if you are talking about the hand, you will have the corticospinal tract, but corticospinal tract is coming from the upper motor neurons. That is in the cerebral cortex. So it will be human type of palsy. Human type of palsy means you will have hypertonia, hyperreflexia, you will have spasticity. But this patient is not having any of such features, cannot be the answer. Why it is not corticospinal tract in the cervical? It's the same thing. Only thing is, if it was a lesion in the cervical spinal cord like Brown-Séquard syndrome, it'll be ipsilateral spastic palsy. But there is no spastic palsy in this patient. There is flaccidity, actually weakness with flaccidity. So that is why we'll keep our answer as anterior horn cells. That is the lower motor neurons in the spinal cord, which is cervical level. We'll be giving this. We'll be giving detailed answers also. Here I'm going quite fast so that, just to give you the answers. Now, question number 4, congenital anomaly shown in the diagram, and which pharyngeal arch artery might be involved. The diagram is showing us what is called as patent ductus arteriosus, and that is mostly happening on the left side and the 6th pharyngeal arch artery. As you understand, that is a problem of left-sided 6th pharyngeal arch artery. It is actually, see, normally what happens is the 6th pharyngeal arch will give pulmonary artery and ductus arteriosus on both sides, but the right regresses and left is left. You can see that detail here. We have 6 pharyngeal arch arteries, and it is the 6th pharyngeal arch artery which is giving us the pulmonary arteries, like on the right side and also on the left side. But along with pulmonary artery, it will also give what is called as ductus arteriosus, which is active in the fetal circulation. Now, ductus arteriosus is regressing on the right side, but it will be remaining on the left side. Left side is left, and that ductus arteriosus, sometime, after baby is born, placenta is removed, you will not have that prostaglandin and all that, so there should be a physiological spasm, but sometime it may persist, which is called PDA, patent ductus arteriosus. So that is what they are asking. Of course, they are asking about the left 6th arch artery, and that is what we have given answer, choice number C, PDA. Now, question number 5, which of the following is not passing through the arrow mark region? Arrow mark region is here. That is asking about jugular foramen. So if you're talking about the jugular foramen, which is found between petrous temporal bone and the occipital bone, you will have certain structures passing. It is the number 9, 10, 11, 11 both parts, that is the cranial accessory nerve as well as spinal accessory nerve. Along with that, you will also see that there is inferior petrosal sinus joining the internal jugular vein. So there are veins also. If you're talking about the one-net syndrome can compromise all of this, leading to difficulty speech, swallowing, shrugging the shoulder, overhead abduction, all that. So these are some important topics, but you cannot take your answer as hypoglossal nerve, because hypoglossal nerve will be passing in the hypoglossal canal. There's a hypoglossal canal here. You can see the details here. See, posterior cranial fossa, you see, this is where you will have the hypoglossal nerve, hypoglossal canal. It is not passing through the jugular foramen. In the jugular foramen, what we have is the number 9, 10, and 11. And 11, not only the cranial part, but also spinal part. As you see, this is spinal cord giving spinal axillary nerve. It also passes through the jugular foramen. This is internal auditory meatus, where you have the number 7, 8. So in the posterior cranial fossa, you have the number 7, 8 in the internal auditory meatus. Then you have the number 9, 10, 11, along with the internal jugular vein, inferior petrosal sinus in the jugular foramen. And if you're talking about the number 12, the number 12 is hypoglossal nerve in the hypoglossal canal. It is not in the jugular foramen. That is why in this question, we'll keep our answer as hypoglossal nerve, because hypoglossal nerve will be here. It is passing in the occipital bone. There's a hypoglossal canal. That is where you will have the 12th nerve, not here, which is marking for jugular foramen. Jugular foramen, you will have the number 9, 10, and both the parts of 11. So we keep our answer as hypoglossal nerve. Yes, Kalyan, it is hypoglossal. Now, question number 6, you had a question which is marking a muscle having both bellies. So it is a hybrid muscle which will have more than one motor nerve supply. And that what we are looking at is digastric. It has two bellies, and anterior belly developing in the first arch and the posterior belly developing in the second arch. Because the anterior belly developing in the first arch, the mandibular nerve branch of trigeminal will be supplying. Trigeminal give the mandibular nerve, and mandibular nerve will give nerve to mylohyoid. That nerve to mylohyoid not only supply mylohyoid, but also anterior belly of digastric. What about the second arch? Second arch will have facial nerve. So nerve to mylohyoid and facial nerve. That is the point. Point is that when you are talking about anterior belly of the digastric, it is one of the muscle, one of the 8 muscles developing in the first pharyngeal arch. First pharyngeal arch will have 8 muscles developing. In the 8 muscles, you'll have 2 of the muscles attaching to the hyoid bone, and they are anterior belly of digastric and mylohyoid. To supply them the trigeminal nerve, phi3, it will give a branch which is nerve to mylohyoid, and nerve to mylohyoid not only supply mylohyoid, but also anterior belly of digastric. So that is why we are taking our answer nerve to mylohyoid, that is for anterior belly. What about posterior belly? Actually, posterior belly of digastric is developing in the second pharyngeal arch, and since it is developing in the second pharyngeal arch, now our second pharyngeal arch is the facial nerve. That is why. So in this question, we'll take our answer as, I'm going fast because of some specific reasons we'll discuss in detail, don't worry. But facial nerve for posterior belly, second arch, and nerve to mylohyoid for first arch. Muscles of mastication. Mylohyoid, anterior belly, they depress the mandible and you open the mouth, and muscles of mastication developing in first arch. Now, looking at question number 7, what is this mark structure? As you see, it is not a plain X-ray. Some students were telling it is thyroid cartilage, but thyroid cartilage is not seen on X-ray also until it is calcified, and that will be a man of 100 years. So somebody of 100 years, then it's maybe his thyroid cartilage is calcified, because hyaline cartilage have a tendency to calcify. But a 100-year patient you are taking, and anyway, it is basically a barium swallow. So this was a barium swallow, and you are looking at something here, something here. It is on the side of the larynx. It is basically laryngopharynx. So laryngeal inlet on the side, and of course, you are talking about pyriform sinus here, smuggler's fossa, internal laryngeal nerve damage, all those questions are coming. Then what is this? This is actually between tongue and the epiglottis, glossoepiglottic space, and what is called as the vallicula. So that will be vallicula. Let us take one coronal section. As you take the coronal section, this is the nasal septum, that is the terminates in the nasopharynx. Then you will have, this is the soft palate uvula, this is the epiglottis. So between them, you will have the oropharynx. And if you go behind the larynx, then you'll have the laryngopharynx. There are 3 pharynges basically. So the nasopharynx, the oropharynx, and the laryngopharynx. You are talking about laryngopharynx here. If you go inside here, that will be the laryngeal inlet. But you are not in the laryngeal inlet. You are outside the larynx. You are on the side of the larynx. And that is where we have the pyriform fossa. So examiner is basically locating the pyriform fossa. That is the arrow mark. And where is this vallicula? Vallicula is glossoepiglottic, means anteriorly you will have tongue. This is the tongue. There you will have tonsil also. And that is the epiglottis. So between tongue and epiglottis, you will have vallicula. And that is the region of vallicula. You know, if somebody is having acute tonsillitis, collection of saliva in the vallicula, that is what we see. And it is glossoepiglottic fold. Space. But anyway, the question was on this area, that is pyriform recess. That is the pyriform recess. That is why we'll keep our answer like that. So that is your answer, question number 7. And question number 8, 75-year-old, hypertension, type 2 diabetes mellitus, epistaxis, not responding after packing the artery. You know, nasal packing is done. Then after that, you can go for electrocoagulation, or you can go for the, ligature also. So which one? Actually, the artery of epistaxis is sphenopalatine artery. That is the point. Posterior thrombus is not very much contributing to the epistaxis. It is not in the lateral area of epistaxis. Basically, it is the anterior thrombus which is, and greater palatine is generally not the case. So yes, you already have answered, Kalyan. Anushka, you're welcome. So as you see, this is the Kieselbach area or Little's area of epistaxis. You should know the arteries, but the chief artery is here. The third part of maxillary artery giving sphenopalatine artery. So sphenopalatine artery is the major artery, though the third part of maxillary artery will also give the greater palatine artery contributing here. So greater palatine artery is there, sphenopalatine artery is there. They are coming from the third part of the maxillary artery to the Little's area of epistaxis. Along with that, you will have one more contribution from external carotid artery. External carotid artery giving facial artery giving the superior labial artery, and superior labial artery giving contribution. So this is the septal branch of superior labial artery, which is coming from the facial artery, which itself is coming from external carotid artery. And you know, external carotid artery has given 3 branches by this time: sphenopalatine artery, greater palatine artery, and the septal branch of this facial artery, superior labial artery. So what about the internal carotid artery? Actually, internal carotid artery is also contributing. Internal carotid artery will have given the ophthalmic artery. Ophthalmic artery would have given these ethmoidal arteries. And there is anterior ethmoidal artery, posterior ethmoidal. Posterior ethmoidal doesn't contribute. It is the anterior ethmoidal which is contributing to Kieselbach plexus. And generally, when you are talking about epistaxis, it is usually the sphenopalatine which is compromised. And even if the anterior ethmoidal was compromised, you're not supposed to put a ligature here or do electrocoagulation and all that, because you are talking about brain area here. So internal carotid artery you don't mess with. You generally should restrict to external carotid artery branches. Anyway, you already have answered. We are going quick here, so answer should be A. Question number 9, submandibular gland dissection. Dr. Rajamendran was also discussing the same thing, and running. So depends upon the stem of the question. If it is telling superior to the posterior belly of digastric muscle, then my answer will be different. So what will you be choosing here? Actually, as sir mentioned, that there are some nerves which are at risk of injury, including lingual nerve, hypoglossal nerve, but even glossopharyngeal nerve is at risk of injury, and of course branches of facial nerve will be at injury. Depends what kind of a stem of question was there, what are the options. But in such a scenario, when you say it is passing superior to the posterior belly of digastric, for me, I think the answer would be, you see, we are talking about submandibular gland, and related to that will be this nerve, of course, the lingual nerve, and that is at risk of injury. Then you have this hypoglossal nerve also going to supply tongue muscles. So even the hypoglossal nerve, it will be marked here. This is the hypoglossal nerve, it has at risk of injury. Even glossopharyngeal nerve is related here. It is running like this. So as a surgeon, you have to look into more details. Maybe I have to work upon this question, but as such, for me, the best answer will be hypoglossal. Why I'm telling hypoglossal? Because I have been given the relation that during submandibular gland dissection, a structure is identified running superior to the posterior belly of digastric. See, glossopharyngeal nerve runs deep to the posterior belly of digastric. So superficial superior, if you'd say, I'll go for hypoglossal nerve. But as I'm telling you, I'll have to work upon this question, because we know Dr. Raja Mahendra also discussed the same thing, and we might discuss and go on approach consensus, like what could have been the question. Now, question number 10, 19-year-old while training during hyperextension. Extension muscle is triceps. Triceps means 3 heads. So there is a pain at the side. Trainer is expecting probable disruption of the long head of triceps, infraglenoid tubercle. If this is the scapula, you're looking from the posterior view, you'll have glenoid cavity, supraglenoid tubercle, you'll have long head of biceps brachii, and infraglenoid tubercle, you'll have the long head of triceps brachii. So something wrong with the long head, so infraglenoid tubercle should be the answer. Let us look at some details. Triceps muscle is triceps, so it will have one long head which is coming from infraglenoid tubercle, posterior view, and there is a lateral head coming from the shaft of the humerus above the spiral groove where the radial nerve and profunda brachial artery runs, and then there is a medial head also coming from the shaft of the humerus again, but but it is inferior-medial to the radial groove where the radial nerve is running. So it is a triceps. It will have 3 heads. It will be inserting on the olecranon process so that it can do extension. So the point is, maybe the patient was hyper enthusiastic using this triceps exercise. Like sometimes they get hyper excited, and he has pulled his long head of triceps from the infraglenoid tubercle of the scapula. Triceps brachii we are talking about. Hyper extension, because you're talking about this is the nerve, radial nerve, which is supplying the muscle. So quickly, C is your answer. Question number 11, clinical examination. Intern is asked to examine umbilical cord and mention the number of arteries. Let us look at this diagram only. So left is left vein is left. So left vein is left vein in shown in red color because it carries oxygenated blood from the placenta to the baby. And the 2 umbilical arteries, they are persisting. Umbilical arteries are basically shown in blue color because they are carrying deoxygenated blood back to mother. So only one umbilical vein is there, and when the right vein was regressing, when the right umbilical vein was regressing, there might be some defect, and gastroschisis can happen. So gastroschisis happens at a weak spot, which is at the regressing right umbilical vein. Like that, you can remember, right vein regresses. So it is only left vein which is left. That is why. And also remember, it is umbilical cord transverse section, which is covered by amnion. It'll have not only the remnants of vital intestinal duct, it'll have midgut also, which is physiological umbilical hernia. If it is persisting, you may have what is called as omphalocele also. If this is persisting, you may have Meckel's fistula. And if allantois is urachal fistula can be there. So some of the problems can be there. But since it is just asking, examine the umbilical cord, how many veins and arteries, we know left vein is left, so only one vein is left, 2 umbilical arteries. Your answer is choice number A here. Yes, Kalyan, that is correct. So question number 12, abdominal surgery, as you are telling. Perforated duodenal. Again, Dr. Rajamendran was discussing, and I was surprised, like I was little taken back that sir gave some other answer, but finally he corrected his answer. So duodenal ulcer you are operating on, and surgeon is accidentally stabbing some structure posterior to epileptic. See, he was thinking that he's a surgeon. How can he stab such a large vessel? That is why he's being genuine in answering the question. But sometimes these questions are academic questions. So if you are going behind the epipletic foramen, remember, anterior to epipletic foramen, you have 3 structures. That is the DAV structure, that is the bile duct, hepatic artery, and portal vein. And posterior to the epipletic foramen, you have 3 structures, which is T12 vertebra. On T12 vertebra, you have inferior vena cava and the right adrenal gland. I'll show you a diagram also. 3 structure behind, 3 structure in front, and you are going between them. So epipletic foramen of Winslow, a lot of questions are coming. So if you are going posterior, of course, your answer should be inferior vena cava, though abdominal aorta is also there. But you are a surgeon, you are not stabbing these large vessels. Somehow it is more of an academic question. So as you are focusing upon this area, which is epipletic foramen Winslow, you have magnified it. These type of questions keep coming. So this is the foramen of Winslow. What are the 3 structures posterior? 3 structures posterior are T12 vertebra and the right adrenal, and this vessel, which is the inferior vena cava. So inferior vena cava, T12, and the right adrenal. Now these 3 structures are behind. What are the 3 structures which are in front? In front, the DAV structure. The D is the bile duct, A is the artery, which is the hepatic artery, and vein is the portal vein. And what is superior and inferior? Superior is the L1, inferior is the D1. What is L1, D1? L1 is lever 1, which is caudate lobe, which is superior, and D1 is duodenum, which is first part of duodenum, which is inferior. You have taken a transverse section also now, and you see this is the DAV structure anteriorly. Now, if they are the DAV structure, what are they? DAV, they will be the bile duct, hepatic artery, and portal vein, which are anterior. This is the epipletic foramen Winslow. It is basically coming from the lesser sac to the greater sac. Greater means this is the greater sac. From greater sac, if you want to go to lesser sac, which is small space, let me magnify. So this is the stomach. Behind that, you'll have a small space, peritoneal space, which is the lesser sac. If you want to go to lesser sac, from the greater sac, the pink color to the blue color, you'll pass this epipletic foramen of Winslow. And epipletic foramen Winslow, what are the 3 structures anterior? 3 structures anterior are the DAV structure. What are the 3 structure posterior? The 3 structure posterior are the T12 vertebra. On that, you have the inferior vena cava and the right adrenal gland. This is kidney. So on the kidney, you'll have right adrenal gland, inferior vena cava, and also the T12 vertebra. aorta. Though abdominal aorta is also there, but you are not supposed to poke abdominal aorta. Are you a surgeon or what are you? So that is the point. But anyway, if they have mentioned posterior to this, exactly behind the foramen of Winslow, then I'll go for inferior vena cava. Even Dr. Raja Mahendran gave the same answer. So that is why in this question, we should keep our answer as inferior vena cava. Now, question number 13, patient is presenting with CA near the anal opening. Anal canal, it is having a dentate line or pectinate line, and if there is something below that dentate line, pectinate line, it will be superficial inguinal lymph node. And if it is above that dentate line, the internal iliac lymph node. So this dentate line is very important surgically, anatomically, embryologically, histologically, because things change. Embryologically, inside you have endoderm, outside you'll have ectoderm, so endo-ecto junction. Epithelium also, squamocolumnar junction will be there, transitional epithelium will be, so a lot of the details are there. But anyway, if you are telling that carcinoma near the anal opening means anal verge, means below the dentate line, so facial inguinal lymph node. So that is why I have taken my answer as facial inguinal lymph node, because if you are talking about internal iliac, then it will be above the dentate line, means internal, deeper anal canal. But that is not, it is anal opening, anal verge. So let us keep our answer as superficial inguinal lymph node. Kalyan, why you are telling internal iliac? It is near the anal opening. So what I assume is that they are talking about anal verge, means below the dentate line. You should take your answer as B. And question number 14, this is sensation over the lateral aspect of the thigh, myalgia paresthetica, they already mentioned. So myalgia paresthetica, all these questions keep coming again and again. And if you don't say that questions are coming again, then previous year topics are coming again. And since I started teaching 25 years back, I started teaching. It's been 25 years. I have only one advice to the students, and that advice is practice as many questions as possible. Previous year questions, 10 to 15 years, and you will see that 90%, 70 to 90% questions come from there only. But nobody listens. So if you don't listen, then what can I do? That is the only one single advice which I give. So what about myalgia paresthetica? You can see this diagram, L2, L3 coming from the lumbosacral plexus, and this is the nerve which can be compressed behind the deep to the inguinal ligament. That could be a pregnancy, that could be type 2 diabetes mellitus with protruded belly, or anything which is compressing the nerve under the inguinal ligament. And of course, if you are looking at this area, inguinal region, it is L1 dermatome. But as you go, L2 will be here, L3 will be here. It goes lateral to medial now. So L2, 3, that is what you should answer. That is your answer. And the question number 15, forceful eversion. Now you are talking about eversion injury. Eversion injury means take the sole outside. If you take the sole outside, then one ligament which is on the medial side will be pulled. Lower end of the tibia, you have medial malleus. For the medial malleus, there are 4 parts coming. Below this will be the talus bone, and below the talus you have the calcaneum bone, and there will be some ligament which is connecting not only to the talus anterior posteriorly, but it also connects to the navicular bone, which is more medial and anterior, and to the calcaneum. This is deltoid ligament, it will be pulled. So you are talking about deltoid ligament having 4 parts, all starting with the name tibia. So tibia, calcaneal, anterior tibiotalar, posterior tibiotalar, tibio-navicular, all those will be pulled. If you're talking about the talofibular or calcaneofibular, you are looking from the lateral side. Lateral side, this is lateral malleolus, which is fibula bone, and the fibula bone is also related with the talus here, and with the calcaneum, the heel bone, you are looking from the lateral side. So you will have anterior talofibular, posterior talofibular, or fibular, calcaneal, all these, but they will be compromised if you had inversion injuries, turn the sole inside, inversion injury. So none of that will be the answer. Your answer should be deltoid ligament, and that is all I wanted to take care of. Total 15 questions, and your answer should be deltoid ligament. We'll discuss them in detail later. Take care. All the best. I'm hoping that most of you, all of you, will have very good ranks in hundreds and within 1,000. God bless.
Hello and good evening, everyone. Am I audible? Good evening, everyone. All dear students, please let me know in the chat box if my audio and video is good. Are we good to go? Are we good to go? Yes. Yes, 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 yes. So good evening, everyone. Good evening. So, right. Right. So, hello, everyone. So let's have a rapid fire discussion of the NEET PG questions asked just today, right? And this will be a quick recall. We'll be doing a detailed recall, and that will be later. And for medicine, I'll be doing it system wise, just as I have done it for NEET PG 2024, where we'll have a more elaborate discussion of the questions. But for this session, I'm just going to keep it very concise and crisp. I'm going to show you the question and what is the answer. If you have got any queries, please do ask me in the chat box. I'll be happy to answer. Okay, right. Let's go to question number 1. Okay, so question number 1, 32-year-old female presents with weakness in the right arm in the form of difficulty in kneading dough, and on examination there is hypotonia, sluggish deep tendon reflexes in the affected limb. Which of the following structures is most likely involved? Now just tell me, looking at the question, the weakness that you have here, is it an upper motor neuron type of weakness or a lower motor neuron type of weakness? The features like hypotonia, sluggish deep tendon reflexes, they are all suggestive of element pattern or lower motor neuron pattern of weakness. Look at the options: posterior limb of internal capsule, left medullary pyramid, right corticospinal tract in the cervical cord, and anterior horn cells of the cervical cord. Out of the 4 options, you tell me what is the solid evidence of an LMN lesion. You tell me. It is going to be option D, that is anterior horn cell of the cervical spinal cord. When it is involved, it can produce weakness which is of the element type. So for this question, the answer is option D. None of the other options are suggestive of element type of weakness. Coming to the next question. Patient with asthma is currently treated with salbutamol and ipratropium bromide. He now reports frequent nocturnal symptoms. What is the most appropriate next step in the management? A similar question was asked in NEET PG 2024 as well. Pretty straightforward question. The answer is going to be the ICS LABA combination, which we have stressed multiple times in our lectures. Going to question number 3. 35-year-old woman with a history of migraine was initially on over-the-counter non-steroidal anti-inflammatory drugs. Since there was not adequate relief, the patient is currently using sumatriptan for acute attacks. However, the patient is reporting chest tightness after taking the medication. The father has history of coronary artery disease. What is the most appropriate agent for migraine prophylaxis? Now look at this. Patient is already on sumatriptan. We know that sumatriptan is used for acute treatment of migraine and not for prophylaxis. And even while the patient is on sumatriptan, there is some sort of chest tightness. So father is having a history of coronary artery disease. So anyway, triptan is not the right choice here. Okay. Now the question is, what is the most appropriate agent for migraine prophylaxis? What do you think is the answer here? What do you think is the answer for this question? Most appropriate agent for migraine prophylaxis. What do you think? Can, 1 second. Can I just have, yeah, right. 1 second. Okay, what do you think is the answer here? So we know that this ergotamine as well as this naratriptan, these are agents which are used for the acute treatment of migraine, right? Acute treatment of migraine. Now, what do you think for this particular patient for migraine prophylaxis? What would be the ideal choice? Any other additions you want to make for this particular case for migraine or this question? No, right? So the answer for this question will be propranolol, which is used for the migraine prophylaxis. That will be the answer here for this question, right? Coming to the next question. 55-year-old patient presents with shortness of breath, arterial blood gas analysis shown, and you can see pH 7.22 acidosis. So the arrow goes down here for the pH. PaCO2 66, arrow goes up. Okay, sorry, PaCO2 was 66 and this one was PaO2. Okay, this is a typing error. PaO2 was 45 and for bicarbonate 26. Average value 24. You can say it is more or less normal. Maybe the time has not reached there for adequate compensation. But again, this is typically a case of respiratory acidosis. This is typically a case of respiratory acidosis as the arrows are going up, opposite. Okay. The reason why the bicarbonate has not taken up is because probably it has not got enough time for the compensation by the kidney, and that is why this is maybe an acute respiratory acidosis, right? Okay. Now coming to next question. 70-year-old patient with history of hypertension and atrial fibrillation presents with acute onset right-sided weakness and aphasia, which began 2 hours ago. Non-contrast CT shows no evidence of hemorrhage. What is the next step in the management? I've always told you, for an acute stroke, for revascularization, you will definitely go for recombinant tissue plasminogen activator, IV RTPA, especially the patient has presented within the window period. Yes, the patient is having atrial fibrillation. You will have to subsequently give, the anticoagulant, but as for the immediate revascularization is concerned, you will have to go for either a thrombolytic agent or even if it is a large vessel occlusion on angio, you can go for thrombectomy. Among the 4 options, the best one is option A, right? Okay. Coming to the next question. 55-year-old patient presents with episodes of shortness of breath and palpitation. ECG confirms a paroxysmal supraventricular tachycardia. Now, I want your help here. Was the question prophylactic management? Just tell me, what is prophylactic? Was it prophylactic or not? Just tell me in the comment section, was it prophylactic or was it for acute treatment? What was mentioned? Can you tell me? What was mentioned? Can you tell me? If it was prophylactic management, okay, if it was prophylactic management, then the answer for this particular condition will be oral verapamil. Okay, because look, IV adenosine is definitely a drug that is given for treatment of paroxysmal supraventricular tachycardia, but it is not an option for prophylaxis. So the question was for prophylaxis. You can see here, esmolol, again, not an agent for prophylaxis. Phenytoin, not an agent for prophylaxis. Adenosine, again, is for the acute treatment. And yes, a drug like verapamil can be used as prophylactic. So from the comment section, I can see, yes, most of you are saying it was for prophylaxis. So the answer will be option A. Which of the following intravenous fluids, when given in large volume, is most likely to cause hyperchloremic metabolic acidosis? So we know the question was actually suggesting which fluid is likely to cause a hyperchloremic metabolic acidosis. It is normal saline. I think we have discussed this in our discussion on the acid-base balance as well. I've told you this point. So normal saline, the other fluids that are given in the options are not very rich in chloride, and the answer will be option A. Coming to the next question. 45-year-old woman with a history of 6 months, dry mouth, dry eyes, dry cough, laboratory investigation suggestive of ANA positivity, anti-Rho positivity, anti-La positivity. Which of the following is most commonly associated? Some students told me that a positive Sharma test also was given in the question. Please let me know if it was given like that. Whatever it be, the answer for this question will be option B, because in Sjogren's syndrome, you can have a destruction by the lymphocytes infiltrating into the exocrine glands. The answer is option B, right? Now coming to question number 9, teenage girl with non-case of type 1 diabetes mellitus on insulin therapy presents to the outpatient department with severe dehydration after skipping her last insulin dose. Blood sugar level 720 milligram percentage, serum sodium 126, serum potassium 4.3. So essentially this is, a case of probably a diabetic ketoacidosis, and what is not appropriate for her management. Out of the options that have been listed, we know that option B, C, and D are definitely a part of the management of DK that I've taught you, but hypertonic saline is not preferred in the management of diabetic ketoacidosis. Coming to question number 10, a patient with tuberculosis and HIV. Please note that the CD4 count is low, is found to be rifampicin resistant on CBNAT. What is the appropriate management and what is the most likely associated complication? So they've given a list of drugs that have been given in the options, and the side effect also was mentioned. And see, out of the options that have been listed, you can just have a simple look and have a look at which drug is used for the treatment of drug resistant tuberculosis. It is the option A, the BPAL-M regimen. And BPAL-M regimen, yes, the patient can, there is a chance that of development of iris as well. Definitely it is possible. I think we have discussed this in the lecture on the TB treatment as well. Okay, and along with HIV also we have discussed about iris. Now coming to question number 11, a patient diagnosed with hyponatremic encephalopathy initially has a very low serum sodium levels. Again, aggressively treated with hypertonic saline. It looks like a too rapid correction. After sodium correction, neurological status has deteriorated. This is something which I have told you in my videos as well. Rapid correction of hyponatremia can result in osmotic demyelination syndrome, and this is probably a scenario of ODS. And how do you confirm the diagnosis? It is usually by the MRI brain. So in MRI brain, especially in the flare sequences, the T2 flare sequences will show hyperintensities predominantly in the region of pons, because the demyelination happens predominantly in pons. Very rarely you can have some sort of extra pontine demyelination as well. But looking at the other options, CSF analysis, brainstem evoked potential, EEG, no, it's going to be MRI, and that is going to be my answer. Coming to question number 12, benralizumab acts on which receptor? Something which we have discussed in the module on bronchial asthma. It is interleukin 5. Then coming to the next question, patient with type 2 diabetes mellitus, currently on insulin and metformin, has an HbA1c of 8.3. Patient also has features of chronic heart failure. In the question, the ejection fraction was given less than 35%. What is the next best add-on therapy? Again, this is a repeat question. Time and again it has been asked. SGLT2 inhibitor, yes, is empagliflozin. Definitely is the answer, no doubt about it, which we have discussed in the previous recall discussion videos as well. Patient presents with knee joint pain and swelling, synovial fluid aspiration, rhomboid crystals, no doubt about this, it is pseudo gout. I've always told you, in gout it is needle shaped, in case of pseudo gout it is rhomboid shaped crystals. Coming to next question, HIV positive patient with 2-week history of fever, cough and weight loss, diagnosed with tuberculosis. What is the most appropriate approach to the management? Again, a question relating to iris. Question relating to iris. So you will start antiretroviral therapy 2 weeks after initiating the anti-tubercular therapy. Okay. So Abhinav is asking, sir, so the hyponatremia does not need correction. See Abhijit, hyponatremia requires correction. But what did I tell you? Too rapid correction. In a day, 24 hours maximum, you should, correct by 10 milliequivalents only. If too rapid a correction occurs, that is when, you will have osmotic demyelination syndrome. As Dr. Srinath is rightly telling in comment section about the pontine myelinolysis associated with this condition. So that is what I want to tell you. Okay, right. Now, coming to the next question, 55-year-old woman presents with acute respiratory distress and hemoptysis day 7 after knee replacement surgery. Respiratory rate is 28 per minute, pulse is 120. What is the most appropriate investigation? Now, what is the answer for this? Simple, straightforward, CT pulmonary angiography. Did you write D-dimer? No, you cannot write D-dimer. Why? Number one, this is a high probability case for pulmonary embolism. The role of D-dimer is for relatively low probability cases of pulmonary embolism. That is reason number one. Reason number two is that normally post-operatively, even without any sort of pulmonary embolism, you will have some sort of elevation of D-dimer. So it is not that reliable. And yes, for pulmonary embolism, you will go for CT pulmonary angiography. And next question, I think this was repeated recently for the FMG exam as well. A boy with chronic kidney disease, who's a chronic kidney disease patient, he is having anemia, and what is the most appropriate treatment was asked. You will have to supplement with erythropoietin injection. Only if iron reserves are less, you will have to supplement iron reserves, iron supplements as well. But nothing of that sort was mentioned in the question. So the best answer will be a darbepoetin. Okay, right. So coming to the next question, what is preferred in the evaluation of syndromic meningitis? What is preferred in the evaluation of syndromic meningitis? It is multiplex PCR. Again, repeat question. Same question was asked in NEET PG 2024 as well. So one question was DK. Okay, so you are asking in this particular question on diabetic ketoacidosis. Where is that question? Okay, this particular question, 126 sodium. You are asking whether, the saline supplementation is not required. Please understand that, the hyponatremia that occurs here will automatically be corrected once the DK is getting resolved. So there is no need of aggressively correcting the sodium in this particular patient. You will have to prioritize on the insulin as well as fluids, and automatically other laboratory parameters will be under control. Okay, Abhinav? Right. Fine. Let's go to the next question. Based on the imaging, again, this is one question I have put in one of my MCQ discussion video that I have taken for you. Based on the imaging, what is the diagnosis? This is the famous dural tail sign. This is the dural tail sign. This is pretty specific for meningioma. You will have, in the corners, are you seeing a small tail out here? Let me just show it once again. You will see a small tail around here. Yes, this part, that is actually the dural tail sign, and that is seen in meningioma. The answer is option C. Okay, the answer is option C, right? Option C, meningioma is the answer. Okay. Which of the following causes of factor 9 deficiency can be improved after vitamin K injection? Look, hemophilia is again due to hemophilia B is due to factor 9 deficiency, but that cannot be completely reversed with vitamin K injection. But you look at biliary obstruction. What happens in biliary obstruction? You will bile is definitely important for the absorption of fat soluble vitamins. So in biliary obstruction, you will have trouble in the absorption of fat soluble vitamins, and we know that vitamin K is a fat, is actually the factor 9 is a vitamin K dependent clotting factor. So when you supplement vitamin K, obviously you will have increase in the levels of factor 9. Okay, right. Coming to the next question, 24-year-old male abattoir worker complains of fever and headache for 1 week, red eyes and reduced urine output. Some students told me that jaundice also was, icterus also was mentioned in the manifestation as well. Serum bilirubin levels were raised. What is the probable diagnosis? Straightforward question on Weil's disease. Okay. A patient complains of palpitations and dyspnea since 4 hours. He was hemodynamically stable. On doing ECG, it was suggestive of atrial fibrillation. What is the next best step? So if patient is hemodynamically stable, there is no need of an emergent cardioversion. What you should be doing here is to control the ventricular rate. You have to control the fast ventricular rate. That will be my immediate priority. Yes, this patient has to be anticoagulated, but in a patient who presents to me in the emergency department with palpitations, I am first concerned about controlling the ventricular rate, and after that, yes, I'll have to address the issue of the stroke risk of this patient by anticoagulating. Okay, which drug is used in the prophylaxis of meningococcal meningitis? Among the options, the best answer is rifampicin. I suppose ceftriaxone was not in the option. Okay, coming to the next question, again I think a repeat question on Marfan syndrome and the gene that is mutated. It is fibrillin 1. Okay, next question, I think a scenario based question on pheochromocytoma. 45-year-old male with headache, palpitation, sweating. Laboratory test shows elevated vanillin manlic acid or metanephrine levels. I think and metanephrine levels, I suppose some students said that metanephrine was not mentioned. Please let me know in the chat box. What is the drug of choice for preoperative and intraoperative? Again, a question that we have commonly discussed in our lectures, both the main videos and the QRP. It is phenoxybenzamine. Then I think there was a question on the mechanism of action of pegloticase. One of the options where the oxidizes uric acid, that will be the answer. I did not get the other options, but this option seemed fair enough for the answer. And coming to the next question, 15-year-old presented to the OPD with breathing difficulty. I think some features suggestive of acromegaly was given, and how to confirm the diagnosis was the question. So if the question was on the confirmation of diagnosis, I assume that was the question. Please help me and let me know if that was the question. Okay. If please let me know if that was the question. If that was it, non-suppressed GH on administration of glucose. For a normal person, the growth hormone will be suppressed on administration of glucose, but for this particular patient with acromegaly, there will not be suppression. Answer is option D. Coming to question number 28, this is regarding a 45-year-old female with a 6-month history of some dyspnea, palpitation, breathlessness, oxygen saturation normal, then JVP was elevated, then irregular pulse, tender hepatomegaly. So maybe, you know, there is some sort of a right heart failure also. So there is atrial fibrillation. JVP elevation and tender hepatomegaly shows that there is some sort of a right heart failure. A heaving apex was noted and a mid-diastolic murmur was heard over the apex. Patient has a history of acute rheumatic fever. And which of the following statements is false is what was written. So one option was patient has an increased risk of stroke. It is true. So the question was which is false. So that is not going to be the answer. Absent A wave on JPP is also a true statement. Not going to be the answer. Patient has features of right heart failure is also true. Pre-systolic accentuation of mid-diastolic murmur. Now, usually when a patient with mid-diastolic murmur in mitral stenosis has atrial fibrillation, the pre-systolic accentuation is absent. So the answer for this question will be option D. Okay. Coming to the next question, patient has been taking hydrochlorothiazide for 5 years for hypertension. He now presents with heart failure, bilateral pedal edema, and motor and sensory deficits in both limbs. Regular diet consists of rice, jowar, bajra, and there is no history of use of alcohol or diabetes. What is a likely nutrient deficiency? So there is some sort of heart failure is there. So there is some sort of high output heart failure in spite of taking a diuretic. In spite of taking a diuretic, there is some sort of a high output heart failure with some sort of neurological manifestations. So cardiac manifestation, neurological manifestation. In a patient, jawr is definitely having substances that inhibit thiamine. So obviously for this particular question, thiamine is a good choice because it can definitely cause, wet beriberi, about dry beriberi. So you have already learned that thiamine can cause a neuropathy, and that very well can result in motor and sensory deficit. And you can also have a heart failure associated with thiamine. Selenium can cause cardiomyopathy, but again, you cannot explain the neuropathy component. So yes, I think option A will be the best answer. Okay, then another question of a scenario of a patient with COVID-19 with ARDS, most appropriate ventilation strategy. This again we have discussed in the module on ARDS, low tidal volume and high PEEP. And I think one another question, along with this neuropathy, I think there was one question on diabetes mellitus, a scenario of a glove and stocking neuropathy was there, is what I assume. There was a scenario of diabetes mellitus with glove and stocking neuropathy. I did not get the full question stem. So once I go for the detailed discussion video in a couple of days, which will be in a system-wise format, I'll let you know. Please stay tuned to the YouTube channel. I'll be doing a system-wise recall, a bit more elaborate one. So in case you are preparing for the upcoming NEET PG, the next NEET PG or INICT, I think you can watch that particular video. And yeah, so basically I think for the diabetic neuropathy question, there was an option like a symmetrical neuropathy was there in the option. So that will be the answer here. And I suppose there was another question on the sarcoidosis where I think they actually mentioned about the stellate inclusions of sarcoidosis. I think it was a scenario with not an image but a description of stellate inclusions. This is what I assume. Please let me know if I'm right or wrong, if that was the description in the question. And that was another question. Then there was another question on ABG, but I have not discussed in today's session. I'll be doing the next session because I did not get the exact recall, because when I put that particular question in group, I had students saying different opinions about the value. So I thought I'll discuss in the next session on this ABG. And then coming to any other question that I've missed, can you please let me know if there is any other question that I have missed discussing with you. Please let me know if there is any other question that I've missed. I'm just waiting quickly for your comments. So we'll be discussing, as I told you, this was just a rapid fire recall. We'll be discussing in detail in the coming couple of days. Okay. So I think that's it. Okay, that's it. Yeah, Addison's disease reason for hyperpigmentation. So Addison disease, I think ACTH should have been in the options. Okay, ACTH should have been in the options. That should be the, I've talked to you about the melanocortin 1 receptor as well as melanocortin 2 receptor, if you remember. So when there is excessive ACTH, which is stimulating the melanocortin receptors on the skin, that would actually result in hyperpigmentation. Any other question that we have missed? Any other question? I think some of the questions were discussed in the previous recalls by other faculties. So those recalls I have not discussed right now. But when I go with the system-wise recall, I'll be definitely discussing those, questions as well. Okay, right. So let me just quickly once have a look whether I've just missed out on any question. I think that's it. That's it. Yeah. So thank you so much everyone for joining, and I hope all the lectures that were taken, especially the main videos, the live lectures, the QRP videos, the QBank, I hope it was of benefit for you. So stay tuned to this channel for the other videos that are coming up as well. I'll be doing a system-wise recall as well, and wish you good luck for the exam. I mean, not exam results. Okay, so I'm sure that you have put in a lot of effort over the last several months, and finally this is one night where you can go back home and sleep peacefully. So happy for all of you and so proud of all of you for the effort that you have put in for the last several months. Thank you so much everyone for joining, and good luck for the results, and please do let us know once the results are announced. We'll be happy to be a part of your success as well. Thank you so much.